The first topic will be gram-positive cocci. Gram-positive cocci can be classified into two families. Start. Good morning. So now we will discuss about gram-positive cocci, which can be classified into two families, Micrococci family and the other one is Streptococci family. Micrococci family examples include Staphylococcus and Micrococcus. Streptococci family examples include Streptococcus, Enterococcus and Pneumococcus. Fine. So these are the broad two families under gram-positive cocci. Which is the single most important test that can differentiate Micrococci and Streptococci? You have to do a catalase test. This is again a very important MCQ. You do a catalase test and catalase will be positive for Micrococci family, whereas the Streptococci family will be catalase negative. One more difference is the arrangement in the gram stain. Micrococci family will be gram-positive cocci either in cluster, that is staph, or in tetrad, that is Micrococcus. Whereas the Streptococci family will be arranged in gram-positive cocci in chain, or Entero and Pneumo will be arranged in pair. So they are either in chain or in pair. Entero and Pneumo will be pair, whereas Streptococcus will be in chain. Okay, so why it is like that? Why Micrococci is in cluster whereas Streptococci is in chain? This depends upon a very important criteria, that is plane of division. Plane of division. Micrococci family divides in multiple plane. Because they divide in multiple plane, that gives rise to cluster formation, whereas Streptococci family divides in one plane, and because of that it gives rise to pair, which on extension becomes chain. Fine. So these are the two important things. So now I will tell you, if you have gram-positive cocci, in cluster or tetrad, you are not sure what it is, but it is catalase are positive. What it could be? Yeah, it could be either Micrococcus or Staphylococcus. Next question is how to differentiate. How to differentiate is, you have to do a test called as OF test. This is a very important test. Hugh and Lipson OF test. The name of the test is Hugh and Lipson oxidative fermentative test. If it gives a oxidative pattern, it is Micrococcus, whereas if it gives a fermentative pattern, it is Staphylococcus. Apart from that, there are two other tests. You can do a bacit resin sensitivity test and Furajolidin. Furajolidin sensitivity test, and Staphylococcus will be bacitracin resistant, whereas Furajolidin sensitive, whereas Micrococcus will be bacitracin sensitive, Furajolidin resistant. These are not commonly done tests. What is commonly done is OF test. OF test is again a very frequently asked question. Hugel-Lifson oxidative fermentation test. If it gives a fermentative pattern, it is what? It is Staphylococcus. If it gives an oxidative pattern, it is Micrococcus. Fine. My next question is, suppose you know that there is gram-positive cocci in cluster, catalase is positive, OF test shows fermentative pattern. What is this? This gives rise to the answer that it is Staphylococcus. Now, how to differentiate the most pathogenic organism of Staphylococcus, that is Staph aureus, with other species? How to differentiate? Which is the most important? There are so many tests, but which is the most important test? Yes, very good. The most important test is coagulase test. If you do a coagulase test, if it is positive, it is Staph aureus. If it is negative, it is called as CONS. Can you tell what it is? Coagulase negative Staphylococcus. Coagulase negative Staphylococcus. Fine. So this is the introduction, how to differentiate Staphylococcus and Streptococcus. Now we will discuss about Staphylococcus. In Staphylococcus, first we will focus on Staph aureus. Next we will discuss about other Staphylococcus species. Coming to the virulence factor of Staphylococcus aureus, the virulence factor of Staphylococcus aureus can be classified into various categories. Cell wall factor, hemolysis, toxin, and enzymes. Cell wall factor, again, so first we will discuss cell wall factor. So in cell wall factor, Staph aureus, coming to the peptidoglycan, you all know that the peptidoglycan layer of gram positive is thicker or thinner? Thicker. Gram positive peptidoglycan layer is 100 times thicker than gram negatives, and also it confers rigidity and stability to the cell wall. Gram positive cell wall contains one more important element, that is teichoic acid. Teichoic acid is exclusive part of gram positive cell wall. This teichoic acid helps in adhesion, and it also sometimes helps in inhibition of phagocytosis. Other than that, in Staph aureus cell wall contains two important factors. One is protein A, other one is clumping factor. These two are present only in the cell wall of Staph aureus. Protein A is responsible for a reaction called as co-agglutination reaction. Co-agglutination reaction. Whereas clumping factor is responsible for slide coagulase test. As you all know that the coagulase test is of two types, tube coagulase and slide coagulase. Slide coagulase is due to clumping factor, whereas tube coagulase test is due to the coagulase enzyme secreted by Staph aureus. Coming to the coagglutination test, I need to explain a bit. What is coagglutination test? This is Staph aureus. In its cell wall there is a protein is present which is called as protein A. And what is coagglutination test? They say that the protein A of Staph aureus has a property to bind to any IgG antibody. The protein A of Staph aureus has a property to bind to Fc portion of any IgG antibody. So this property can be used to detect antigens in the clinical sample. Like for example, if you want to detect Haemophilus influenza antigen in CSF specimen of patients suffering from meningitis. If you want to detect Haemophilus influenza antigen in the CSF of specimen suffering from meningitis, then what you have to do is you coat Haemophilus influenza IgG antibodies on the surface of Staph aureus, and such preparation can be used to detect antigen in the clinical sample. And such reaction is called as coagglutination reaction, and here Staph aureus act as carrier molecule. Here Staph aureus act as carrier molecule. Okay. Stop. Okay. So now next we will discuss about hemolysis. Hemolysin, Staph aureus can produce four important hemolysin: alpha hemolysin, beta hemolysin, gamma hemolysin and delta hemolysin. So these are the four hemolysins produced by Staph aureus. Alpha hemolysin has a property of became inactivated when you raise the temperature to 70 degree, but again it gets paradoxically activated at 100 degree centigrade. It is inactivated at 70 degree, but again it gets paradoxically activated at 100 degree centigrade, and this is due to denaturation of inactivator. There is a heat labile inactivator in Staph aureus which gets denaturated when you raise the temperature at 100 degree centigrade. Fine. Next is beta hemolysin. Beta hemolysin has a property of showing hot cold phenomena. Hot cold phenomena means the hemolysis starts at 37 degree centigrade. The hemolysis start at 37 degree centigrade, but when you decrease the temperature to the refrigerated temperature, then the hemolysis increases. They say that there is an enhancement of hemolysis when you raise the temperature to 4 degree centigrade. This is called as hot cold phenomena. One more MCQ they ask about beta hemolysin is, it lyses only sheep RBC. It has no action on human RBC. So they usually ask the question as which blood agar is better to demonstrate the hemolysis of Staph aureus, sheep blood agar or human blood agar. Sheep blood agar is better because the sheep blood, the beta hemolysin acts on sheep RBCs. It does not act on human RBC. Hence the hemolysis is better demonstrated on a sheep blood agar plate. Fine. So coming to gamma hemolysis, gamma hemolysin, they say that it is a bicomponent toxin. It is a bicomponent hemolysin. It has got two fragments and both the fragments are important for demonstrating the hemolysis. Delta hemolysin has a detergent like action. D for D, you can remember, it has a detergent like action. Coming to the next toxin, that is pentan-valentine toxin. Pentan-valentine toxin, it is called as PV toxin, or also it is known as leucocidin. This is again a very important virulence factor for Staph aureus. They say that this toxin usually it is expressed by community associated MRSA strains. It is a very important virulence factor usually expressed by community associated MRSA strains, and this also has got two fragments. It is also a bicomponent toxin. It has also got two fragments and both the fragments are important for action. And one more MCQ is, what are the two bicomponent toxins I have told you now? The two bicomponent toxins are gamma hemolysin and PB toxin. Both these toxins are bicomponent toxins, and the components of both the toxins, they work together. The components of both the toxins, they work together to express the function. Hence these bicomponent toxins are called as synergo-hymenotropic toxin. Synergo-hymenotropic toxin. Fine. Both the bicomponent toxins are together called as synergo-hymenotropic toxin. Next we will discuss about the various other toxins of Staph aureus. Of course PV toxin we have discussed. Let us now focus on other important toxins of Staph aureus. These toxins are described as three important toxins: epidermolytic or exfoliative toxin. Other two toxins are enterotoxin and toxic shock syndrome toxin. Enterotoxin and toxic shock syndrome toxin. So let us now focus on epidermolytic toxin or exfoliative toxin. As the name says, it is epidermolytic in nature or exfoliative in nature, and as a result they say that it produces scalded skin syndrome. And the scalded skin syndrome is characterized by a very important sign called as Nikolsky sign. Characterized by separation of outer epidermal layer. The outer epidermal layer will be separated. Outer epidermal layer will be separated. Apart from that, the other important manifestations, like children, this particular toxin can produce Ritter's syndrome, fine, and in adult it can also produce toxic epidermal necrosis. So both these are the severe form of the toxin manifestation, whereas it can also produce milder manifestations like bullous pemphigus, and pemphigus vulgaris. Fine. So these are the various manifestations of epidermolytic toxin. Now we will discuss enterotoxin. Staphylococcus enterotoxin is produced only by 50% of isolates. It will not be there in all the isolates. It will be expressed only by 50% of isolates, and these isolates can cause food poisoning. What is the characteristic feature of staphylococcal food poisoning? What is the characteristic feature? Incubation period is longer or shorter? It has a shorter incubation period of 1 to 6 hours. 1 to 6 hours. Why the incubation period is shorter? Because this toxin is an example of preformed toxin. What do you mean by preformed toxin? It is synthesized in food or it is synthesized in the intestine. Yes, this preformed toxin, it the meaning of this is this type of toxin is usually synthesized in food itself. It will be secreted in food itself. That's why they say that when you take the food containing the toxin, you are directly ingesting the toxin, hence the incubation period is very less, 1 to 6 hours. And the mechanism of action of the toxin will be, it acts on 2V, stands for vagus nerve and vomiting center. Vagus nerve and vomiting center. And this toxin, of course, is an example of heat stable toxin. That means even cooking also, in spite of cooking, the manifestation can still occur. Cooking doesn't destroy the toxin, and the manifestations wise, fever and vomiting. Vomiting will be one of the important manifestation of enterotoxin. Right? Then apart from that, they say that it is of multiple antigenic type. This toxin is of multiple antigenic type. The most common type is type A, responsible for food poisoning. Type A responsible for food poisoning. Fine. So this is about staphylococcal enterotoxins. Now let us focus on toxic shock syndrome toxin. Toxic shock syndrome toxin is nothing but it is enterotoxin type F. This is the most common toxin for toxic shock syndrome. Other than that, enterotoxin B and C also may sometime manifest this syndrome. And this toxin, they say that it's an example of superantigen. Superantigen, of course, all three. They say that both enterotoxin and epidermolytic toxin and toxic shock syndrome toxin, all these three toxins are example of superantigen. And this toxic shock syndrome toxin is particularly associated with males or females? Females, using vaginal tampons. This is the most important risk factor for toxic shock syndrome. This is particularly important for females using vaginal tampons, and they say that this toxin released by the organism and it will be absorbed by the tampons and then it will be released to the circulation. So this is how the pathogenesis occurs. Okay? Staphylococcus aureus releases the toxin in the tampon, then the toxin will be absorbed and it will be released to circulation. As a result, the manifestations will occur, and important manifestations are rashes, yes, DIC, multi-organ failure. All these are important manifestations of toxic shock syndrome, and here the drug of choice is important. The drug of choice of this condition is clindamycin, because it inhibits the toxin synthesis. Okay? Now we will discuss the other important virulence factor, that is various enzymes. Staph aureus can produce various enzymes like Vogel's enzyme, DNase, phosphatase, okay, heat stable thermonuclease. Heat stable thermonuclease. All these are various enzymes produced by Staphylococcus aureus. They also play a very important role in their virulence factor. Okay, so let us now discuss the various manifestations produced by Staph aureus. As you all know, Staphylococcus aureus is the most common agent of various conditions. There are a list of conditions where Staph aureus plays a major role, and it is the most common agent. Examples: most common agent of osteomyelitis, septic arthritis, skin and soft tissue infection, surgical site wound infection, SSI, surgical site wound infection. Apart from that, post-operative parotitis, paronychia, they will produce cavitary lesions in lungs called as nematocele, especially in infants. Okay, tropical pyomyositis, all all these are the conditions where Staphylococcus aureus is the most common agent. Okay, bacteriomycosis. Bacteriomycosis is nothing but is a mycetoma-like condition. Resembles mycetoma. Mycetoma-like conditions caused by Staph aureus. Bacteriomycosis. Fine. Then furunculosis, carbuncle. All these are various cutaneous manifestations. Folliculitis. Hidradenitis. Suppurativa. Okay. So these are the various cutaneous manifestations where Staph aureus is the commonest agent. Okay. So apart from that, it can also plays a very important role in bacterial endocarditis. They say that the most common agent of bacterial endocarditis is nothing but Staphylococcus aureus. Overall, the most common agent is Staph aureus. In this context, I want to tell you the other important MCQs related to the agents of bacterial endocarditis. Coming to the, if you talk about native valve endocarditis, overall, of course, Staph aureus. If it is a hospital-acquired endocarditis, again Staph aureus. Whereas if it is a community-acquired native valve endocarditis, it is Streptococcus viridans. Streptococcus viridans is the most common agent. Similarly, if you speak about prosthetic valve endocarditis, less than 12-month onset. If the bacterial endocarditis occurs within 12 months of prosthetic valve replacement, then the most common agent is Staphylococcus epidermidis. Of course, overall also the most common agent is same, that is Staphylococcus epidermidis. But if the prosthetic valve replacement is done more than 12 months duration, then the agent is Streptococcus viridans. See, various agents can cause, but the most common agent is Streptococcus viridans. Similarly, endocarditis in IV drug abusers. IV drug abusers, if it is right-sided endocarditis, Staph aureus is the commonest agent. Overall also Staph aureus. Left-sided endocarditis, it is Enterococcus. Enterococcus. Fine. So this is all about the various agents of endocarditis. Now we will discuss about the laboratory diagnosis. Laboratory diagnosis of various staphylococcal infections. If you collect, of course, the specimen will be according to the manifestation. Usually pus or the swabs will be collected for cutaneous manifestation. as well as abscesses. If you do a gram stain, you will get plenty of pus cells plus gram positive cocci in cluster. This is the typical gram stain feature of direct smear. Then the next step is you do a culture. As I told you, on blood agar, Staphylococcus produces pinhead shaped colony with a narrow zone of beta hemolysis. Pinhead shaped colony with a narrow zone of beta hemolysis. On nutrient agar, it produces golden yellow hemolytic colony. Golden yellow colonies. Of course, hemolysis will be on blood agar. Nutrient agar only you can appreciate golden yellow colonies. The selective medium of Staph aureus, this they usually ask what are the various selective medium. Salt containing medium like mannitol salt agar. Mannitol salt agar. Then salt milk agar. Apart from that, other medium like Ludlam's medium. Ludlam's medium. All these are various selective medium for Staphylococcus aureus. So these are the various cultural properties. So once the organism grows in culture, how will you confirm that it is Staph aureus, not other organisms? You can confirm by doing various biochemical reactions. First thing is how to differentiate Staph versus Streptococcus. We have already discussed. You do a catalyst test. If it is positive, Staph. If it is negative, Streptococcus. Catalyst positive, it could be anything. It could be either Staphylococcus or Micrococcus. Catalyst, if it is positive, it is either Staphylococcus or Micrococcus. How to differentiate? To do a OF test. If it shows fermentative pattern, it is Staphylococcus. If it shows oxidative pattern, it is Micrococcus. Once it is known that it is Staphylococcus, how will you tell it is Staph aureus or others? Yes, you can differentiate Staph aureus and other Staphylococcus, of course, by doing a coagulase test. Apart from that, there are so many other tests. Please remember, Staph aureus and coagulase negative Staph can be differentiated by the most important test, that is coagulase test. Apart from that, they say that there are 4 important enzymes which are present only in Staph aureus. That is coagulase, DNase, heat stable thermonuclease, heat stable thermonuclease, and phosphatase. These are the enzymes which are present only in Staph aureus. Fine. Apart from that, there are so many other tests that can be used to differentiate, like mannitol fermentation. Staphylococcus will ferment mannitol, whereas coagulase negative Staph does not ferment mannitol. Other differences like Staph aureus can produce golden yellow pigmentation, whereas cons will be white colonies, no pigment. His golden yellow pigments are composed of beta carotene. Beta carotene. Staph aureus will produce beta hemolysis, whereas coagulase negative staph will be non-hemolytic. So these are the other differences. Cell wall factors like protein A and clumping factor. These two are important. Cell wall factors which are present only in Staph aureus. Fine. And Staph aureus can also produce black colony on potassium tellurite agar, whereas cons does not produce. So these are the various differences by which you can differentiate Staph aureus and coagulase negative staphylococcus. Once you know it is Staph aureus, how will you further differentiate within the species? Within the species you can do typing method, and among all the typing method, the most commonly used typing method for Staph aureus, anybody can tell? Phage typing. Phage typing, bacteriophage typing is the most commonly done typing method for Staph aureus. Is the most common typing method for Staph aureus, and the particular method what is used for typing is called as pattern method of phage typing for Staph aureus. In Staph aureus the pattern method is used, and the Maulana Azad Medical College is the reference center for Staph aureus phage typing. And phage type 8081 is the most common strain isolated in epidemics. This is again an MCQ what they ask. Is the most common strain isolated in epidemics. Fine. So apart from that, now we can discuss the various treatment modality of Staph aureus. Treatment modalities of Staph aureus. Feature of direct smear. Then the next step is you do a culture. As I told you, on blood agar, Staphylococcus produces pinhead shaped colony with a narrow zone of beta hemolysis. Pinhead shaped colony with a narrow zone of beta hemolysis. On nutrient agar, it produces golden yellow hemolytic colony. Golden yellow colonies. Of course, hemolysis will be on blood agar. Nutrient agar only you can appreciate golden yellow colonies. The selective medium of Staph aureus, this they usually ask what are the various selective medium. Salt containing medium like mannitol salt agar. Mannitol salt agar. Then salt milk agar. Apart from that, other medium like Ludlam's medium. Ludlam's medium. All these are various selective medium for Staphylococcus aureus. So these are the various cultural properties. So once the organism grows in culture, how will you confirm that it is Staph aureus, not other organisms? You can confirm by doing various biochemical reactions. First thing is how to differentiate Staph versus Streptococcus. We have already discussed. You do a catalyst test. If it is positive, Staph; if it is negative, Streptococcus. Catalyst positive, it could be anything. It could be either Staphylococcus or Micrococcus. Catalyst, if it is positive, it is either Staphylococcus or Micrococcus. How to differentiate? To do a OF test. If it shows fermentative pattern, it is Staphylococcus. If it shows oxidative pattern, it is Micrococcus. Once it is known that it is Staphylococcus, how will you tell it is Staph aureus or others? Yes, you can differentiate Staph aureus and other Staphylococcus, of course, by doing a coagulase test. Apart from that, there are so many other tests. Please remember, Staph aureus and coagulase negative Staph can be differentiated by the most important test, that is coagulase test. Apart from that, they say that there are 4 important enzymes which are present only in Staph aureus. That is coagulase, DNase, heat stable thermonuclease, and phosphatase. These are the enzymes which are present only in Staph aureus. Fine. Apart from that, there are so many other tests that can be used to differentiate, like mannitol fermentation. Staphylococcus will ferment mannitol, whereas coagulase negative Staph does not ferment mannitol. Other differences like Staph aureus can produce golden yellow pigmentation, whereas cons will be white colonies, no pigment. These golden yellow pigments are composed of beta carotene. Staph aureus will produce beta hemolysis, whereas coagulase negative Staph will be non-hemolytic. So these are the other differences. Cell wall factors like protein A and clumping factor. These two are important cell wall factors which are present only in Staph aureus. Fine. And Staph aureus can also produce black colony on potassium tellurite agar, whereas cons does not produce. So these are the various differences by which you can differentiate Staph aureus and coagulase negative Staphylococcus. Once you know it is Staph aureus, how will you further differentiate within the species? Within the species you can do typing method, and among all the typing method, the most commonly used typing method for Staph aureus, anybody can tell? Phage typing. Phage typing, bacteriophage typing is the most commonly done typing method for Staph aureus. Is the most common typing method for Staph aureus, and the particular method what is used for typing is called as pattern method of phage typing for Staph aureus. In Staph aureus the pattern method is used, and the Maulana Azad Medical College is the reference center for Staph aureus Faj typing. And Faj type 8081 is the most common strain isolated in epidemics. This is again an MCQ what they ask. Is the most common strain isolated in epidemics. Fine. So apart from that, now we can discuss the various treatment modality of Staph aureus. Treatment modalities of Staph aureus. Okay, so now we will discuss the treatment modality coming to the strains which are sensitive to penicillin. The drug of choice will be penicillin G. If it is sensitive to methicillin but penicillin resistant, you can give the methicillin group of other antibiotics like cloxacillin or oxacillin, etc. If it is resistant to methicillin, that is MRSA, then the drug of choice will be vancomycin, or you can also give various alternate drug that we will discuss under MRSA little later. And please remember, if you want to give empirical treatment, this is what you have to know, because many times the MRSA status will be known only after 2 to 3 days of culture. So if you want to give some antibiotics empirically without knowing that Staph aureus is MRSA or not, in such case they say that vancomycin is indicated only if the condition is serious or life-threatening condition, or when you are expecting some hospital strains of Staph aureus. In such conditions you can give vancomycin. Whereas if other conditions, other non-serious conditions, there is no need to give vancomycin as empirical treatment. You can give other class of antibiotics like ciprofloxacin or erythromycin. Those class of antibiotics can be given, but vancomycin is given in empirical treatment if the condition is life-threatening or if hospital strains are expected. Fine. So after treatment, next we will discuss the various drug resistance and their mechanisms seen in Staphylococcus aureus. Especially we will discuss about the beta-lactam resistance. Resistant to beta-lactam drugs by Staph aureus is mainly by two mechanisms. One is by producing beta-lactamase enzyme. Other one is by alteration of penicillin binding protein, which is usually shown by MRSA strains. So this beta-lactamase enzyme production is seen in 90% of Staph aureus strains. So almost all the Staph aureus strains can produce beta-lactamase enzymes, and these enzymes are usually plasmid coded, and the plasmids coding for beta-lactamase enzyme can be transferred from one Staph aureus to other Staph aureus by a mechanism called transduction, not conjugation. So please remember, here one MCQ they ask, Usually conjugation is the mechanism by which the plasmid coding for beta-lactamase or any other drug resistance genes are transferred, except in Staph aureus where the beta-lactamase coded plasmids are transferred within the various strains by transduction, not by conjugation. In contrast, the MRSA strains, the mechanism is alteration of penicillin binding protein, and it is usually expressed only by 30% of strains. In contrast to 90% of strain will produce beta-lactamase enzyme, and here it is encoded by mecazin, which is a chromosomal gene, not plasmid mediated. So these are the differences what you need to remember. And of course now we will discuss in detail about MRSA. It is a very important gold mine of MCQ as far as entrance is concerned. What is the definition of MRSA? Yes, somebody who has defined MRSA, he has really given a wrong name. It is methicillin resistant Staph aureus, but is it really resistant only to methicillin, or it is resistant to whole beta-lactam drugs? Yes. So if you understand the mechanism, you can easily answer. MRSA is due to a gene called as mecazin, and this gene is chromosomally located, and this gene, what it does is it alters the penicillin binding protein into penicillin binding protein 2A. You know that the penicillin binding protein is a normal protein of bacterial cell. Staph aureus or any bacterial cell, a penicillin binding protein is a normal protein. It is usually present in cell membrane. And what is the function of this protein is, they say that this protein is an essential protein of the bacterial cell. Why it is essential? Because it acts as transpeptidase. It acts as transpeptidase enzyme, and it helps in the cross linking of peptidoglycan layer. It helps in cross linking of peptidoglycan layer, and as a result it helps in cell wall synthesis. So please remember, penicillin binding protein is an essential protein of Staph aureus or any organism that helps in cell wall synthesis. Why it is called as penicillin binding protein? Because the name of this protein is given as penicillin binding protein. The reason is it is also the binding site of the penicillin group of antibiotic. The beta-lactam group of antibiotic, they usually binds to this protein, and following which they will inhibit this protein. They will bind, followed by they will inhibit this protein. That is how the beta-lactam antibiotics work. What happens in MRSA? In MRSA, penicillin binding protein alters to penicillin binding 2A, and this altered protein has less affinity for penicillin group of antibiotic. It has less affinity to beta-lactam group of antibiotic. As a result, now you can tell me, as a result, if the beta-lactam drugs will not go and bind to this protein, as a result the beta-lactam drugs fail to work. So this MRSA strains, though it is called as methicillin resistant Staph aureus, actually speaking it is resistant to all beta-lactam antibiotic. All beta-lactam antibiotics. Fine, so this is about MRSA. In contrast, there is another term which sometimes we use called as Borsa strains. Borsa strains, it stands for borderline oxacillin resistant Staph aureus. Borderline oxacillin resistant staph aureus, and they say that these are not frank MRSA strains. These are borderline strains which are slightly resistant to oxacillin, and here the mechanism is hyperproduction of beta-lactamase, not penicillin binding protein alteration. Here the mechanism is due to hyperproduction of beta-lactamase. Fine, so this is about the definition of MRSA and BORSA. Now I will tell you how the MRSA strains are important as far as the manifestations are concerned. There are two kinds of MRSA strains: hospital acquired, hospital associated MRSA strain and community associated MRSA strain. Which is more virulent, hospital strains or the community strains? Which is more virulent? Which is more drug resistant? Yes, so now what you have to remember is there is a dictum that always the virulent genes, they are replaced by drug resistant genes, because the organism, the length of the genome is constant. If you want to acquire drug resistant genes, you will not have any place to accommodate the drug resistant genes. So what the strains they do is, usually organism they lose their certain virulent genes to gain the drug resistant genes. So this is the general rule you have to remember. So if you apply this rule here, hospital strains are multi-drug resistant strains. Hospital strains are multi-drug resistant strains, whereas community strains are more virulent strains. If you remember, I have told you earlier, the community strains they express a very important toxin called as Panton-Valentine toxin, and they are associated with various clinical manifestations like necrotizing pneumonia, all these are the manifestations which are confined to Panton-Valentine toxin expressing strains, mostly the community acquired strains. Necrotizing pneumonia, necrotizing fasciitis, Waterhouse-Friderichsen syndrome. Usually it is caused by Neisseria meningitidis. Rarely it can also be caused by community acquired MRSA strains. Waterhouse-Friderichsen syndrome. Fine. Apart from that, fulminant purpura, so all these manifestations are confined to the community acquired strains. Okay. Coming to the MEC-A-gene distribution, they say that MEC-A-gene subtype 1, 2, 3 are usually the hospital strains, whereas subtype 4, 5, 6 are usually the community associated strains. Fine, so this is what you need to remember. Coming to detection of MRSA, MRSA can be detected by using three important discs: methicillin disc, oxacillin disc, cefoxitin disc. Which is best among the three? Cefoxitin disc is the best among the three. Oxacillin disc, if you are using, you have to maintain three conditions, because oxacillin disc, if you are using to detect MRSA, you have to incubate for full 24 hours and you have to add 4% salt to the medium and it will incubate at lower temperature of 30 degree. So these are the three additional conditions to be maintained if you are using oxacillin disc. If you are using cefoxitin disc, then all these conditions are not required. That is why now we consider cefoxitin disc is the recommended disc for detection of MRSA. Other than disc diffusion, so if you are using disc, you are doing the test called as disc diffusion test. So other than the disc diffusion test, there are other methods to detect MRSA like oxacillin screening agar can be used. You can also detect the MIC, that is the minimum inhibitory concentration, and the best method is detection of MEC-A by doing a PCR. This is of course is the best method to detect MRSA. Best method to detect MRSA. Fine. Coming to the treatment of MRSA. MRSA, of course, as I told you earlier, the drug of choice is vancomycin. However, you can also give alternate drug like teicoplanin, daptomycin. Daptomycin is usually given in endocarditis. Mupirocin is given for nasal carriers of MRSA. Nasal carriers of MRSA, mupirocin ointment is given, 2% ointment. Other than that, you can also give quinquestone, linezolid, okay, so all these are various alternate antibiotics that can be given to MRSA, but please remember all these are given if the condition is serious. If you have a non-serious condition, then you can also give other classes of antibiotics. Simpler, orally effective other classes of antibiotic like ciprofloxacin, cotrimoxazole, macrolides, azithromycin. Okay, so all these are the other classes of antibiotics that can be given if you have a non-serious conditions. No need to give vancomycin everywhere. What about beta-lactams? You should give or not? There are various higher generation beta-lactams like the carbapenems, imidopenems, all these can be given. Piperacillin, given or not given? In general, the rule is all beta-lactams are contraindicated. As I told you earlier, the penicillin binding protein, which is the attachment site of beta-lactam drugs, that gets altered, so the beta-lactams cannot bind and they will not be effective. So in general, all the beta-lactam antibiotics to be avoided. However, we have seen that the 5th generation cephalosporin like ceftobiprole, it has got some affinity against MRSA. So you can remember that all beta-lactams need to be avoided, contraindicated, except the 5th generation cephalosporin. It has got some affinity against MRSA. Okay, so this is about MRSA. But the drug of choice is vancomycin, but you should not give vancomycin everywhere. If the condition is non-serious, you can manage with orally effective other classes of antibiotic. Why not to give vancomycin everywhere? If you keep on giving vancomycin, what will happen? Yes, there is a resistance to vancomycin that can develop, and the vancomycin resistance is described as VRSA and VISA. What is this? VRSA is vancomycin resistant staph aureus. One more term is there called as VISA, that stands for vancomycin intermediate staph aureus. The difference is vancomycin resistant staph aureus, the MIC is higher, more than a 32 microgram per ml, whereas vancomycin intermediate staph aureus, the MIC is 8 to 16. There is a third term is there which is called as heterovisa, H visa. H visa means these are the visa strains only, but you will have a mixed population. You will have a mixed population. The mixed population consists of either visa strains or sensitive strain. This is called as H visa. Mixed population will be there. Some strains are visa strains, some strains are sensitive strains. So these are the three variety of vancomycin resistance which is described. And coming to the mechanism, they say that VRSA is due to a gene called as VAN gene. VRSA is due to a gene called as VAN gene, and it is expected that this VAN gene is acquired. It is acquired from Enterococcus. Whereas visa or H visa, the mechanism is increased cell wall thickening. Increase cell wall thickening. Fine. So, which is more common, VRSA or visa? VRSA is extremely uncommon, whereas compared to VRSA, visa is slightly common. It has been reported from various places like Hyderabad, Mumbai, Lucknow, like that. Even various other places visa has been reported from India, whereas VRSA is extremely uncommon, but erroneous use of vancomycin, irrational use of vancomycin, there is every chance that in near future you will have more cases of VRSA and visa. And the treatment of visa, you can give all antibiotics indicated for MRSA except glycopeptides like vancomycin and teicoplanin. Vancomycin and teicoplanin are not given. Other MRSA antibiotics which are given for MRSA can be given. So this is all about visa. Now a bit about carriers of staph aureus. As I earlier told you, 25 to 50% of normal individuals are healthy carriers of staph aureus. Most of the hospital staffs, healthcare workers, they will be carriers. 25 to 50% of normal individuals are healthy carriers of staph aureus. The most common site being nose and skin. Of course, the treatment I told you have to give mupirocin ointment. 2% ointment is given. Diagnosis, you can use mannitol, salt agar added with, if you want to detect MRSA, then you can add oxacillin. Otherwise, mannitol salt agar is enough. Okay? And can you tell me which is the most common source, whether it is healthcare worker or it is patient? Which is the most common source of staph aureus? Yes, healthcare workers, 25 to 50% will be carriers. Then which is the most common method to prevent the MRSA spread? Most common method to prevent the spread of MRSA? Yes, by simple hand washing, not by giving antibiotic. Hand washing is the most effective method for prevention of spread of staph aureus in the hospital. Okay, so it's a very important thing what you have to know. Then about coagulase negative staph. Coagulase negative staph, the most common coagulase negative staph is staph epidermidis. Staph epidermidis is the most common coagulase negative staph. Maybe around 70% of total coagulase negative staph is staph epidermidis. It is a normal flora. However, though it is a normal skin commensal, in certain condition it acts as a pathogen, especially by its property of producing biofilm on plastic surfaces. It has a property to produce biofilm when any artificial plastic surface will be there in the body, and that is the reason why it is the most common organism to cause, yes, prosthetic valve endocarditis. Prosthetic valve bacterial endocarditis. It can also cause ventricular shunt infection, and stitch abscesses. Stitch abscesses. Fine. So this is all about Staphylococcus epidermidis. One more important coagulase negative staph, which is important for exam point of view, Staphylococcus saprophyticus. Saprophyticus, it can cause UTI in sexually active female. And of course, it is identified by its property of resistant to novobiocin. It is identified by its property of being resistant to novobiocin. As I earlier told you, 25 to 50% of normal individuals are healthy carriers of staph aureus. Most of the hospital staffs, healthcare workers, they will be carriers. 25 to 50% of normal individuals are healthy carriers of staph aureus. The most common site being nose and skin. Of course, the treatment I told you, you have to give mupirocin ointment. 2% ointment is given. Diagnosis, you can use mannitol, salt agar added with, if you want to detect MRSA, then you can add oxacillin also. otherwise mannitol salt agar is enough. Okay, and can you tell me which is the most common source, whether it is healthcare worker or it is patient, which is the most common source of staph aureus? Yes, healthcare workers 25 to 50% will be carriers. Then which is the most common method to prevent the MRSA spread? Most common method to prevent the spread of MRSA? Yes, by simple hand washing, not by giving antibiotic. Hand washing is the most effective method for prevention of spread of staph aureus in the hospital. Okay, so it's a very important thing what you have to know. Then about coagulase negative staph. Coagulase negative staph, the most common coagulase negative staph is staph epidermidis. Staph epidermidis is the most common coagulase negative staph, maybe around 70% of total coagulase negative staph is staph epidermidis. It is a normal flora. However, though it is a normal skin commensal, in certain condition it acts as a pathogen, especially by its property of producing biofilm on plastic surfaces. It has a property to produce biofilm when any artificial plastic surface will be there in the body, and that is the reason why it is the most common organism to cause, yes, prosthetic valve endocarditis. Prosthetic valve bacterial endocarditis. It can also cause ventricular shunt infection, and stitch abscesses. Stitch abscesses. Fine. So this is all about Staphylococcus epidermidis. One more important coagulase negative staph, which is important for exam point of view, Staphylococcus saprophyticus. Saprophyticus, it can cause UTI in sexually active female. And of course, it is identified by its property of resistant to novobiocin. It is identified by its property of being resistant to novobiocin. Okay, so the next topic is Streptococcaceae family. Streptococcaceae family, there are three important group of organisms: Streptococci, Enterococcus and Pneumococcus. Can you tell me which is the test to differentiate these three group of organisms? Of course, as I told you in the previous session, if you do a catalase test, that will differentiate Streptococcus and Staphylococcus. All Streptococci will be catalase negative. All Streptococci will be catalase negative. Among the Streptococci, Streptococcus, Enterococcus and Pneumococcus, they can be differentiated by their hemolysis on blood agar. On blood agar, there are three kind of hemolysis can be produced: alpha hemolysis, beta hemolysis and gamma hemolysis. Alpha hemolysis or green discoloration. This is pneumococcus or Streptococcus viridis. They produce alpha hemolysis or green discoloration on blood agar. Beta hemolysis or yellowish discoloration. Alpha is partial hemolysis, whereas beta is complete yellowish hemolysis or complete hemolysis. Here the examples are various beta hemolytic streptococci. Various beta hemolytic streptococci. Gamma hemolysis, gamma means non-hemolysis, there is no hemolysis, and here the examples are Enterococcus. Enterococcus is an example of gamma hemolytic organism. So if you have beta hemolytic streptococci, that can be further be differentiated based on Lancefield grouping, and this Lancefield grouping is based on a streptococcal antigen called as carbohydrate antigen. Based upon the carbohydrate antigen, the beta hemolytic streptococci can be divided into 20 groups from group A to group V except I and J. There is no I and J group, other than that from group A to group V. Okay. So group A streptococcus, that is Streptococcus pyogenes, can be further divided based on M protein into approximately 100 various M types, and this is called as Griffith typing. This is called as Griffith typing. Okay, so beta hemolytic streptococcus can be grouped into 20 serogroups based on carbohydrate antigen, which is called as Lancefield grouping, and group A streptococcus, that is Streptococcus pyogenes, can be further divided into various M types based on M protein. Or the group A streptococcus can also be classified based on the EMM gene. EMM is a gene coding for, it is a gene which codes for M protein. EMM gene is nothing but is a gene which codes for M protein, and you have around 124 EMM genotypes. EMM genotypes. Okay. So group A streptococcus can be classified by serotyping based on M protein into more than 100 M types, or can be classified by the gene coding for M protein, that is EMM gene, and this classification can lead to more than 124 EMM genotypes of group A streptococcus. So this is how it is classified. Now we will discuss group A streptococcus, that is Streptococcus pyogenes. First we will discuss about the virulence factor. Virulence factor of group A streptococcus. Group A streptococcus virulence factor can be classified to against cell wall factor, toxin, hemolysin and enzyme. Coming to cell wall factor, again it has a thick peptidoglycan layer like Staphylococcus. It also has teichoic acid like Staphylococcus. In addition, streptozin has additional virulence factor like M protein. M protein is the principal virulence factor of Streptococcus pyogenes. It is the most important virulence factor. It is responsible for adhesion and inhibition of phagocytosis. Adhesion and inhibition of phagocytosis. And they say that there are various important manifestations which are related to M protein, because it is the most important protein. They say that M protein is also important for the pathogenesis of rheumatic fever, acute rheumatic fever. Okay. So other than M protein, one more cell wall associated element is capsule. They say that only few mucoid strains of Streptococcus are capsulated, and the capsule is composed of hyaluronic acid. Capsule is composed of hyaluronic acid. Other than that, carbohydrate antigen, streptococcal carbohydrate antigen, one more virulence factor. So all these are cell wall associated virulence factor. Now we will discuss about hemolysin. Streptococcus produces two important hemolysins, streptolysin O and streptolysin S. O for oxygen level as well as it is heat level, whereas S is serum stable, oxygen stable, as well as it is responsible for surface hemolysis, because it is oxygen stable. On the, if you do aerobic incubation on the surface of the blood agar plate, the hemolysis is due to streptolysin S. Streptolysin O is oxygen labile, so it cannot produce hemolysis on the surface of the plate because it will be destroyed by aeration. It can produce hemolysis only inside. The deep hemolysis is due to streptolysin O. Inside the agar, if the hemolysis is there, that may be due to O, but the surface hemolysis is always due to S. Apart, and this streptolysin O hemolysis also can be manifested if you incubate in anaerobic condition. If you produce anaerobic condition, then streptolysin O hemolysis can be demonstrated. Otherwise, streptolysin O hemolysis cannot be demonstrated on the surface of the agar plate. Other than that, the difference is, they say that streptolysin S is not antigenic. In contrast, streptolysin O is strongly antigenic, and anti-streptolysin O antibody, they are raised in most of the streptococcal infection. They say that it is used as a marker of post-streptococcal infection. Except it is a marker of post-streptococcal all kind of infections, except there are two conditions like skin infection like pyoderma and post-streptococcal glomerulonephritis. These are the two conditions where ASLO is not raised, it will be low. It is not used as a diagnostic marker. Other than that, most of the streptococcal infection, ASLO is the post streptococcal diagnostic marker. In these two conditions, instead of anti-streptomycin O antibody, they say that anti-DNase B antibody is used as a diagnostic marker. Anti-DNase B antibody is used as a diagnostic marker. Fine. So these are the differences between streptomycin S and streptomycin O. Now we will discuss about the toxin. Streptococcus can produce an important toxin called as SPE. Stands for Streptococcus is pyrogenic exotoxin. Streptococcus pyrogenic exotoxin. And this toxin is responsible for pathogenesis of scarlet fever, necrotizing fasciitis, and streptococcal toxic shock syndrome. Okay, so all these are the various conditions which are produced due to Streptococcus pyrogenic exotoxin. And this particular toxin is of three subtypes, A, B and C. A and C are bacteriophage coded, whereas B alone is chromosomally coded. In this context, I just want to tell you the various important toxins which are coded by bacteriophage. Phage coded toxin is again a very important MCQ for you. So the various toxins which are coded by bacteriophage are diphtheria toxin, cholera toxin. I can tell you in a other way which is easy to remember. You can remember like this: A, B, C, D, E. Yes. Diphtheria toxin, cholera toxin, botulinum toxin, C and D. Yes. Then Streptococcus pyrogenic exotoxin A and C, and this is the enterohemorrhagic E. coli producing virocytotoxin. Enterohemorrhagic E. coli producing VT. VT stands for virocytotoxin. So all these are the toxins which are coded by bacteriophage. Now we can discuss about the various enzymes produced by Streptococcus. Streptococcus can produce various enzymes like streptokinase, streptodornase, and hyaluronidase. Like that, various enzymes it is capable of producing. Streptokinase enzyme is fibrinolytic in nature. It is fibrinolytic in nature. It is used to lyse the clots, hence it is used for the treatment of coronary artery thrombosis. It is a life-saving toxin. It is a life-saving toxin. Similarly, streptodornase, also called as DNase, is a fourth type, A, B, C and D, and the streptodornase is used in empyema cases to liquefy the thick pus. It is used to liquefy the thick pus. And in this particular condition, they say that in empyema cases, they say that a combination of streptokinase and dornase is used. Both streptokinase and streptodornase is used for the treatment of empyema cases. For the treatment of empyema cases. Hyaluronidase is another enzyme which is produced only by few strains such as type 4 and 22. Only few strains can produce enzymes like hyaluronidase. So these are the various enzymes and their mechanisms in pathogenesis of Streptococcus. Fine. So coming to the pathogenesis or manifestations, we can discuss both together. Streptococcal, of course, as you know, we are discussing group A Streptococcus. So group A Streptococcus manifestations can be classified into two categories: suppurative infection and non-suppurative infection. Suppurative infection or pyogenic infection. What are the various pyogenic infections produced by Streptococcus? Can be classified as a respiratory infection like pharyngitis. Pharyngitis or sore throat. You can write down here Streptococcus is the most common agent. I can highlight where and all Streptococcus is most common. Pharyngitis, Streptococcus, group A Streptococcus is the most common agent of pharyngitis. Apart from that, it can produce various skin and soft tissue infection. Like it can cause pyoderma, a form of pyoderma which is called as impetigo. Impetigo is a form of pyoderma characterized by honey crust, honey color crusts, honeycomb crust. It is described as, the lesions are described as honeycomb crust. Okay, impetigo, it is a cutaneous manifestation. Apart from that, cellulitis. Again, cellulitis, Streptococcus is most common. A form of cellulitis which is described as erysipelas. Erysipelas is a form of cellulitis characterized by pudgy orange skin. Pudgy orange skin. Usually it is present in the malar area of face. Okay, erysipelas. Puerperal sepsis. Puerperal sepsis, of course, group A Streptococcus can cause, but if they ask the most common agent, it is not group A, it is group B Streptococcus is the most common agent. Puerperal sepsis. Other than that, toxin mediated manifestations like scarlet fever, necrotizing fasciitis, and streptococcal toxic shock syndrome. Scarlet fever is now, it is of course very rare. Almost now we don't have this particular manifestation. It is very rare now. Fine. However, this particular manifestation of scarlet fever is described as rashes which are having sandpaper feeling. Sandpaper rashes and strawberry tongue. One more manifestation is strawberry appearance of tongue. Rashes over the skin fold which are described as pistia lines. These are nothing but rashes over the skin fold. Rashes over the skin fold, pistia lines. Necrotizing fasciitis, of course, don't forget, Streptococcus group A Streptococcus is the most common agent of necrotizing fasciitis. Like a toxic shock syndrome, of course, Staph aureus is most common. Very rarely it is caused by Streptococcus. Streptococcus toxic shock syndrome is rare, but the differentiating feature is here it is bacteremic. Blood culture will be positive. In contrast to staphylococcal toxic shock syndrome, the streptococcal toxic shock syndrome is rare, but it is bacteremic. The blood culture will be positive. Okay, so these are the various pyogenic or suppurative manifestations. Now we can discuss about non-suppurative manifestation. Non-suppurative manifestation of Streptococcus pyogenes is mainly due to antigenic cross reactivity. Autoimmune reaction, they say that antigenic cross reactivity or the autoimmune hypothesis is the reason behind the non-suppurative manifestations. They say that various streptococcal antigen they cross react with human antigen, mammalian antigen, and this is the reason behind various non-suppurative manifestations. So, for example, the M protein cross reacts with myocardium. Carbohydrate antigen of Streptococcus cross reacts with cardiac valve. And so, if you have a prior streptococcal infection, maybe in the form of pharyngitis, then the streptococcal antigens like M protein and the carbohydrate antigen against which you develop antibodies, and those antibodies on a later stage can cross react with your own antigens, and the antigen antibody mediated autoimmune mechanisms can lead to a very important manifestation, that is acute rheumatic fever. Other than that, the streptococcal cell membrane antigen can cross react with glomerular endothelial antigen, and this is the mechanism behind post streptococcal glomerular nephritis. So these are the two important non-suppurative complications of Streptococcus pyogenes, that is ARF and post streptococcal glomerular nephritis. These two are the most important non-suppurative complications. Other than that, there are other rare examples of non-suppurative complications like gutted psoriasis, reactive arthritis, pandas. It is an autoimmune disorder seen mainly in children. So all these are various non-suppurative complications. We can discuss the differences between ARF and PSGN. ARF, the prior exposure is in the form of pharyngitis usually, whereas PSGN is usually it follows pyoderma, skin manifestation in the form of pyoderma. ARF, any strain can cause ARF, whereas there are some limited nephrogenic strains which can cause PSEN. ARF is an example of hypersensitivity type 2, whereas AGN is antigen antibody complex mediated, that is hypersensitivity type 3 kind of reaction, PSEN. Complement will be utilized in PSEN, so the complement level will be low in PSEN, whereas in ARF the complement level remains normal. So these are the differences. Other than that, ARF, there are three important features. ARF will have genetic predisposition, whereas PSEN will not be there. This kind of genetic predisposition will not be there. There is a genetic susceptibility. Only few genetically predisposed individuals only can get ARF. Penicillin prophylaxis is indicated in ARF. Yes, relapse is again common in ARF, whereas relapse is almost not there in AGN, and there is no need of penicillin prophylaxis in AGN. Fine. And of course PSEN, the prognosis is good. Prognosis is always better in PSEN. ARF, the prognosis is variable. Fine. So these are the things. Now we can discuss about laboratory diagnosis of group A Streptococcus. If you do a direct smear examination, gram stain, you will get gram positive cocci in short chain and pus cells with gram positive cocci in short chain. Regarding the culture media, the transport media is Pike's media. And of course it can grow in blood agar, but if you want to selectively grow only Streptococcus pyogenes, you can use a selective medium by adding crystal violet. It is called as crystal violet blood agar, which is a selective medium for Streptococcus pyogenes. And in blood agar, the description is pinpoint colony. Staphylococcus, what I have told earlier, pin head colony with narrow hemolysis. Here the description is pinpoint colony with wide zone of hemolysis. Okay, so you can remember like this: Staphylococcus, the colonies are bigger, whereas hemolysis is narrow. Streptococcus, the colony is pinpoint, whereas hemolysis is wide zone of hemolysis. Fine. So this is all about the culture medium. Then once it grows in culture, how to tell that it is Streptococcus pyogenes, it is not other Streptococcus. So how Streptococcus pyogenes can be differentiated from other Streptococcus? Based on which antigen? Yes, as I have told you earlier, if you do a Lancefield grouping, then you can, based on the carbohydrate antigen, if you do a Lancefield grouping, it can differentiate the beta hemolytic Streptococci. If it is group A, it indicates Streptococcus pyogenes. If the Lancefield grouping says it group B, then it is nothing but Streptococcus agalactiae. Like that, other groups also you can detect. Here I want to emphasize that group A Streptococcus and group B Streptococcus, apart from Lancefield grouping, of course Lancefield grouping is the best method to differentiate, but apart from Lancefield grouping there are other methods to differentiate. Group A Streptococcus, you can go for a bacitracin sensitivity. Group A Streptococcus is sensitive to bacitracin. PYR test will be positive for group A Streptococcus. CAMP test and hippurate hydrolysis. CAMP test and hippurate hydrolysis tests, both these tests are negative for group A, whereas both these tests are positive for group B. So all these are other methods to differentiate, but the best is always Lancefield grouping because it is a serological differentiation. Fine. So coming to treatment, usually penicillin is the drug of choice for most of the group A streptococcal infection, and the resistance to penicillin is not reported yet. As I am telling for group A streptococcus. Group A streptococcus is always, till now it is sensitive to penicillin. The resistance has not been reported. So penicillin has been the treatment of choice. However, for conditions, serious conditions like necrotizing fasciitis, first is debridement, wound debridement, followed by you can give penicillin. And for carrier, you have to add rifampicin. You have to add rifampicin. Okay, so these are the various treatment modalities for group A streptococcus. Coming to group B streptococcus or Streptococcus agalactiae, as I told you, this is usually a normal flora of female genital tract. And it can cause puerperal sepsis. Apart from that, it can cause neonatal meningitis. Yes, neonatal meningitis, can you tell me the three important causes? The three important causes of neonatal meningitis are E. coli, group B streptococcus and Listeria monocytogenes. Okay, and according to most of the literature, group B streptococcus is the most common agent. Okay, E. coli, group B streptococcus and Listeria monocytogenes. There is a controversy which is more common, E. coli or group B streptococcus, but most of the references tell that group B streptococcus is the commonest agent. Okay, so this is about neonatal meningitis, but if I ask you 2 to 12 years, if you talk about meningitis, the most common agent is meningococcus. More than 20 years or even overall, if they ask, overall the most common agent of meningitis, anybody can tell? Yes, pneumococcus. Overall the most common agent is pneumococcus is the most common agent of meningitis overall. Okay, so this is about group B streptococcus. Now we will discuss about enterococcus. Enterococcus, again it is a normal flora of intestine, hence it is called as enterococcus. Usually it produces gamma hemolysis, most common. However, rarely it can produce beta or alpha hemolysis, but it is very rare, but it can produce. So at times it is important to differentiate Enterococcus from other organisms. They say that Enterococcus shows various important properties, like it is one of the resistant organism, so it can grow in extreme of conditions. Extreme of conditions, it can grow like 40-degree temperature, 40% bile, raised pH and raised salt concentration. So all these extreme of conditions Enterococcus can grow. Apart from that, it can produce a positive bile esculin hydrolysis test. Bile esculin hydrolysis test will be positive. So these are the various properties of Enterococcus by which you can differentiate from other species. There are two important pathogens, Enterococcus faecalis, Enterococcus faecium. There are other species which are not very important as human isolates. Enterococcus faecalis is the most common isolate in humans, whereas Enterococcus faecium is rare. However, it is more resistant than faecalis. Okay, Arabinose test is done to differentiate. Arabinose fermentation is done to differentiate faecalis and faecium. Faecium will ferment Arabinose, whereas faecalis is Arabinose non-fermenter. Okay, so that is how you can differentiate faecium and faecalis. As far as the treatment is concerned, I mean, a clinical feature you can remember Enterococcus. Again, it is a very common organism in the hospital setting. It can cause various infections. It can cause UTI, it can cause meningitis, endocarditis, especially right-sided endocarditis in IV drug abuses. And Enterococcus is a normal flora of your intestine. So any GI surgery can lead to spillage of Enterococcus to cause intra-abdominal infection. Intra-abdominal infection. So GI surgery or any other reason, if there is a spillage of organism from GI to the abdominal cavity, can lead to intra-abdominal infection. So there are various infections can be produced by Enterococcus. Treatment, again treatment of Enterococcus is a bit worrisome because it is one of the most important resistant organism in hospital. Because it is resistant, I mean the drug of choice, they say that it is resistant to low level aminoglycoside. How it is also resistant to penicillin, but they say that penicillin plus aminoglycoside you can give together because they act synergistically. Because of the synergistic action, penicillin and aminoglycoside can be given together. It is also resistant to cotremoxazole. Various antibiotics it will be resistant. Serious conditions, vancomycin is given. Vancomycin is usually given as a drug of choice in serious enterococcal infections, but again a point to be noted, vancomycin resistance in Enterococcus is very common. It is called as VRE. What is VRE? Vancomycin resistant Enterococcus, and VRE is due to a gene called as VAN gene. VAN gene has got various subtypes from VAN A to VAN E, and nowadays even the other subtypes like FG also has been discovered. And VRE, if they ask the mechanism, it is like, I mean it is overlapping like that of MRSA. MRSA, what is the mechanism? MRSA is due to which gene? Macazin. Macazin does what? Alters the target site of penicillin. The target site of penicillin is PVP, which gets altered to PVP2A. Similarly, VRE is due to VAN gene, and VAN gene alters the vancomycin target site. Vancomycin is also a cell wall acting drug, right? Vancomycin acts on which site of cell wall? It acts on a peptidoglycan side chain composed of D-alanine. This D-alanine peptidoglycan side chain, it gets altered to D-alanine D-lactate or D-alanine D-serine. One alanine is replaced by either lactate or serine, and this altered protein has got less affinity for vancomycin. This is the mechanism. This altered side chain has less affinity for vancomycin. That is how VRE occurs, and VRE is much more common than VRSA. Okay, VRE is much more common than VRSA. Next, we can discuss about Streptococcus pneumoniae. Okay, when we talk about Streptococcus pneumoniae, we have to know how it is differentiated from another alpha hemolytic throat commensal, that is Streptococcus viridans. So pneumonia or Streptococcus pneumonia or pneumococcus, you have to know how it is differentiated from Streptococcus viridans, because both are alpha hemolytic. The commonality is both are alpha hemolytic and both can be found in sputum sample. Both can be found in sputum sample, but one is a normal flora whereas other one is a pathogen. So how to differentiate? This differentiation is very crucial to initiate the treatment. Yes, you can differentiate based upon gram stain. First you can do a gram stain. If you do a gram stain, Streptococcus pneumoniae or pneumococcus will be gram positive cocci in pair. Okay, very peculiar description which is called as lanceolate or flame shaped diplococci, whereas this is in long chain. This is in long chain, and usually pneumococcus surrounded by a capsule. Surrounded by a capsule, it is capsulated. Capsule can be detected by a very important test called as Quilling test. Quilling test is done to detect the pneumococcal capsule, whereas there is no capsule in viridans. On blood agar, pneumococcus can produce caram coin colony. Caram coin or Draughtsman shaped colony. Caram coin or Draughtsman shaped colony. This is because of the production of an enzyme called as autolysin. They say that pneumococcus can produce an enzyme called as autolysin, and the autolysin enzyme is responsible for Draughtsman shape because it will eat up its own colony. So the colony will be destroyed by producing the enzyme called as autolysin. Only the alpha hemolysis will be there surrounding, which is described as Draughtsman or caram coin colony. Other than that, you can do various biochemical reaction like bile, inulin and optogen. Pneumococcus will be bile soluble, inulin will be fermented, optogen will be sensitive, whereas viridans will be bile insoluble, inulin not fermented, optogen will be resistant. Of course, the best is mice pathogenicity. This is the best method to differentiate, and of pneumococcus will be pathogenic, whereas viridans will be non-pathogenic to mice. So the best method to differentiate is mice pathogenicity test. If it is not there, then the next best method is bile solubility. The next best, usually you will have options between bile and inulin, optogen, all three will be there. In that, the best method to differentiate is bile solubility. Coming to the pathogenesis of pneumococcus, virulence factor of pneumococcus. Of course, pneumolysine, autolysin, all these are the various virulence factors of pneumococcus. Carbohydrate antigen and capsule. Which is the most important virulence factor? Capsule. The capsule is the principal virulence factor. And based upon the capsule, you can type pneumococcus to more than 90 serotypes. More than 90 serotypes. Carbohydrate antigen of pneumococcus based on the CRP is named. What is CRP? C-reactive protein. So C-reactive protein is a protein produced by our liver against acute inflammation, and it is named CRP because it is okay. Next is various manifestation of pneumococcus. Pneumococcus is the most common agent of various important manifestations like lobar pneumonia. It is the commonest agent of lobar pneumonia, typical lobar pneumonia, alveolar pneumonia, commonest agent of pyogenic meningitis, of course except the neonatal group where group B streptococcus is most common. It can also cause, it is also the commonest agent of otitis media, sinusitis, etc. Okay. Rarely it can cause other invasive infections like osteomyelitis, endocarditis. All these are rare manifestations. Even sometimes it can cause hemolytic uremic syndrome, as well as it can cause bacterial, spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. All these are rare manifestations, but the commonest, I mean, it is the most common agent of this lobar pneumonia, pyogenic meningitis, otitis media, sinusitis. Fine. So, coming to the lab diagnosis is nothing but the differences between pneumococcus and streptococcus viridans. We have already discussed. Treatment, penicillin is the drug of choice. Amoxicillin is also given. Okay, especially otitis media and other non-invasive conditions. Vaccine is something which they frequently ask. Pneumococcal vaccine. So regarding pneumococcal vaccine, there are two types of pneumococcal vaccine. 23 valent vaccine. 23 valent capsular vaccine and 7-valent conjugate vaccine. The 23-valent capsular vaccine, it includes 23 serotypes of pneumococcus. So this kind of capsular vaccine is used most commonly. It can cover 90% of strains, 90% of common strains of pneumococcus which can infect human being. But the problem of capsular vaccine is, capsular antigen is an example of T independent antigen. It's an example of T independent antigen, and you all know that T independent antigens are less immunogenic to man, less immunogenic, especially to children below 2 to 3 years. The T independent antigen are less immunogenic to children below 3 years, hence capsular antigens are contraindicated in less than 3 years, as well as it is contraindicated in pregnancy. These are the two contraindications for 23-valent vaccine. So in these two situations, 7-valent conjugate vaccine, because you all know that if an antigen is less immunogenic, to increase the immunogenicity of an antigen, to add an adjuvant. If you add an adjuvant, such conjugate vaccines are more immunogenic to children. They are more immunogenic to children. Hence, this is the vaccination of choice in children. But the drawback of 7-valent conjugate vaccine is, because it contains only 7 serotype, hence it can cover only 60% of total infections. It can protect us only against 60% of pneumococcal infections. Hence, in general, the polyvalent vaccine is given. Only for the children, the 7-valent vaccine is given. Where exactly the pneumococcal vaccine is indicated? Indications of pneumococcal vaccine. Yes, which organ if it is defective? Very good. Spleen is the site of destruction of capsulated organisms. The capsulated organisms are destroyed in spleen. Hence, whenever the spleen is absent or maybe spleen is defective, there are various conditions like sickle cell disease, thalassemia. All these are the conditions where the spleen will be defective, overreactive, chronic heart, lung, liver, renal disease patient. Liver and renal disease patients. So all these are the indications of pneumococcal vaccines. So these are the conditions where, and also immunosuppression, prolonged immunosuppression, including HIV individuals, corticosteroid therapy. All these are the conditions where pneumococcal vaccines are given. Okay, next we will discuss Neisseria. Neisseria are example of gram-negative cocci. Neisseria are example of gram-negative cocci, which also includes Veillonella. Veillonella is also an example of gram-negative cocci. Veillonella is anaerobic cocci. Okay. So coming to Neisseria, it has got two important pathogens. You all know the two important pathogens are Neisseria meningitidis, that is meningococcus. Other one is gonococcus. What are the salient differences between meningococcus and gonococcus? Which is capsulated? Meningococcus is capsulated. What is the shape of these two coccus? Both are gram-negative cocci in pair. Both are gram-negative cocci in pair. But meningococcus is lens-shaped. It is lens-shaped. lens shaped diplococci. Lens shaped or moon shaped, half moon shaped. Whereas gonococcus is kidney shaped. It is kidney shaped diplococci. Regarding the fermentation is concerned, M for M. Very important, M for M, that is M for moon shaped as well as M for maltose fermentation. Maltose will be fermented by meningococcus, not fermented by gonococcus. Okay? In general, meningococcus is less drug resistant compared to gonococcus. Gonococcus, the resistance is more. It is more resistant to various antibiotics. Fine. So these are the salient differences between meningococcus and gonococcus. Let us discuss in detail about meningococcus. Meningococcus, based upon the capsule, meningococcus is divided into 13 serogroups. 13 serogroups. Among these, the important ones of course are A, B, C, Y and W135. These are the important groups to cause human infections. And the serogroups are further subjected to serotyping based on outer membrane protein antigen. Based on outer membrane protein antigen, the serogroups are further subjected to serotypes. Okay? So, if you talk about the virulence factor of meningococcus, of course, capsule is the most important virulence factor. Apart from capsule, other virulence factor like bacterial endotoxin is a gram-negative organism, right? So, gram-negative and gram-positive, the major difference is the presence of endotoxin in gram-negative organism. And this bacterial endotoxin of meningococcus is responsible for Waterhouse-Friderichsen syndrome. This particular endotoxin is responsible for Waterhouse-Friderichsen syndrome. Apart from that, other virulence factor like outer membrane protein, yes, IgA proteases, all these are other virulence factors of meningococcus. Coming to the pathogenesis, they say that most of the endemic cases, you know that the most endemic area of meningococcal infection is sub-Saharan Africa. The sub-Saharan Africa is the most endemic zone for meningococcal meningitis, and most of the endemic cases are due to serogroup A. A is the most common cause of endemic infection, followed by W135. Followed by W135. Outbreaks, especially in school and militants, etc., are due to group C. Okay, most of the hyperendemic infection are due to group B. Group B. Of course, sporadic infection anyone can cause. All important serogroups, whatever I have described earlier, that is A, B, C, W and 135, anyone can cause sporadic infections. The source of infection is nasopharyngeal carrier. Nasopharyngeal carrier, especially children. They are the major source of infection. Of course, the mode of transmission is through the respiratory mode via the droplet inhalation. So, can you tell me which is the most common route of spread from the nasopharynx to the meninges? From the nasopharynx to the meninges, the most common route is via hematogenous or via the olfactory nerve. Which is the most common route? They say that hematogenous spread is more common than the olfactory nerve spread, or that is via the pubiform plate. So hematogenous spread is the most common route, and they say that if you have complement deficiency, especially late complement deficiency, that is C5 to C9, attack complex complement deficiency, this leads to increased Neisseria infection as well as toxoplasma. So late complement deficiency is a major predisposing factor for Neisseria, increased Neisseria and toxoplasma infection. Okay. Other than that, travelers, meningococcal meningitis is more common in traveler, especially Hajj pilgrimages. Hajj pilgrims, the most common travelers which can get meningococcal meningitis, and it shows seasonal variation. Meningococcal infections are mainly in cold and dry, that is winter and summer, winter and spring are the important seasons where meningococcal infections are common. So let us now discuss the various manifestations. Meningococcal infections can from rashes to meningococcal meningitis, pyogenic meningitis, especially in 2 to 12 years age group, pyogenic meningitis. It can cause Waterhouse, Frederickson syndrome, Waterhouse-Frederickson syndrome, which is characterized by rashes, DIC, multi-organ failure, and the most important feature is bilateral adrenal hemorrhage. Bilateral adrenal hemorrhage. Okay. Apart from that, post meningococcal syndrome, post meningococcal syndrome. So these are the some of the manifestations produced by meningococcus. Coming to laboratory diagnosis, specimen of course will be CSF, and because it spreads through hematogenous spread, blood also is an important specimen. So this is important for cases, whereas for carriers, nasopharyngeal swab. Nasopharyngeal swab. So CSF and blood will be sterile specimen. So if you want to isolate meningococcus in these two specimens, then even blood agar or chocolate agar will be fine. Whereas for nasopharyngeal specimen, if you have to use a selective medium, that is Thayer-Martin medium. Thayer-Martin medium. Okay. Other than that, you can detect In CSF you can detect meningococcal antigens by doing latex agglutination test. Meningococcal antigens can be detected in CSF by doing latex agglutination test. So these are the various diagnostic tools. Antibody detection doesn't have much role in diagnosis because they are usually raised in convalescent patients. So they provide retrospective evidence of diagnosis. So mainly the diagnosis relies on CSF antigen detection or CSF culture. Coming to treatment, third generation cephalosporin will be the drug of choice. And for carriers, earlier rifampicin was given, but now the latest edition of Harrison says that single dose ceftriaxone is more effective. Single dose ceftriaxone is given for carriers. Second drug of choice will be rifampicin or ciprofloxacin. All these are given secondarily. Fine. So this is about treatment. Then vaccine for meningococcal infections. Yes, meningococcal vaccine is again composed of polyvalent vaccine. Like pneumococcal vaccine, even the meningococcal vaccine is composed of important serotypes like A, C, Y and W135. 50 microgram per dose is given. And can you tell me which important serogroup is not included here? There is no vaccine available for which serogroup? Serogroup B. For group B, there is no vaccine available. Why? Because they say that the group B capsule is less immunogenic. The group B capsule is less immunogenic as well as it is encephalitosigenic. Autoimmune reactions can take place. That is why group B capsules is not included in meningococcal vaccine. One more drawback of meningococcal vaccine is it is a capsular vaccine, polyvalent capsular vaccine. So if you use a capsular vaccine, then the common rule is it is not given less than 2 to 3 years. Why? Because it is an example of capsular antigen is an example of T independent antigen. Hence it is less immunogenic to children. Hence it is not given below 2 to 3 years. So this is all about meningococcus. Now we will discuss about gonococcus. Gonococcus, coming to the virulence factor, it is non-capsulated, and here the principal virulence factor is pili or fimbrial antigen. Of course, fimbria will also be there in meningococcus, but in meningococcus the fimbria are less important as virulence factor, but for gonococcus they are the principal virulence factor. They are the principal virulence factor. Other than that, you have IgA proteases, siderophores, all these are the other virulence factor. Outer membrane protein. Endotoxin, again it is a gram negative, so endotoxin. So these are the other virulence factors for gonococcus. Pili is the most important virulence factor because it is responsible for adhesion to the urogenital tract. That is the main reason how it can cause urethritis. So coming to the manifestations, gonococcus can produce an array of manifestations in adult male and adult female. Adult male, the most common manifestation is urethritis. They say that the urethral discharge appears as flow like seed like flow. That is why it is called as gonorrhea. The name gonorrhea is derived from the word seed like flow. The meaning of gonorrhea is seed like flow of semen or urethral discharge. Other than that, in male it can cause other complications like epididymitis, and involvement of other genital organs. Adult female, the most common complication will be cervicitis. Again, a point to be noted, gonococcus does not infect vagina. They say that adult vagina is resistant to gonococcal infection. Adult vagina is resistant to gonococcal infection because of the pH change. It is resistant to gonococcal infection. So urethritis or vaginitis, especially a vaginitis, is not a feature of gonococcus. Coming to neonate, gonococcus can cause ophthalmia neonatorum. Ophthalmia neonatorum is a condition which is either due to gonococcus or due to non-gonococcal, that is chlamydia. Both can cause ophthalmia neonatorum. Which is the commonest cause, gonococcus or chlamydia? Chlamydia is a more common cause than gonococcus to cause ophthalmia neonatorum. How to differentiate is, gonococcus, the incubation period is less than 24 hours, 24 to 48 hours. Chlamydia, the incubation period is around 5 to 7 days. Gonococcus, you will have a purulent eye discharge that will become crusted. The lesions will become dry and crusted, the discharge. Whereas chlamydia will be mucus or seromucus, mucus ocular discharge. Okay, so these are the differences between gonococcal and chlamydial ophthalmia neonatorum. Regarding complication, gonococcus can cause non-specific complications like Fidge, Hugh, Curtis syndrome, characterized by perihepatitis syndrome, which is characterized by liver involvement, or perihepatitis, and here they say that with non-specific conditions it can also be caused by chlamydia. It can also be caused by chlamydia. Other than that, it can also cause water can perineum. Water can perineum. Specific complication. Specific complication is characterized by DGI, that is deep or disseminated gonococcal infection, which is characterized by arthritis and endocarditis. Polyarthritis and endocarditis, and this is most commonly seen with AHU oxotypes. Always keep on telling you that oxotyping is the typing method followed for gonococcus. Oxotyping is a typing based on nutritional requirement. Oxotyping is a typing method based on the nutritional requirement of organism. And AHU oxotype means the type of gonococcus, the strains of gonococcus that require arginine, hypoxanthine and uracil as growth factor. Arginine, hypoxanthine and uracil as growth factor. And AHU oxotype is the most common oxotype associated with deep gonococcal infection. And deep gonococcal infection is also associated with the serotype POR B1A. The serotype POR B1A is the most common serotype associated with deep or disseminated gonococcal infection. Coming to the lab diagnosis, the specimen of choice in male, the most common manifestation is urethritis, so you have to take a urethral swab. In female, you have to take a endocervical swab. And remember, you cannot use an ordinary cotton swab because gonococcus will die in presence of cotton fiber. So the transport media will be cotton swab impregnated with charcoal. Charcoal added cotton swab, example will be Stewart's medium and Amis medium. Stewart's medium and Amis medium. Apart from that, specialized automated systems are there. For example, Jembec system. Jembec system is a specialized transport system for gonococcal specimens. Okay, so once you collect the swab, what you are going to do? You are going to do a gram stain where you will demonstrate gram negative cocci in pair, what shape? Kidney shape. So when you demonstrate gram negative cocci in pair, kidney shaped, and mostly they are intracellular, inside the pus cell, inside the pus cells. So when you demonstrate this kind of gram stain appearance, it is more important for male or it is more specific for female? Where it is more definite to start the treatment, male or female, and why? Male, they say that the gram stain is more definite. In male, you can directly start the treatment based on the gram stain appearance. But in female, there is commensal Neisseria species, non-pathogenic commensal Neisseria species. So many species are there which are non-pathogenic in female genital tract. So they also will appear like kidney shaped gram negative cocci in pair. So based on gram stain in female, you cannot start the treatment. What you have to do is, in female always culture is recommended. Which culture? Which specimen you have to use for culture? Endocervical swab, not vaginal swab. Endocervical swab is used for culture. And when you do a cervical swab culture, which medium is important? Selective medium, because you want to inhibit the commensal. So selective medium like Thayer-Martin medium is used. Other than that, you can also use Martin-Lewis medium and New York City medium, modified New York City medium. All these are various selective medium for gonococcus. And of course, other than that, as I told, it is oxidase positive, and biochemically gonococcus can ferment glucose, but how it is differentiated from meningococcus? Maltose will be fermented or not fermented? Not fermented. Maltose is fermented by meningococcus, not by gonococcus. Treatment, drug of choice is third generation cephalosporin. But please remember that gonococcus is known to produce resistance. They say that drug resistance is common in gonococcus. The reason is it carry a number of drug resistant plasmids. One of the important resistance shown by gonococcus to beta-lactams is called as PPNG strains. PPNG strain stands for penicillinase producing gonococcus. Penicillinase producing Neisseria gonorrhoeae. These strains are called as PPNG strains. So like that, even quinolone resistance Neisseria gonorrhoeae and tetracycline resistance Neisseria gonorrhoeae, like that various strains are there, and this resistance is mainly due to plasmids coding for the drug resistance. Sometimes they may have also chromosomal resistance, but in general gonococcus is more resistant than meningococcus. Okay, so now we will discuss the next chapter, Corynebacterium and Bacillus. So both are gram positive bacilli. So let me enlist the various gram positive bacilli before I start this chapter. Corynebacterium, Bacillus, Clostridium, and certain non-sporing anaerobes. I will tell little bit later, and Listeria, Actinomycetes. Actinomyces, which include Listeria and Actinomyces, which include Actinomycetes, and Nocardia. So all these are example of gram positive bacilli. Fine. So let us now start Corynebacterium. Corynebacterium, the coryne means club shaped. It is a club shaped gram positive bacilli, and the Corynebacterium diphthery, to be very particular, it is club shaped, having Chinese letter or cuneiform arrangement. Cuneiform arrangement, that is VL, like that it will be Chinese letter or cuneiform arrangement, and having characteristic metachromatic granules on either end. On both the ends, it is characterized by presence of volutin or metachromatin granule. Okay, and this granule is composed of polymetaphosphate inorganic granule, inorganic polymetaphosphate granules, and this granule is typically stained by Albert stain. Albert is the most common stain is used. Other than that, Ponder stain and Niger stain, these are the stain which are used for demonstrating metachromatic granules. Fine. So you can have a look here. This is characteristic metachromatic granule of Corynebacterium diphthery. In contrast, this side, this particular picture is other Corynebacterium species which are called as diphtheroid. You know that Corynebacterium broadly classified into Corynebacterium diphthery and others. Others are called as diphtheroid. They have a very important gram stain difference. C. dipth is in Chinese letter arrangement, V or L shaped, whereas diphtheroids are palisade in arrangement. They are palisade in arrangement, parallel to each other. So palisade in arrangement. Fine. So now I will discuss the other aspects, then the pictures I will show you later. Let us discuss the virulence factor. Virulence factor for diphtheria is nothing but expression of a very important toxin called as diphtheria toxin. This diphtheria toxin has got two fragments, A and B. Wherever AB fragment is there, A stands for active fragment, B stands for binding fragment. Very good. P binds to the host cell receptor. Here the host cell receptor is epidermal growth factor. Epidermal growth factor is the host cell receptor for diphtheria. A is the active fragment. It acts by, the fragment A acts by ADP ribosylation of elongation factor 2. ADP ribosylation of elongation factor 2 leading to inhibition of elongation factor 2 leading to inhibition of translation step of protein synthesis. Inhibition of translation step of protein synthesis. This particular mechanism is also shown by exotoxin A. Exotoxin A of Pseudomonas aeruginosa. This particular mechanism is also produced by exotoxin A of Pseudomonas aeruginosa. So now I will tell you the various factors influencing the expression of diphtheria toxin. Diphtheria toxin release is influenced by various factors. For example, it is a phage coded toxin. So as long as the bacteriophage genome is inside the diphtheria bacilli, it will produce the toxin. If the phage goes out, then the toxin production will not be possible. So phage coded. Second is its expression is dependent on production of iron. It is a iron regulated toxin, especially 0.1 milligram per liter of iron is optimally required for expression of toxin. Why? Because iron acts as a negative regulator of DT regulated gene. Okay, there is a DT regulated gene and iron acts as a negative regulator. So if iron concentration is more, then the DT regulated gene will be suppressed. As a result, diphtheria toxin will not be produced. Hence, iron concentration is very important for the expression of toxin. Fine. So what is the difference between a toxin and a toxoid? Can you tell me? Which is used for vaccine? Toxoid. So the difference between a toxin and a toxoid is, toxoid is a form of toxin which retains immunogenicity but it lacks virulence property. Toxigenicity is lost. Toxigenicity is lost, whereas immunogenicity is retained. So how will you convert toxin into toxoid? Toxin to toxoid conversion is possible by low pH, acidic pH, prolonged storage, increased storage, or even by use of formalin. These are the various methods by which you can convert the toxin into toxoid. And the Park-William 8 strain, Park-William 8 strain of Corynebacterium diphtheria is used as a source for toxoid production for the preparation of vaccine. Fine. So this is all about diphtheria toxin. Now we can discuss a bit about the pathogenesis. As I told you earlier, diphtheria toxin is the toxin responsible for pathogenesis. It binds to epidermal growth factor. After that, it will be internalized into cell. But please remember, after it gets internalized, it will go to blood, and then it will cause various manifestation. But where the organism resides, diphtheria bacilli, they say that it is present only locally. It does not invade. So here a very important point to be noted, blood culture will be positive or negative? Yes, negative. They say that diphtheria is a toxemia, but never bacteremia. Diphtheria is a toxemia but never a bacteremia. Fine. And it is a toxin which goes to the circulation and responsible for most of the manifestation, starting from pseudomembrane formation on tonsil, which is called as faucial diphtheria. Faucial diphtheria means tonsillar diphtheria, pseudomembrane formation on a tonsil. This is the most common variety. Apart from that, pseudomembrane can also be found in larynx and in other places. Laryngeal diphtheria is most dangerous. It is rare, but it is dangerous. Why? Because of chance of respiratory obstruction. It is dangerous. Then pseudomembrane formation over the tonsil. What do you mean by pseudomembrane? How it is different than true membrane? Pseudomembrane bleeds or doesn't bleed on removal? The difference between pseudomembrane and true membrane is, pseudomembrane is a false membrane. It is not a true membrane. It is attached to the underlying base, where a true membrane is a complete membrane which is separated from the underlying base. So if you try to remove, on removal, pseudomembrane will be attached. It is a false membrane, so it will bleed on removal. Whereas true membrane is a complete membrane over the tonsil, so it does not bleed on removal. Example of true membrane, Candida. There are various examples, but the membrane over the tonsil due to Candida is the most common cause of true membrane. Okay? So true membrane formation is seen in Candida, whereas pseudomembrane formation is seen in tonsillar diphtheria. But can you tell me any condition is there which is not due to toxin but due to organism? As I told you, most of the manifestations of diphtheria is due to toxin, not due to organism, except cutaneous diphtheria. The skin lesions are due to organisms, not due to toxin. Not due to toxin. Hence they say that the skin lesion can also be produced by non-toxigenic strain. Non-toxigenic strain also can cause cutaneous diphtheria. Skin lesions can also be seen in vaccinated people. Try to remember, vaccinated people means what? What they have taken? What vaccine we take in diphtheria? We take diphtheria toxoid as a vaccine. So when you take diphtheria toxoid as a vaccine, you will develop antitoxin. This antitoxin can neutralize the toxin, but antitoxin cannot prevent colonization. Understanding or not? Vaccinated children, they can have diphtheria bacilli on their throat, yes or no? Yes, they can have diphtheria bacilli on their throat, because vaccination cannot eliminate the carrier state. Vaccination is against the toxin. So if you're vaccinated, you can have organisms in the throat, but those organisms are usually non-toxigenic because you are vaccinated. So if you have non-toxigenic strain, you will not get any form of diphtheria except cutaneous diphtheria, which can be caused due to non-toxigenic strain. It is caused due to organisms. So any kind of organism, whether it is toxigenic or non-toxigenic, can cause cutaneous diphtheria. So that is why they say that the skin lesions are increased in incidence now. Why? Because most of the children are vaccinated now. So the usual conventional form of faucial diphtheria is not seen nowadays. Nowadays the cutaneous lesions are more common than faucial diphtheria. So this is about the manifestations. Then the complications. Diphtheria can produce various complications ranging from neurological complication like cranial nerve palsy, peripheral neuropathy, myocarditis. Okay, all these are various complications. The first muscle to be affected is palatopharyngeus. Palatopharyngeus will be the first muscle to be affected in diphtheria. Which is the first muscle to be affected in tetanus? Tetanus, it is first symptom of tetanus is trismus. So the first muscle to be affected is masseter, whereas in diphtheria it is palatopharyngeus. Okay, then let us now focus on laboratory diagnosis. Laboratory diagnosis, is it important to initiate the treatment? Diphtheria, the treatment is started based on laboratory diagnosis. True or false? False. They say that treatment should not be based on laboratory diagnosis. It should be based on clinical diagnosis. Clinical history. If you have a membrane over the throat, you have to start the treatment as early as possible. Why not on laboratory diagnosis? Because respiratory obstruction can happen at any time. So you cannot wait for the laboratory confirmation. So the laboratory diagnosis is done only to confirm the main purpose of laboratory diagnosis is only to confirm the clinical diagnosis. To have a confirmation on diagnosis, we do a laboratory diagnosis. It has got two parts: isolation and toxin demonstration. Isolation and toxin demonstration. The third part will be typing. These are the three parts of laboratory diagnosis. Fine. So what will be the specimen? Throat swab will be the specimen of choice. Apart from that, bits of membrane you have to remove, because you have to, of course it will bleed on touch, but you have to meticulously remove at least a small piece of membrane which will yield the organism better. After you collect the specimen, you can do the direct microscopy. You can do a gram stain also, but gram stain is usually not useful because you may have diphtheroids in your throat. So it is very difficult to differentiate diphtheria from diphtheroids of throat. So gram stain is less useful. More useful will be Albert stain. Albert stain, you will have green color bacilli with bluish black metachromatic granule. Bluish black metachromatic granule. But at the same time, I will tell you, these metachromatic granules can also be seen in, of course, Corynebacterium diphtheri, but it can also be seen in Corynebacterium gerosis, which is a throat commensal. Corynebacterium gerosis, which is a throat commensal. It is a diphtheroid. Apart from that, it can also be seen in Gardnerella, some mycobacteria, some yeast, few yeast, as well as some enterobacter, species. So these are the various other organisms which can express metachromatic granules. Of course, as far as throat is concerned, Corynebacterium gerosis is important differential diagnosis. So membrane over the tonsil. So first you do Albert stain, then what you can do is you can do a culture. Culture, there are two culture methods are available. You can use an enriched medium like blood agar, chocolate agar, and the best enriched medium is LSS, stands for Loeffler's serum slope. This is the best enriched medium. Other than that, you can use selective medium. The selective medium what is in use for diphtheria is potassium tellurite agar, PTA, potassium tellurite agar, 0.04 unit of potassium tellurite is used, and here you will produce black colony in 48 hours. After 48 hours you will get black colony, whereas enriched medium like Loeffler's serum slope is highly nutritious. So the advantage of Loeffler's serum slope is here the growth will be early growth in 6 to 8 hours. So if you want to detect early growth, you have to do Loeffler's serum slope, and because it is enriched medium, hence the granules are better developed. Why? Granules will be produced in which condition? Granules are nothing but they are the storage granules of the organism. So where the storage granules are produced? When the nutrition is more or less? More. So enriched medium will have more nutrition, hence Loeffler's serum slope is the best medium for granules to demonstrate. However, they say that enriched mediums are enriched for everything. They are enriched for Corynebacterium diphtheria as well as they are enriched medium for other commensals of throat. If you grow if you incubate the medium beyond 6 to 8 hours, even the other commensals of throat also will grow on Loeffler's serum slope. So it is not a selective medium. Hence they say that if you want to diagnose, if you want to isolate Corynebacterium diphtheria from a clinical sample or even from a carrier, potassium tellurite agar is the best specimen because it is a selective medium. So selective medium is the best medium for cases as well as for carriers, because it can differentiate, it can inhibit the commensal, it will allow only Corynebacterium diphtheria to grow. In contrast, the enriched medium, that is a Loeffler's serum slope, is less preferred for isolation from clinical specimen. It is the preferred method for demonstrating the metachromatic granule. It is also the preferred method for early growth. 6 to 8 hours of incubation time only the Corynebacterium diphtheria will grow, so you can isolate faster. Fine. So these are the two methods available. Apart from that, so once you isolate Corynebacterium diphtheria, you can do certain biochemical reactions for confirmation, like you can do his serum sugar. His serum sugars can be used for fermentation, to test the fermentation. Apart from that, urease can be done, urease test can be done. Why urease has to be done? Here I will tell you one important point. Please remember, diphtheria toxin. Diphtheria toxin is produced by Corynebacterium diphtheria. Apart from that, diphtheria toxin can also be produced by Corynebacterium gerosis, Corynebacterium ulcerans and Corynebacterium pseudotuberculosis. These are the three Corynebacterium species that can produce diphtheria toxin, and surprisingly all these three toxin can produce black colony on potassium tellurite agar. Then how will you differentiate? You can differentiate these three by doing a urease test. If you do a urease test, Corynebacterium diphtheria will be urease negative, whereas ulcerans and pseudotuberculosis are urease positive. So this is a method by which you can differentiate Corynebacterium diphtheria from ulcerans and pseudotuberculosis. So now you have done a culture, you have isolated Corynebacterium, after that you have done biochemical reaction, you have confirmed that it is Corynebacterium diphthery. But only confirmation of the organism is not enough, because Corynebacterium diphthery organism itself cannot cause any infection except the cutaneous diphtheria. Most of the manifestations are due to what? Toxin demonstration. So only isolation is not enough. After isolation you have to do toxin demonstration, and toxin demonstration is done by in vivo method as well as in vitro method. In vivo by guinea pig inoculation. Guinea pig inoculation both by subcutaneous and intracutaneous methods are available. Intradermal or intracutaneous and subcutaneous inoculation methods are available, but this is not preferred method because animal inoculation is almost obsolete nowadays. So the better toxin demonstration methods are in vitro method, like Alex gel precipitation test. It is a gel electrophoresis. It is an example of gel electrophoresis. Double diffusion in 2 dimension. To be very particular, what kind of gel electrophoresis? Answer is double diffusion in 2 dimension. Fine. So Alex gel precipitation test. Apart from that, you can detect tox antigen detection by doing immunochromatographic tests. Diphtheria toxin gene detection by doing a PCR, or even the cell line cytotoxicity. They say that diphtheria toxin is cytotoxic to cell line. So cell line cytotoxicity test can be done. All these are the various methods to detect the diphtheria toxin. Finally, the toxin also is detected. After that what to do? For epidemiological purpose, typing is done. So after the toxin demonstration, typing can be done, and among the various typing methods available, they say that biotyping is most common. This typing is called as MacLeod's classification. According to MacLeod classification, diphtheria bacilli or Corynebacterium diphthery can be classified into 3 biotypes: gravis, intermedius and mitis. These are the 3 biotypes. Of course, now a 4th biotype also is available, which is called as Belfanti. Belfanti biotype is the 4th biotype. It is nothing but it is a nitrate negative variant of mitis. It is same as mitis except that it is nitrate negative. So mainly 3 biotypes: gravis, intermedius and mitis. How to differentiate is, you can differentiate these 3 based on their colony appearance on potassium tellurite agar. They say that gravis, how to remember is, you have to remember alphabetically. Three colony appearances are there. Alphabetically you have to remember. Gravis produces daisy head colony. Intermedius produces frog's egg colony, and mitis produces poached egg colony. Can you tell where you will get fried egg colony? Mycoplasma. 2M Mycoplasma and Malassezia. Fried egg colony. Whereas frog's egg colony in intermedius. Fine. So these are the various colony morphology. So next is starch fermentation. Next point of differentiation is starch fermentation. They say that gravis can ferment, whereas intermediates and mites, they do not ferment starch. Then gravis and intermediates can cause epidemics, whereas mites can cause endemics. Mites, the colonies are more hemolytic, and mites, the metachromatic granule is maximum. This is one more point to be remembered. The metachromatic granules are produced maximally in mites, and also the colonies are more hemolytic in mites. Complication, gravis, the complications are hemorrhagic, whereas mites, the complications are obstructive. Intermediates, actually hemorrhagic and paralytic complications are seen in gravis, whereas intermediates will be variable, sometimes it is hemorrhagic. Okay, so these are the differences between the three biotypes of Corynebacterium diphthery. Other than that, you have phage typing method. Phage typing method is available. Genotyping is also there, but biotyping is most widely used. So this is all about the diagnostic process. Now we will discuss about treatment. Treatment is done by two important methods. Antitoxin, which is called as antidiphtheritic serum, ADS, antidiphtheritic serum, otherwise antibiotic. These are the two important diagnostic modalities. Which is more important, antitoxin or antibiotic? Diphtheria is due to organism or toxin? Toxin. So antidiphtheritic serum is the most definitive treatment. However, the antibiotics are useful if you are given early, less than 6 hours. Before expression of toxin, if you are giving antibiotic, it is useful. Antibiotic is also useful because it will prevent further release of toxin by killing the organism. It will prevent further release of toxin by killing the organism. Antibiotics are also important for elimination of carriers. Carriers, vaccine has any role? No. Vaccine cannot eliminate the carriers. So for cases, the drug of choice is penicillin, whereas for carriers the drug of choice is erythromycin. Erythromycin is given for carriers. Okay, so this is the various antibiotic modality. Now we will discuss vaccine for diphtheria. Vaccine for diphtheria is given in the form of DPT, stands for diphtheria toxoid, tetanus toxoid, pertussis what? Pertussis killed vaccine. There is one more vaccine is available, DAPT. Here AP stands for acellular pertussis. Can you tell me why this three combination is there? DPT. Why these three vaccines are given together? There is any reason behind it? Yes, these three vaccines are given together. The reason is why we give combined vaccine. When we give combined vaccine, one acts as an adjuvant for others. In this situation, the pertussis vaccine acts as adjuvant for DT and TT. In case of DAPT also, the acellular pertussis act as adjuvant. For DT and TT. Nowadays the quadruple vaccine is available, that is DPT plus Haemophilus influenza B, Hib vaccine, all given together. Why? In this case, which is the adjuvant, DPT or Hib? What kind of vaccine is Hib? Haemophilus influenza B vaccine is an example of Capsular vaccine. Capsular vaccines are given to children, yes or no? No. Why? Because capsular antigens are T independent antigen, hence they are less immunogenic in 2 to 3 years. How you can make it immunogenic? The capsular vaccine you can make immunogenic by conjugating. How can you conjugate capsular vaccine? By adding adjuvant. So please remember, here DPT is added because DT and TT act as adjuvant for Hib. This is the MCQ what they frequently asked. DT and TT act as adjuvant for Haemophilus influenza B. Fine? Okay. Now coming to schedule. How this vaccine is given? DPT 5 doses, 3 doses at 6, 10 and 14 week, then booster 1 at 1.5 year, booster 2 at 5 to 6 year. Route, it is given deep IM, anterolateral aspect of thigh, anterolateral aspect of thigh. Please remember, gluteal region is not given, not preferred, because a gluteal region will have fat which will inhibit the absorption of the toxin. So usually it is given anterolateral or upper, which is also described as upper outer quadrant of thigh. So this is the site for DPT inoculation. Okay, and thiomersal is used as a preservative. What is the absolute contraindication? The absolute contraindication of DPT is if you have a past history of neurological complication. Past history of neurological complication. Any neurological complication, DPT is contraindicated. More than 6 years also DPT is not given. Why? And of course, hypersensitive reaction to previous dose. These are the absolute contraindications. Why DPT is not given more than 6 years? Because what are the side effects of DPT? And the side effect of DPT is due to which component? D, P or T? The side effect of DPT is due to the killed pertussis component. The killed pertussis component is known to produce neurological complication. It can produce a complication called as hypotonic hyporesponsive syndrome. Can produce a complication called as hypotonic hyporesponsive syndrome. And all neurological conditions are contraindication except they say that any progressive neurological disorder, any progressive neurological disorder is a contraindication for DPT vaccine. Exceptions are cerebral palsy because it is non-progressive, as well as febrile seizure because it is a transient condition, it is not a permanent condition. So any progressive neurological disorder is a contraindication for DPT vaccine except cerebral palsy and febrile seizure. These are not contraindications. These are not contraindications. Can you tell me the difference between capital D and small d? Capital D is given in DPT. Yes or no? It is given to children. It contains higher dose, that is 25 LF of diphtheria toxoid, whereas small d is given to adult, usually more than 1 year, and it contains low dose of diphtheria toxoid. Low dose of diphtheria toxoid. So apart from vaccine, we can now discuss about the non-diphtheria corynebacteria, that is diphtheroids. Okay, diphtheroids. Among the diphtheroids, the important ones are Corynebacterium ulcerans and pseudotuberculosis. They produce diphtheria toxin, so they mimic respiratory diphtheria. However, they are urease positive. This is a way to differentiate. Apart from that, Corynebacterium parvum is an example of immunomodulator, and Corynebacterium jaycium, which is a multi-drug resistant species. It is lipophilic and known to cause opportunistic infection. Opportunistic infection. Corynebacterium minutissimum is agent of a cutaneous condition called as erythrasma. Cutaneous condition called as erythrasma, which is characterized by, if you do a wood lamp examination, what color? Coral red color. So this is all about Corynebacterium, and if you are done with, then let us start Bacillus. Bacillus is an example of obligate aerobe. Obligate aerobic spore forming gram positive bacilli. Broadly, you can categorize into Bacillus anthracis and others which are called as anthracoid bacillus. Why these two broad categories? Because they have lot of differences. Anthrax bacillus differs a lot from other bacillus. One is the presence of capsule. Anthrax is capsulated and non-motile, whereas anthracoid are motile and non-capsulated. The capsule of anthrax can be detected by which test? Mac-Fadian reaction, by using polychrome methylene blue. Mac-Fadian reaction by using polychrome methylene blue to detect the anthrax capsule. If we do a gram stain, anthrax will be gram positive bacilli in long chain. Okay, capsule is detected by Mac-Fadian reaction. Then if you do a gram stain, anthrax appears as gram positive bacilli long chain, described as bamboo stick appearance. Bamboo stick appearance. Okay. Then on nutrient agar, anthrax produces medusa head colony, seen under low power field in microscope. Under the microscope, low power field of the microscope, medusa head colonies are seen. Blood agar anthrax produces non-hemolytic colony, whereas anthracoid bacillus can produce hemolytic colony. Okay. Gelatin stab agar, gelatin stab agar anthrax can produce inverted fir tree colony, which will be absent in anthracoid. Then any solid media with penicillin, any solid medium with penicillin, anthrax can produce string of pearl appearance colony, which will be absent in anthracoid bacillus. So like that there are various differences between anthrax and anthracoid bacillus. Okay, so all these are the various points that can be asked. Selective medium for anthrax is plate agar. Selective medium is plate medium for anthrax, that is polymyxin, lysozyme, EDTA, thallus acetate. Thallus acetate. So these are the composition of plate medium, which is the selective medium for anthrax. Okay, coming to the manifestation, anthrax is for ages it is known to be a zoonotic disease affecting herbivorous animal more than carnivorous animal. Okay, the animals, they vary in their susceptibility to anthrax bacilli. In humans, anthrax can be transmitted by skin contact, which is the most common mode. Other than that, inhalational mode, ingestion, very rare mode like mechanically through flies, etc. Housefly can act as mechanical vehicle for anthrax bacillus, but these are rare mode of transmission. The most common anthrax is cutaneous anthrax. So let me tell you the differences between cutaneous anthrax and pulmonary anthrax. Cutaneous anthrax is the most common form, 95%. It is also called as Hyde Porter's disease, characterized by presence of malignant pustule, which is nothing but it is a black color eschar surrounded by non-pitting edema. Non-pitting edema, and remember it is non-malignant, it is a benign condition. Though it is called as malignant pustule, it is a benign condition and it is a painless condition. Because of the look of the black color eschar, it is having a malignant look, hence it is called as malignant pustule. Otherwise it is a benign condition. In contrast, the pulmonary anthrax is called as Wool-Sorter's disease, characterized by hemorrhagic mediastinitis. If they ask you what are the various occupations associated, cutaneous anthrax is associated with farmers, butchers, abattoir, whereas pulmonary anthrax is seen in workers of wool factory. Which is common? Common is cutaneous. Pulmonary is rare but it is fatal. And pulmonary anthrax is the most common form which is targeted in bioterrorism. Bioterrorism attack, mostly the pulmonary anthrax form is targeted. And if you remember the 2000 attack, or 2001 attack in USA, that is mainly pulmonary anthrax what has been produced there. Okay, and of course anthrax is the most common agent to be used for bioterrorism. Anthrax spore is the most common agent to be used for bioterrorism. And in bioterrorism attack, they say that direct immunofluorescent test is used for diagnosis in bioterrorism attack. Okay, you cannot wait for culture and other things, so direct immunofluorescence is the most confirmatory test used for bioterrorism attack diagnosis. Fine, so this is all about anthrax. Among the anthracoid bacillus, the only organism which is a pathogen is Bacillus cereus. Bacillus cereus can produce two types of toxin, and accordingly it can cause two types of food poisoning. It can produce diarrheal toxin, it can produce emetic toxin. Emetic toxin can cause emetic food poisoning, whereas diarrheal toxin can produce diarrhea. Pain abdomen is a common feature seen in both the variety, abdominal pain, which is preformed, emetic or diarrheal. Emetic variety has an incubation period of less than 6 hours. Why? Because it is an example of preformed toxin, and this toxin is heat stable like Staph aureus enterotoxin. It is also heat stable like Staph aureus enterotoxin. One more point to be remembered is the most common food for emetic variety is Chinese fried rice. Chinese fried rice. In contrast, diarrheal variety has a longer incubation period and it is heat labile. Here the food will be meat, vegetables, etc. Sometimes they ask the serotype association. The odd serotype can cause emetic, whereas even serotype can cause diarrheal variety. Odd serotype is not a, always it doesn't happen, but mostly the odd serotypes they cause emetic, whereas the even serotype they produce diarrheal symptoms. Okay, so this is all about Bacillus cereus, and Bacillus cereus, the selective medium is MIPA. MIPA medium, that is mannitol, egg yolk, polymyxin, phenol red agar. Polymyxin, phenol red agar. Mannitol, egg yolk, polymyxin, phenol red agar. Okay, so that is all about Bacillus cereus. Okay, so now we will discuss chapter number 3.5, anaerobes. Anaerobes are broadly categorized into obligate anaerobe and aerotolerant. The basic difference between obligate anaerobe and aerotolerant anaerobe is that obligate anaerobe, oxygen is lethal to them. They cannot grow in presence of oxygen. They cannot grow in presence of oxygen because they lack certain enzymes like superoxide dismutase and catalase. These are the two important enzymes what aerobes they have to neutralize the lethal effect of oxygen, whereas the obligate anaerobe they lack these two enzymes, hence they cannot grow in presence of oxygen. most of the Clostridia are example of, most of the Clostridia as well as non-sporing anaerobe are example of obligate anaerobe. In contrast, the aerotolerant anaerobe, they can grow in presence of oxygen, but they do not utilize oxygen. They can grow in presence of oxygen, but they do not utilize oxygen. This is because they lack superoxide dismutase. I mean, they will not completely lack. They say that they have less amount of superoxide dismutase. That is why they can tolerate oxygen. However, they lack catalase. They do not have catalase, but at least they will have less amount of superoxide dismutase, as well as they will have peroxidase. That also a little bit amount they will have, hence they can tolerate oxygen. And here the examples are one species of Clostridium, that is histolyticum, and some bacteroids are also, sometimes they behave as aerotolerant anaerobe. So this is a gross classification, but in general we consider both as anaerobes. They cannot, I mean, oxygen is immaterial for them. I mean, they cannot grow in presence of oxygen. So let us discuss Clostridium. So broadly, anaerobes are of two types: sporing anaerobe, that is Clostridium, and non-sporing anaerobe. These are the two variety of anaerobes. So we will discuss sporing anaerobe, that is Clostridium. Clostridium is obligate sporing gram positive bacilli, anaerobic bacilli, obligate gram positive anaerobic sporing bacilli. All Clostridia are motile. They exhibit a motility called as stately motility, except Clostridium perfringens and Clostridium titani type 6. Type 6 serotypes is non-motile. All Clostridia are non-capsulated, again except Clostridium perfringens and Clostridium butyricum. These are capsulated Clostridia. Similarly, the spores are concerned, Clostridium, most of the Clostridia, they produce subterminal spore, with some exception. The exception are Clostridium titani, the spore is terminal and round, described as drumstick appearance. Clostridium tertium, it is terminal and oval. Described as tennis racket appearance. And one more exception is Clostridium bifermentans, where it is central spore. Central spore. Fine. So these are the various spore arrangement of Clostridia. So let us now discuss Clostridium perfringens. Clostridium perfringens, as I told you earlier, it is sporing having a subterminal spore. It is motile or non-motile? Non-motile, capsulated. It is invasive as well as toxigenic. It can produce various toxins. The toxins are categorized into major toxin and minor toxin. Major toxins are alpha toxin, beta toxin, epsilon and iota toxin. Alpha, beta, epsilon and iota toxin, all these are major toxin, and various around 8 minor toxins are there. Among the major toxin, it is the alpha toxin which is called as lecithinase or phospholipase C. This is the most important toxin which is responsible for, this is the principal virulence factor of gas gangrene. This is the principal virulence factor for gas gangrene. And this toxin is responsible for Nagler reaction also. What is Nagler reaction? I will tell you a little bit later, just to write down now. It is the principal virulence factor responsible for Nagler reaction. So, these are the various toxins of Clostridium perfringens. Then coming to the clinical manifestation, Clostridium perfringens can cause clostridial wound infection, which can be classified as simple wound contamination, just it is the contamination of superficial wound with Clostridium perfringens. This does not necessarily causes infection. So, the next stage is from the superficial contamination, spores can invade and that can lead to anaerobic cellulitis. Anaerobic cellulitis. Later on it can cause, further invasion can cause anaerobic myositis, which is also called as gas gangrene. Okay, which I will discuss bit later after finishing the other manifestations. So, apart from clostridial wound infection, clostridial enteric infection, here you can remember as food poisoning. Clostridium perfringens is again a known cause of food poisoning. It can cause food poisoning. Fine. And food poisoning strains are again type A strain. Type A strain of Clostridium perfringens. And these type A strains are known to produce enterotoxin. Okay. Other than that, enteritis necroticans is one more clinical condition, enteric infection produced by Clostridium perfringens. Here you will have ischemic necrosis of jejunum, and this particular condition is also called as pig bell. In the local language it is called as pig bell. New Guinea is the country where it is called as pig bell, and this particular condition is produced by, the principal virulence factor is beta toxin of Clostridium perfringens type C. Okay. Type A can cause food poisoning, type C beta toxin can cause enteritis necroticans. Okay, so these are the various, and other than that, necrotizing enterocolitis, one more clinical condition, overlapping clinical condition. Necrotizing fasciitis we have discussed in the morning, which is the causative agent of necrotizing fasciitis. Yes, group A streptococcus, whereas necrotizing enterocolitis, it is Clostridium perfringens. Gangrenous appendicitis. one more clinical condition. So all these are clostridial enteric infections. Then the third will be other infections produced by Clostridium perfringens. Various infections are there like bacteremia, skin soft tissue infection, endometritis, meningitis, brain abscess, panophthalmitis. Okay, so these are the various other conditions produced by Clostridium perfringens. It is one of the important pathogen in Clostridium. But as I told you earlier, the most important manifestation is gas gangrene. So let us discuss a bit about gas gangrene. Gas gangrene is nothing but, the definition says it is nothing but edematous myonecrotis. And regarding the agents, of course, it is most often it is polymicrobial. Agents can be categorized as established agent, and probable agent. Established in that Clostridium perfringens group A, type A is the most common cause. Other than that, Clostridium novae and septicum are the other two important established agents, novae and septicum. Of course, 60% of gas gangrene is due to Clostridium perfringens. Novae and septicum may be the remaining 20 to 40% of cases. So these three are the established agents. Probable agents are the other rare causes like Clostridium histolyticum, Phalax, Sordelli. I know it is difficult to remember, but you have to remember the agents because they sometimes ask which is not an agent, which Clostridium does not cause gas gangrene. So for that you have to remember the list of probable agents also. Clostridium bifermentans, sporozini. Okay, so these are the various. Tertium, very rarely even Clostridium tertium can also cause aceto, aerophytidium can also cause. These are very rare agents, but they can cause. Okay, so these are the list of probable agent of gas gangrene. Then we can discuss about the various clinical manifestations of gas gangrene. Yes, sudden onset of pain, excruciating pain at the affected site. Why it is called as gas gangrene? Because you will have crepitus. So pain at the site plus crepitus or gas bubble are the important manifestations. Later on, shock and multi-organ failure. And don't forget, you will have a serosanguinous, foul smelling discharge. Anaerobic discharges will be always foul smelling serosanguinous discharge. Okay, so when this kind of manifestations are there, you should always expect gas gangrene. Okay. Okay, so this is a particular clinical manifestation of gas gangrene. Presence of gas bubble at the affected site and crepitus. So when you get a case of gas gangrene, if you go to the laboratory diagnosis, now we can discuss about laboratory diagnosis. What is the specimen of choice? You will take swab or you will take muscle bits. Please remember, for any anaerobic diagnosis, swabs are contraindicated. They are not preferred specimen because swabs are exposed to oxygen, and swabs you will always take from the superficial area. Swabs means what? You will take from superficial skin, so which is already exposed to oxygen. So anaerobic organisms are hardly recovered in swabs. So always the ideal specimen will be muscle bits or deeper tissue. Okay, so when you take the muscle bits or the deeper tissue, if you do a gram stain, what you can get? Gram positive bacilli without spore or gram positive bacilli with spore. Please remember, in this context I want to add a very important point. Clostridium perfringens is always spore bearing, but except the gas gangrene strains. Please remember, the gas gangrene strains of Clostridium perfringens, they do not produce spore. Otherwise it is spore bearing. So if you get gram positive bacilli without spore, like this particular picture you can see here, this is a gram positive bacilli. The description is boxcar shaped. I will write down here. Thick, stubby, boxcar shaped gram positive bacilli without spore. There is no spore. This is a typical description for Clostridium perfringens producing gas gangrene. Whereas if you have with spore, a gram positive bacilli with spore formation, this description goes for other Clostridia species. Okay. Next, what I will tell you is, suppose gram stain, you have seen that gram positive bacilli without spore. Then you are doubting that it is Clostridium perfringens. Then how to confirm that it is Clostridium perfringens? The confirmation is done by various methods. One of the method is Nagler reaction. Nagler reaction, as I told you, Nagler reaction is nothing but production of opalescence on a special medium called as egg yolk agar. Production of opalescence on egg yolk agar, and this opalescence is due to production of which toxin? Alpha toxin or lecithinase, which will degrade the egg yolk protein to produce an opalescence. And they say that this opalescence will be inhibited. See, you can have a look here. Here you have opalescence, and this opalescence is inhibited. Here there is no opalescence. Here only the streak line is there, but the opalescence is absent. And this opalescence can be inhibited by adding anti-alpha toxin to the medium. If you add anti-alpha toxin to the medium, the opalescence will be inhibited. So this is a characteristic feature of Clostridium perfringens producing alpha toxin. So this is one method for confirmation. Other than that, you can look for target hemolysis. Second point is target hemolysis. Target hemolysis is nothing but it is a double zone hemolysis. Third feature is Clostridium perfringens is positive for reverse camp test. This is a picture showing the enhancement of hemolysis of Streptococcus agalactiae towards Clostridium perfringens. So this is a feature of reverse camp test. Camp test is done for group B Streptococcus, whereas reverse camp test is done for Clostridium perfringens. So these are the three methods for confirmation. Okay. So now we will discuss about treatment of gas gangrene. Treatment of gas gangrene. They say that surgical debridement is the mainstay of treatment. It is the mainstay of treatment. Apart from that, the drug of choice is combination of penicillin and clindamycin. Drug of choice is combination of penicillin and clindamycin. Hyperbaric oxygen is given. Why? Because obligate anaerobe, they are destroyed in presence of higher concentration of oxygen. Of course, anti-gas gangrene serum, that is anti-alpha toxin. Anti-alpha toxin. So these are the various diagnostic modalities of gas gangrene. So with this, now we will jump to Clostridium tetani. Clostridium tetani is motile. It produces characteristic swarming type of motility, except type 6, which is non-motile. Except type 6, which is non-motile. It produces two type of toxin, tetanolysin and tetanospasmin, which is important. Tetanospasmin is also called as tetanus toxin, TT, tetanus toxin, and tetanospasmin is the toxin responsible for pathogenesis. Responsible for pathogenesis. This particular toxin is oxygen stable, and heat labile. And the mechanism of action is, they say that it acts presynaptically and it acts by inhibiting it acts by blocking the release of inhibitory neurotransmitter like glycine and GABA. Inhibitory neurotransmitter like glycine and GABA. That leads to spastic paralysis. That leads to spastic paralysis. If you look here, any muscle to contract, you have a positive stimulus given by acetylcholine. You have a negative stimulus for muscle contraction provided by glycine and GABA. Tetanus toxin acts by inhibiting glycine and GABA. That leads to removal of the negative stimulator, hence you will have spastic paralysis. whereas ACH is blocked by botulinum toxin. So when acetylcholine is blocked by botulinum toxin, that leads to flaccid paralysis. So this is the difference in the mechanism of action of tetanus toxin and botulinum toxin. And I hope you remember that strychnine poisoning has a similar mechanism of action like tetanus toxin. The only difference is strychnine acts post synaptically, whereas tetanus toxin acts presynaptically. This is the difference, otherwise they act in a similar fashion. Fine. So this is the mechanism of action. Now we will discuss the mode of transmission of tetanus bacillus. Tetanus bacilli enters through injury, which in the form of severe road traffic accident or maybe surgery or abortion or delivery which are unhygienic. Unhygienic, to be more particular, a tradition which Indian villages they follow by applying cow dung to umbilical stump. You know that the cow GIT is full of Clostridium tetani. Clostridium tetani is a normal flora in the GIT of cows. So if you apply cow dung to the umbilical stump, it is like inviting problems. Okay, so this is the most common habitat that can lead to neonatal tetanus. So other than that, the various other modes like otitis media, otogenic tetanus. Tetanus can enter, tetanus bacilli can enter through otitis media also. Please remember, it is non-infectious. That is, there is no man-to-man transmission. Man-to-man transmission. As well as I told you earlier, it is also non-invasive. It is also non-invasive. You will have toxemia but not bacteremia. You will have toxemia but not bacteremia. Fine. So this is all about the mode of transmission. Let us discuss the various clinical manifestations. Incubation period is 6 to 10 days. They say that lower the incubation period, graver is the prognosis. Lower the incubation period, graver is the prognosis. First muscle to be affected, masseter. That leads to trismus or lockjaw. This is the first manifestation. Except in neonates, they say that neonate you may not appreciate trismus properly. Neonate difficulty in feeding will be the initial manifestation. Otherwise, trismus is the earliest manifestation. As the disease progresses, you will have localized involvement of affected limb. First, the limb will be affected, and which leads to generalized painful spastic contraction of muscle. And please remember, hand and feet are usually spared and mentation is unimpaired. That means the patient will be aware of what is happening. Very pathetic condition. Mentation will be unimpaired. Of course, deep tendon reflexes may be exaggerated. Complications like rhizus sardonicus, two important complications seen in tetanus. Rhizus sardonicus, which is a characteristic abnormal sustained facial muscle spasm. Characteristic abnormal sustained spasm of facial muscles, rhizus sardonicus, and the continuous contraction of extensor muscles can lead to opisthotonous position. Continuous contraction of the extensor group of muscles can lead to opisthotonous position. Autonomous disturbances may be seen. ANS symptoms are quite common, especially during second week. Okay, so these are the various complications seen in tetanus. Now let us focus on laboratory diagnosis. Please remember, the specimen once you collect, if you get gram positive bacilli with drumstick appearance spore, of course it is a clue that it is Clostridium tetani, but do not jump into the conclusion that it is Clostridium tetani, because there are so many tetanomorphic bacilli. Tetanomorphic bacilli are there, so many other Clostridia are there, which may have similar morphological appearance, like Clostridium sphenoides and Clostridium tetanomorphus, tetanomorphum. So these are the tetanomorphic bacilli which also can have similar appearance like Clostridium tetani. So other than that, you have to do culture, and please remember, when you do a Robertson cooked meat broth culture, RCM culture, Clostridium tetani is proteolytic. So being proteolytic, it will turn the meat black. It will turn the meat black with a very offensive odor. With a very offensive odor. I will show you now, so that side by side you can have a picture. So please remember, drumstick. So this is a particular feature of gram positive bacilli with drumstick. When you inoculate in Robertson cooked meat broth, this is the normal uninoculated broth. Normal uninoculated broth. And Clostridium perfringens, the medium will become turbid, and meat will become pinkish, because Clostridium perfringens is saccharolytic. In contrast, Clostridium tetani, which is proteolytic, can produce turbid broth with blackening of meat and very offensive odor. Very offensive odor. Fine. So these are the features to identify Clostridium tetani. Okay. Now we can discuss about treatment. Again, it is a toxin mediated disease, not organism mediated. So again, the treatment of choice will be antitoxin. Antitoxin, it could be human tetanus immunoglobulin or it could be equine tetanus immunoglobulin. Among these two, the human tetanus immunoglobulin is more preferred. It is given as 250 international unit and it lasts for 30 days. The protectivity stays for 30 days. Okay. Antibiotic are useful only in case of early, that is less than 6 hours before the expression of toxin. Otherwise, as we discussed, like diphtheria, it can prevent further release of toxin by killing the organism. And the antibiotic of choice will be metronidazole. Metronidazole is drug of choice. Penicillin also is given as alternate. Fine. So this is all about treatment. Next is prevention. Prevention is by tetanus toxoid. Tetanus toxoid is given either as primary immunization or secondary immunization to adult. Primary immunization is given under national immunization program. It is given as DPT 5 doses. You know that 6, 10, 14 week, then booster 1, booster 2. Booster 1 at 18 month, booster 2 is at 5 year. Followed by 2 doses of TT at 10 year and 16 year. So if you ask total how many doses? 7 doses under primary immunization. If the child is not vaccinated, for example, then what you can do is, if the child is presented later in the adult life, then secondary immunization is given 4 doses, 2 doses at 1 month gap, followed by booster 1 at 1 year and booster 2 at 5 year. This is how it is given. And one more aspect you need to remember is, following a wound injury, what is the guideline? Following the wound injury, this is a very common scenario what you get in a day-to-day practice. If a person is having some wound injury, TT is required or not. This can be assessed by 2 criteria: whether the wound is a simple wound or it is a contaminated wound. Simple wound means fresh wound, less than 6 hours. Clean wound, non-penetrating wound, and no or negligible tissue damage. This is called as simple wound. And other type of wounds are described under contaminated wound. So this is one criteria based on what the treatment differs. One more criteria is whether the person is vaccinated or not. Whether the person is vaccinated or not, based on that you have 4 categories. You have 4 categories. Category A is completely vaccinated less than 5 years back. I mean within 5 years back. Within last 5 years the person is completely vaccinated. Category B is completely vaccinated within 5 to 10 years. Category C is completely vaccinated more than 10 years back. Category D is unvaccinated or unknown status. You don't know the vaccination history. Many cases you will not know the vaccination history because the mother will not be able to reproduce whether the child is vaccinated in not long back. So in such situation, category A, that is the person is completely vaccinated within last 5 years, then whether it is a simple wound or a contaminated wound, nothing is required. If a person is completely vaccinated 5 to 10 years back, category B, then whatever is the type of wound, only single dose of tetanus toxoid is required. More than 10 years back, if it is a simple wound, single dose of TT. If it is a contaminated wound, single dose of TT plus human tetanus immunoglobulin. Unknown status, category D, then you have to give a complete course of TT. And if it is a contaminated wound, then you have to add immunoglobulin. Complete course plus you have to add immunoglobulin. So this is a very important table. Based upon this many MCQs are framed. So you have to remember this table. Okay, fine. So now we will discuss about neonatal tetanus. Neonatal tetanus is also called as 8th day disease because the manifestation symptoms usually start after 1 week, hence it is called as 8th day disease. And as I told you, the neonatal tetanus, the most common reason why it happens is the unhygienic practice of applying cow dung over the umbilical stump. However, if you know that the neonatal tetanus elimination has been recently achieved in India. What is the criteria of neonatal tetanus elimination? The criteria of elimination of neonatal tetanus. Tetanus. There are 4 criteria. One is the rate, the neonatal tetanus rate should be less than 0.1 per 1000 live birth. TT coverage should be more than 90% of pregnant women. 90% of pregnant women should receive TT, and at least 75% of deliveries should be attended, hospitalized or at least attended by the hospital staffs. So 75% of at least attended delivery. So these are the 3 criteria what was required, and they say that Government of India was happy to announce that India has achieved the neonatal tetanus elimination status. In May 2015. So this is one of the health related milestone what we have achieved in 2015. Okay, so this is all about neonatal tetanus. Now it's a time to discuss about Clostridium botulinum. Clostridium botulinum produces a toxin called as botulinum toxin, and this botulinum toxin is the most potent toxin to man, most potent toxin to human being. And if you know the mechanism of action is it inhibits ACH release, leads to flaccid contraction of muscle. Site of action, they say that most commonly it acts on neuromuscular junction, followed by it acts on peripheral ganglia, and parasympathetic nerve ending. Parasympathetic nerve ending. However, it does not act on CNS. Please remember, the most common site is neuromuscular junction and it does not act on CNS. And botulinum toxin is usually produced intracellularly and it is not secreted. It usually appears outside only after lysis of the bacterial cell. Only after the lysis of the bacterial cell it released outside. It is usually secreted intracellularly. Fine, the mechanism, and because it produces flaccid paralysis, hence botulinum toxin is one of those toxins that can be used therapeutically. Therapeutically used in various spasmodic conditions. Various spasmodic conditions like blepharospasm, yes, strabismus, myoclonus. Like that, there are number of spasmodic conditions where botulinum toxin is in use. And they say that if you type botulinum toxin, there are total 8 types, type A to G. Among the 8 types, the most common type to cause human infection is A, B and E are the common types to cause human infection. And all types are neurotoxin, that is they act by inhibiting ACH release except C2, which is an enterotoxin. And type C and D, as you remember, they are coded by bacteriophage. They are phage coded toxins. I hope you remember the 5 important bacteriophage coded toxins which are very important for exam. Fine. Then regarding the manifestation, so there are the manifestations of botulism is described as Ds. There are various Ds, are there 5 Ds characterized by diplopia, dysphagia, dysarthria, decreased deep tendon reflex and descending paralysis. Descending paralysis. But please remember, there is no diarrhea. Instead of that, it produces constipation. As you know, ACH is decreased, so if ACH is decreased, then that leads to constipation, not diarrhea. So 5 deep but not diarrhea, constipation. And respiratory muscle paralysis can lead to death. And of course, please remember, only the muscle will be affected. There is no sensory involvement or there is no cognitive deficit. Okay, so these are the various symptoms of botulism. 5D plus constipation. This is a trick what you have to remember. Type of botulism. Botulism is of 3 types. Food botulism, wound botulism and infant botulism. Food botulism is due to preformed toxin, preformed botulism toxin, and usually the most common food to be associated is canned food. Canned food. Wound botulism results from contamination of wound. Wound contamination with spores of Clostridium botulism. Here the symptoms will be almost same as food botulism, except that the GI symptoms will be absent. Fine. Then the third variety is one of the most commonly asked variety, infant botulism. Infant botulism is usually results from consumption of contaminated honey with spores of Clostridium botulinum, and infants they usually develop extreme of weakness, which is described as floppy child syndrome. Extremely lethargic they will become, which is called as floppy child syndrome. Okay. Of course, it is a self-limiting condition, they usually recover. One rare variety of botulism is there, which is described as iatrogenic botulism, which can result from overdose of toxin. You know that botulinum toxin is used therapeutically in various conditions. So, if you use overdose of the toxin, then also it can lead to iatrogenic botulism. Okay, so there are some other Clostridium. They can also produce botulism toxin. Yes, they sometimes ask, you can remember other Clostridia which can produce botulinum toxin include, of course, Clostridium. Apart from Clostridium botulinum, there are other Clostridium species like Butyricum, Barati. So, these are the other species which can produce Clostridium, botulinum toxin. Okay, so this is all about Clostridium botulinum. Now we will discuss Clostridium difficile. Clostridium difficile is the causative agent of PMC, stands for pseudomembranous colitis. So, this particular condition is seen in which risk factors, the presence of which risk factor act as predisposing for this condition. Prolonged hospital stay, with intake of broad spectrum antibiotic. These broad spectrum antibiotics, if you take for longer duration, then that can suppress the normal flora and that will facilitate the Clostridium difficile to grow and cause infection. Can you tell me which is the most common antibiotic to cause, to be associated with pseudomembranous colitis? It was clindamycin before, but now third generation cephalosporin are the commonest antibiotic, followed by clindamycin, followed by any other broad spectrum antibiotic, including the drug of choice. The drug of choice of pseudomembranous colitis is vancomycin and metronidazole. They say that even the drug of choice also if you give for longer course, that can cause pseudomembranous colitis. Any antibiotic if you are giving for longer duration, it will suppress the normal flora, that leads to multiplication of Clostridium difficile. Please remember, Clostridium difficile it can be a part of normal commensal also in your GIT. Normal commensal of your GIT. Then how it can cause pseudomembranous colitis if it is a normal commensal? They say that why it can cause is the normal commensals which are there in our GIT, those Clostridium difficiles are non-toxigenic. Clostridium difficile inducing pseudomembranous colitis is not organism mediated, it is toxin mediated. They say that the commensal strains are non-toxigenic strain. It is the toxin strains that can cause infection. It can produce two type of toxin, toxin A and toxin B. Toxin A is an enterotoxin. Toxin B is a cytotoxin. And both the toxins are important for disease manifestation. Both are important. Both the toxins are responsible for disease manifestation. Other risk factor. This is again a frequently asked MCQ. Recently in PGI they have asked rectal thermometers. Use of rectal thermometers. Of course, old age, intestinal GI surgery, patient undergone GI surgery, old age, use of electronic rectal thermometers, as I have already told, antacid, patient on antacid treatment. All these are the other risk factors that can cause pseudomembranous, that can predispose to pseudomembranous colitis. Coming to clinical manifestation, diarrhea is the most common manifestation. Other manifestations include fever, abdominal pain, etc. Please remember, blood in stool is uncommon. This is again a recently asked question. Okay. Pseudomembrane can be detected. Pseudomembrane formation on colonic mucosa. And this is again one more manifestation. So these are the various clinical manifestations which can be seen. Diagnosis. Diagnosis of pseudomembranous colitis, again various MCQs are there. Which is definitive? Which is most commonly done? Culture is important or not? They say that laboratory diagnosis is essential, but again it is a toxin mediated disease, not organism mediated disease. So whenever the disease is toxin mediated, culture plays less important role. Why? Because Clostridium difficile is a normal flora of your stool. So how can you say that it is pathogenic? So they say that culture is more sensitive, but it is less specific, because later on you have to demonstrate the toxin. Only culture you cannot conclude that it is the causative agent. There are various media to be used. The most important media is CCFA medium, that is cefoxitin, cycloserine, fructose agar. So this is one of the most important selective medium used for Clostridium difficile. Why it is called as difficile? Because earlier it was believed that it is difficult to culture, hence it was named as difficile. Hence it is named as difficile, but later on we have developed many media by which Clostridium difficile can be isolated. So remember, culture is more sensitive but less specific. So toxin demonstration is the ultimate method to confirm the diagnosis. Toxin can be demonstrated by cell culture where you can demonstrate the cytotoxicity, like how you have done for diphtheria toxins, cytotoxicity in cell line. Apart from that, you can detect the toxin antigens by various enzyme immunoassay. That is, both toxin A and B can be detected. Similarly, PCR you can do to detect the tox A and B genes. Fine. So these are the various toxin demonstration methods. Colonoscopy to detect the pseudomembrane. This is again an important tool. They say that pseudomembrane demonstration is highly specific. Pseudomembrane demonstration is highly specific, but the sensitivity is low, maybe around 50%. Sensitivity is low. Histopathology, one more diagnostic tool is histopathology of colonic mucosa. This is again highly specific. This is again a highly specific tool for diagnosis. Okay, so this is all about the various diagnostic tools. Then we can discuss treatment. Treatment is again a very important aspect. They say that if it is an initial episode and if it is a mild infection, then the DOC is oral metronidazole. If it is recurrent, you know that pseudomembranous colitis is, the relapse is very common. 15 to 30% cases you will have relapse. Or even if it is severe, if the primary episode is severe, then also the drug of choice is, yes, vancomycin. Severe, complicated or fulminant cases, highly fulminant cases, vanco plus IV metronidazole. Okay, so this is how it is given. And please remember, prolonged use of vancomycin or metronidazole can cause pseudomembranous colitis. So it is one of the conditions where the drug of choice can produce the disease if you give for longer duration. Of course, fecal transplant is one of the remote alternate method what is in research now. Fecal transplantation. They say that the complete GI normal flora can be transplanted with fresh normal flora. This is one of the research aspect of Clostridium difficile what is in trial now. Okay, so this is all about Clostridium difficile. So let us now focus on non-sporing anaerobe. Non-sporing anaerobe, I will just summarize the important ones. You can classify the non-sporing anaerobe as gram positive cocci, gram negative cocci, gram positive bacillus and gram negative bacillus. Gram positive cocci like Peptococcus and Peptostreptococcus. They are non-pathogens. They hardly cause any infection. Gram negative cocci like Veillonella also is considered to be a non-pathogenic organism. Gram positive bacilli, you have various examples like Bifidobacterium, Eubacterium and Propionibacterium. These are the important gram positive bacilli. Apart from that, Lactobacillus, Mobilincus, and actinomyces. Actinomyces. So these are the 6 important gram positive bacilli. You can remember as two categories you can divide: bacterium, bifidobacterium, eubacterium and propionibacterium, and LAM stands for lactobacillus, actinomyces and mobilincus. So among this you can remember that lactobacillus is important for, is a normal flora of stomach as well as adult vagina. It maintains the vaginal pH, thus it will prevent infection. Stomach also, it maintains the acidity, thus it prevents infection. Actinomyces, again we will discuss later. It can cause various infections which will be discussed later. Mobilincus, along with Gardnerella vaginalis, it can cause bacterial vaginosis. Bacterial vaginosis along with Gardnerella vaginalis. So two important agents of Gardnerella vaginalis, two important agents of bacterial vaginosis. One is Gardnerella, other one is Mobilincus. Gram negative bacilli, yes, Bacteroides, Porphyromonas, Prevotella, Fusobacterium, and last but not the least is Leptotrachea. Okay, so a little bit of manifestation I will tell you, not much. Fusobacterium fusiformis. Can you tell me what it causes? Vincent angina, along with what? Which is the other agent of Vincent's angina? Borrelia vincenti. So along with Borrelia vincenti, it can cause Vincent's angina. Leptotrachea, they say that Fusobacterium fusiformis is otherwise, the new species, it has been reclassified as Leptotrachea. Fusobacterium has got various species. Among that, the fusiformis is reclassified as Leptotrachea. One more species is there of Fusobacterium, which is called as Fusobacterium necrophorum. This is the agent of Leimes syndrome, which is a thrombophlebitis like condition called as Leimes syndrome, which is nothing but a thrombophlebitis like condition. Okay, so Fusobacterium has got various species. Fusiformis can cause Vincent's angina, which is reclassified as Leptotrachea, whereas Fusobacterium necrophorum can cause Leimes syndrome. And of course, I have anaerobic cocci. What are the examples of anaerobic cocci I have told you? Anaerobic cocci like Peptococcus, Peptostreptococcus. These are normal flora. These are normal flora in female genital tract. Sometimes they can cause puerperal sepsis. Though they are normal flora in female genital tract, but sometimes they can cause puerperal sepsis. Coming to bacteroids. Bacteroids has a special importance among non-sporing anaerobe. Why? Because bacteroid is the most common anaerobe to cause infection. and surprisingly it is the most common anaerobe, I mean it is the most common organism, it is the most common commensal in your GIT. Please remember, if somebody will ask you which is the most common commensal in your GIT, is it E. coli? No. Among aerobe, of course, E. coli is the commonest commensal, but always in our GIT, anaerobes are much more in number than aerobes, and the most common commensal is Bacteroides fragilis. At the same time, it can cause human infection. It is the most common anaerobe to cause human infection. Of course, in GIT it doesn't cause infection, it is a commensal, but other places it can cause various infections, like it can cause brain abscess, it can cause sepsis, like that various widespread infections it can produce. Fine. And please remember, Bacteroides is gram negative, right? Is an example of gram negative anaerobe. So gram negative means endotoxin will be there. Please remember, the endotoxin of Bacteroides is less toxic. They say that it is less potent. Endotoxin of Bacteroides is less potent than the endotoxin of aerobic gram negative bacilli like E. coli. E. coli endotoxin is much more potent than Bacteroides endotoxin. Hence they say that Bacteroides, the complications are less compared to that of endotoxin produced by aerobic gram negative bacilli like E. coli. So that finishes your anaerobe. Now the next topic will be Mycobacterium. So we will discuss now about Mycobacteria, chapter number 3.6. So Mycobacteria are acid-fast organisms. This acid fastness is due to presence of mycolic acid in the cell wall as well as integrity of the cell wall. So these two are the reason why the Mycobacteria are acid fast. Okay, so you must be knowing the list of acid fast organism because it is a very important question in the entrance. So if somebody will ask acid fast organisms, it could be Mycobacterium tuberculosis, lepra, and non-tuberculous Mycobacteria. Nocardia, bacterial spore, 1 gram negative, that is Legionella magdae. Okay, this is also acid fast. Sperm head. Then there are various parasites which are acid fast, like the oocyst of Cryptosporidium, Isospora and Cyclospora. Okay, oocyst of Cryptosporidium, Isosporas, Cyclospora, all these are acid fast. Apart from that, other parasitic structures like Tinea saginata, egg and segments, okay, scolex, especially scolex. Then hooklet of hydatid cyst, hooklet of hydatid cyst is also acid fast. Fine. So these are the acid fast structures what you need to remember. So let us now focus on Mycobacterium tuberculosis. First we will discuss about M tuberculosis, then we will discuss about other part of Mycobacteria, that is NTM and Mycobacterium leprae. So there is something called as MTB complex, Mycobacterium tuberculosis complex. This complex includes the related species of Mycobacteria, Mycobacterium species which are genetically related. Genetically related to each other. Example. Example is Mycobacterium tuberculosis, bovis. These two are most important species under this. Apart from that, Mycobacterium africanum and microti. Microti and africanum. So they are genetically related, first point. Second is, all of them are known to produce pulmonary tuberculosis in man. These two are rare pathogen, whereas these two are common. MTB and bovis are the common pathogen to produce pulmonary tuberculosis in man. So what is the pathogenesis behind tuberculosis? Let us now focus on the pathogenesis, followed by manifestations, then laboratory diagnosis. Pathogenesis, as far as transmission is concerned, aerosol mode of transmission. Aerosol transmission is the principal mode of transmission. Aerosol transmission means around less than 5 to 10 micrometer droplets, aerosol droplets, or even dust particle contaminated with M. tuberculosis. And once they are inhaled, they say that they attack pulmonary macrophages via the antigen, that is lipoarabinomannan antigen. This is the M. tuberculosis surface antigen which acts as a receptor to enter into pulmonary macrophages. Okay, LAM antigen or lipoarabinomannan antigen. Lipoarabinomannan antigen. So once M. tuberculosis enters into lung macrophages, inside the macrophage, what is the mechanism of survival? Mechanism of intracellular survival. Once it enters into the macrophage, the mechanism of intracellular survival is nothing but by inhibiting the phagolysosome fusion. This is the most important mechanism and very frequently asked MCQ for you. Inhibits phagolysosome fusion. Inhibits phagolysosome fusion. Fine. So this is how the salient feature of pathogenesis, what you need to remember. Then coming to the clinical manifestation, broadly you have pulmonary tuberculosis and extrapulmonary tuberculosis. Okay, and pulmonary tuberculosis again can be divided into primary pulmonary tuberculosis, which occurs in children, and secondary pulmonary tuberculosis, or is also called as post-primary pulmonary tuberculosis, which occurs in adult. Okay, so what are the differences? Primary pulmonary tuberculosis occurs in children following primary exposure to M. tuberculosis. This occurs in adult following secondary exposure or reactivation of primary exposure organism. The organism which would have entered by through primary exposure, reactivation of the latent infection, reactivation of the latent infection. Otherwise, it could be a fresh secondary exposure. So primary pulmonary tuberculosis, say that it usually, the most common site is, it affects the upper part of the lower lobe, upper part of the lower lobe and lower part of the upper lobe. This is the interface, is the most common site. Upper part of the lower lobe and lower part of the upper lobe. So this interface is the most common site where it multiplies and produces a lesion. The lesion is called as Gons focus. Gons focus is the primary pulmonary tuberculosis lesion produced in lungs. The lymph node involvement is common, especially the hilar lymph node involvement is quite common, and Gons focus with the associated hilar lymph node involvement, together it is called as primary complex. Together it is called as primary complex. Sometimes associated calcification, the lesions can get calcified. Such calcified lesions, if the primary focus gets calcified, such calcified lesions are called as Ranke's complex. Ranke's complex. Okay, so this is all about primary pulmonary tuberculosis. Secondary pulmonary tuberculosis, I have already told, it occurs in adult, either following the secondary exposure of a new infection or reactivation of the latent infection due to the primary exposure. And here the difference is, here the site of involvement will be the apical lobe, apex. Okay, where it multiplies and produces various lesions like Aspen focus. Aspen focus will be the calcified lesion. Some more differences. Lymph node involvement is common in primary, whereas lymph node involvement is rare in secondary pulmonary tuberculosis. In contrast, the hematogenous spread is common. Hematogenous as well as direct invasion is common in post-primary or secondary pulmonary tuberculosis, and that leads to various lesions, and among that the most important is cavitations. Cavitations, necrosis, all these are quite common in secondary pulmonary tuberculosis. The most important MCQ they ask is about the cavitations. It is the cavitations are never a feature of primary, they are always a feature of secondary pulmonary tuberculosis. Okay, so these are the differences. Then coming to extrapulmonary tuberculosis. Extrapulmonary tuberculosis, again it depends upon the site of involvement. The most common site is PV lymph node. Lymph adenitis is the most common site of extrapulmonary tuberculosis. Second is pleural tuberculosis. This is the second most common site. Apart from the gastrointestinal tuberculosis, most commonly affecting the ileocecal region, ileocecal tuberculosis, pot spine, then tuberculous meningitis. This is quite an important complication in children. Cutaneous tuberculosis. There are various cutaneous manifestations like scrofuloderma, that is, it is a subcutaneous ulcer, okay, due to the breakdown of PV lymph node. Okay, leading to producing a subcutaneous ulcer. The lupus vulgaris. Lupus vulgaris is the most common TB skin lesion affecting females over the face, and characteristically it will produce an apple jelly nodule which has a tendency of squamous cell malignant transformation. It has a tendency of undergoing squamous cell malignant transformation. Okay, so these are the various list of extrapulmonary tuberculosis. And one thing what you have to remember is the extrapulmonary tuberculosis always it has increased risk in HIV infected people. In HIV infected people, there is always a higher risk of developing extrapulmonary tuberculosis. Then coming to the next important segment, that is laboratory diagnosis. Laboratory diagnosis of tuberculosis, first part is the specimen collection. This again depends upon the site of involvement. As far as the pulmonary tuberculosis is concerned, ideally you have to take 2 sputum specimens. At least two sputum specimen early morning and spot sample. Spot sample as soon as the patient attends you, and again you have to ask the patient to come in the next day morning to collect the early morning sputum sample. Okay. And apart from that extrapulmonary tuberculosis, the specimen would be depending upon the site of involvement. Like in case of meningitis, it could be CSF. Genitourinary tuberculosis, it could be urine. So like that, based upon the site, you can collect various specimens. Once you collect a specimen, the first part is you will do a digestion, especially the sputum specimen. You will do a digestion and decontamination. This is particularly it is important for sputum specimen. Why digestion? Because you have to digest the macrophages and the polymorphonuclear cells so that the TB bacilli will be released out. To release the TB bacilli outside, digestion of the macrophages and the polymorphonucleases. Why decontamination? Because to inhibit the normal flora, so that it will helpful in the culture of tuberculosis. So this is done by using 4% sodium hydroxide, which is popularly called as Petroff's method. Petroff's method. Else you can use N-acetylcysteine method, NALC. This also can be used, N-acetylcysteine method. Okay, so these are the methods to do the digestion and decontamination of the sputum specimen. Once it is done, the third will be the microscopy, smear microscopy. This is most commonly done by Gill-Nielsen method, Gill-Nielsen acid-fast staining method, and this is done, I hope you all would have done in your second year, acid-fast staining. How it is done? It is done by, you have to make a smear, first you have to add strong carbonyl fusion, with intermittent
heating, and once it is done, you have to add 25% of sulfuric acid. 25% of sulfuric acid. With this act as a decolorizer. Followed by, you have to add methylene blue as a counter stain. Methylene blue is used as a counter stain. So there are certain modifications. They say that you can use Kinyon's method. Kinyon's cold acid fast staining method. Here they say that intermittent heating is not required. Hence it is called as cold acid fast staining method. There is no need of intermittent heating. Instead of 25% of sulfuric acid, you can use acid alcohol as a decolorizer. Acid alcohol as a decolorizer can be used. This is very much useful for renal tuberculosis, because in urine sample and urine specimen there is a commensal called as Microbiology smegmatis. This is a commensal in the urine specimen. So this has to be differentiated from AMTB in suspected case of renal tuberculosis, which is a pathogen. So this can be differentiated by using acid alcohol as a decolorizer. The reason is AMTB is acid fast as well as alcohol fast, whereas M. smegmatis is only acid fast but not alcohol fast. That is how you can differentiate. Okay, so this is called as Kinyon's acid fast staining, and the second one is acid alcohol is used for renal tuberculosis. The third modification, you can do one more acid fast staining method, that is fluorescence staining method. You can use auramine rhodamine staining method. Auramine rhodamine staining method is a fluorescence staining method, and tuberculosis appears to be fluorescent, brilliant green color. Brilliant green color. Okay, and this has an advantage that it is rapid, as the smear screened under low power field. Whereas in the conventional acid fast staining method, whether you use a Kinyon's method or whichever method, you have to screen the smear under oil immersion field. Whereas in the auramine rhodamine staining method, you are screening under low power field. Hence, it is faster. It is a more rapid method than the conventional method. Okay, can you tell me what is the appearance of M. tuberculosis in the acid fast staining? M. tuberculosis under acid fast staining appears as, yes, three important words: long, slender, beaded appearance. Long, slender, beaded appearance. Okay, so this is the particular appearance what you need to remember. Now you tell me what is the advantage and what is the disadvantage of smear. Smear has the advantage that it is faster. Especially when you compare smear with culture, it has a definitive advantage that it is much faster. But the disadvantage is it is less sensitive than culture. It has a detection limit of at least 10,000 bacilli per ml. Minimum this much bacilli should be there in the sputum or in any specimen to be detected by acid fast staining. So this is a huge drawback of smear. However, it has the advantage that it is faster. And you can do RNTCP grading of the sputum smear, and this is used to grade the sputum smear from 3+ to scanty. 3+, 2+, 1+, then scanty. This grading is useful. It has various uses to assess the severity of infection. Higher the grade, more severe is the disease. As well as to monitor the treatment response. Following the treatment, if the grading falls down from 3 plus, if the grading falls down to 2 plus or 1 plus following treatment, then it indicates that the patient is responding to the treatment. And also to assess the infectiousness of the patient. They say the higher the grade, more is the infectiousness, more is the transmission to other patient. Minimum 10,000 bacilli. This is the minimum load to transmit the infection. So the patient to be infectious, minimum he should have 10,000 bacilli per ml in the sputum specimen. Below which, though the patient is having the organism, but he is non-infectious. Okay, so these are the usefulness of RNTCP grading of the sputum smear. Fine. So let us now focus on the culture. Now we discussed about the smear. What about culture? Culture, most commonly used culture method is Elgin medium, Lowenstein-Jensen medium. Lowenstein-Jensen medium. Definitely, the culture has the advantage of more sensitive. It is considered as a gold standard method because it is more sensitive and the detection limit is lesser than that of smear. As low as 10 to 100 viable bacilli. If it is that, then it will be culture positive. Please remember, viable bacilli. So the viability is another advantage of culture. If the organism grows in culture, that means it is viable organism. Whereas in smear, even the dead bacilli also can be seen in smear. So you may not know whether the organisms, whether the acid-fast bacilli in the sputum sample are really live or they are dead bacilli. Whereas culture always detects viable organisms. So this is again an advantage of culture. But culture has a huge drawback. The drawback of culture is that it is time consuming. 6 to 8 weeks of incubation is needed to say that it is culture negative. Minimum 6 to 8 weeks of time required for the organism to grow in culture. So this is a huge drawback of culture. Okay. So can you tell me what is the appearance? MTB in Elgin medium appears as rough, tough and buff colony. The colony appears as rough, tough and buff. Okay, so this is a particular appearance what you need to remember. So the drawback is time consuming. It takes so much of time, 6 to 8 weeks of time to grow in culture. That is why instead of conventional Elgin medium, there are various automated culture systems available now. Automated cultures like Bactec, Bacteriology, Midget. All these automated culture method has the advantage of it can detect the growth in 2 weeks. Around 2 weeks it will detect the growth. Not even 3 weeks. Just 2 weeks it can detect the growth. Among this, the most important is Midget. It is quite promising. Midget is mycobacterial growth indicator tube. Mycobacterial MGIT, mycobacterial growth indicator tube. It is a fluorescent based detection system. Not only it detects the growth, apart from detecting the growth, it also detects the resistance to the first line anti-tubercular drugs. The first line anti-tubercular drug, the resistance can be detected by MIGIT. So this is another advantage of mycobacterial growth indicator tube or MIGIT. Okay, it is a very important device. Fine. So apart from that, there are various molecular methods of diagnosis. Molecular method, you can go for PCR to detect MTB specific gene. MTB specific gene, like for example IS6110 gene. This is a gene which is specific for Mycobacterium tuberculosis complex. Okay, so this is quite promising, especially for extrapulmonary specimens. Okay, next is you can go for, there is a newer device which is available called as Gen probe. Okay, line probe assay. Okay, all these are DNA probe based method. Then the best available automated instrument is Gene Expert. Gene Expert is quite promising now. It is the recommended test for diagnosis of tuberculosis because it gives result in 2 hours time. Less than 2 hours it will give the result. Not only it will detect the growth, but also it detects the resistance to rifampicin. Resistant to rifampicin. Okay, so it is also quite promising. It is based on real-time PCR technology. It is based on real-time PCR technology. Fine, so these are the various methods of diagnosis of tuberculosis. Now I will tell you how to diagnose latent tuberculosis. Latent TB is diagnosed either by tuberculin test or by recently described IGRA method, that is interferon gamma releases. IGRA, interferon gamma releases. So first let us discuss tuberculin test. Tuberculin test is a conventional method to diagnose latent tuberculosis. Okay. Otherwise, it is done by the most common technique called as Monto technique, Monto test. It's an example of demonstrating hypersensitivity type 4 reaction. Okay, where you are injecting 0.1 ml of PPD antigen. PPD stands for purified protein derivative antigen. It is a crude preparation of M. tuberculosis. This you are injecting intradermally into the forearm. Okay, and you are taking the reading at 72 hours, and this is taken by measuring the induration. At the site of inoculation, you have to measure the width of the induration. The induration will be surrounded by erythema. But please remember, you should not measure the erythema. You have to measure only the induration. If the width of the induration is more than 10 mm, it is taken as positive. 6 to 9 mm, equivocal. Less than 5 mm, considered as negative. So then the question is, if it is positive, indicates what? It indicates latent tuberculosis, not active tuberculosis. Please remember, Monto test, if positive, that is more than 10 mm. In adult, it indicates latent or past infection. Hence, it is used as an epidemiological marker to calculate the prevalence and incidence of infection in a locality. It is the best epidemiological marker of tuberculosis. However, it doesn't speak about diagnosis in adult because it indicates only past infection. It cannot differentiate between active and past infection in adult. In contrast, in infant, Montauk test plays a very important role because it indicates active infection. Hence, it is used as a diagnostic marker in infant. Okay? There are false negative as well as false positive Montauk tests. False negative Montauk tests can be seen in miliary tuberculosis, early or advanced tuberculosis, in HIV infected people, as well as post measles. Following measles also the CMI falls down, hence the Montauk test will become false negative. Okay, so these are the origin for Montauk test. There are various false negative reactions. Similarly, there are various false positive conditions also where Montauk test will be falsely positive. Example, following atypical mycobacteria and following BCG vaccination. After BCG, after 8 to 14 week of BCG vaccination, Montauk test will become false positive. So these are the conditions you have to remember so that the Montauk test interpretation can be done properly. Okay. So to avoid false positive conditions, there is another method of latent tuberculosis which is called as IGRA. IGRA or interferon gamma release assay. This is one more method of diagnosing latent tuberculosis. It is also quite promising. It has the advantage that it doesn't have false positive conditions because it uses highly specific MTB antigen. That is, there are two antigens used, EZ6 and CFP10. EZ6 stands for excretory secretory antigen 6 and CFP10 stands for culture filtrate protein 10. So these two antigens are highly specific MTB antigen and it is a in vitro test compared to the Montauk test which is in vivo test, whereas IGRA is in vitro test. You have to collect the T lymphocyte from the patient. The peripheral T lymphocyte is collected from the patient. From the patient the blood is taken and the T lymphocytes are extracted and they are subjected to highly specific MTB antigen. This highly specific MTB antigen, they are exposed to this peripheral T lymphocyte of the patient. It is a ELISA based method or ELISpot based method. ELISA or ELISpot based methods are available. So T lymphocyte you have to collect and you do subject in vitro with the highly specific MTB antigen. Now, following which the T lymphocyte will start secreting interferon gamma, and this interferon gamma has to be measured. You have to measure the level of interferon gamma. If it is more, then it indicates that the person has a past exposure to MTB. Indications are same. Interpretation is same as tuberculin test. That is, in adult, past infection, marker of prevalence, epidemiological marker. In infant, active infection, marker of diagnosis. Okay, but the advantage is it uses highly specific MTB antigen. One difference. Second difference is it is an in vitro method. Third difference is because it uses highly specific MTB antigen, So there is no false positive condition. That is, the atypical mycobacteria and following BCG vaccination, in these two conditions, IGRA will be negative. IGRA will be negative, whereas Monto test will be false positive. Monto test will be false positive. So this is the advantage of IGRA than the Monto test. Fine. So now we will discuss a bit about BCG. BCG is the recommended vaccine for tuberculosis, bacilli, Calmette and Guerin. So the Calmette and Guerin are the two scientists who had used Mycobacterium bovis to prepare the BCG strain. So the BCG strain is nothing but it is a live attenuated Mycobacterium bovis strain, and they have subcultured the strain in a medium called as bile potato glycerol medium. So this is the medium which is used to subculture the BCG strain to make it live attenuated. And in India the BCG vaccine is prepared. Where is the BCG lab located in India is Guindy of Chennai. And we use the Danish 1331 strain of Mycobacterium bovis. This is used in, so it is a WHO recommended strain. It is a WHO recommended strain what is being prepared in the BCG lab Chennai. Okay. Then how it is given? What are the indications and what are the contraindications and how it is given? BCG is given by intradermal route. First of all, you have to remember that it is available in lyophilized form. BCG is available in lyophilized form. You have to reconstitute by mixing with normal saline. It is reconstituted with normal saline. Please remember, not distilled water. It is reconstituted with normal saline, and once it is reconstituted, it should be given within 1 hour. It is given by intradermal route above below the insertion of left deltoid. Below the insertion of left deltoid. And 4 to 8 weeks, within 4 to 8 weeks, the baby will develop a uniform, tiny, healthy scar. So this denotes that the site of inoculation is proper. Intradermal route has been used and it is properly inoculated. Then only this uniform, tiny, healthy scar will be produced within 4 to 8 weeks of inoculation. Then indication and contraindication. BCG is indicated. There are two methods of indications: direct BCG and indirect BCG. Direct BCG is given in high prevalence area, like in India. It is directly given at birth. Whereas low prevalence area, like the Western countries where the TB prevalence is low, in such case BCG is given at 1 year after performing the Monto test. If the Monto is negative, then only the BCG is given. Otherwise the BCG is not given. So these are the two indications for BCG. And if not given at birth in India, then it can be given maximum up to 2 years. After that there is no need to give BCG vaccines. Why? Because it is expected that by 2 years the baby will have exposure to environmental and mycobacteria, following which he will develop the natural immunity. So BCG should be given at birth in India. If not given, then maximum up to it can be given up to 2 years, but not beyond 2 years. No need to give beyond 2 years. Contraindications. Contraindication of BCG include, they say that the child having generalized eczema, then if the mother is AB positive, and if the child is a HIV infected baby. So these are the three conditions where BCG vaccine is contraindicated. Fine. If the mother is AB positive, what are the indications and what are the contraindications? Another question what they frequently ask. If the mother is AFB positive, then what are the do's and what are the don'ts? Don'ts will be, do not give BCG. Just now we discussed. Do not give BCG to baby. Do not separate the baby from the mother. And do not stop breastfeeding. Fine. Whereas the do's will be, you have to start ATT to mother, give INH prophylaxis to the baby, and screen the household contact for presence of tuberculosis. Okay, so now we will discuss about atypical mycobacteria or non-tuberculous mycobacteria. According to Runion's classification, the atypical mycobacteria can be classified into four groups: photochromosome, non-chromosome, and rapid grower. Photochromosome, as the name says, these mycobacteria will produce pigmentation only in light, not in dark. Scotochromosome, they will produce pigmentation in light as well as in dark. Non-chromosome, there is no pigmentation at all. And rapid grower, the definition is they will grow within 1 week, in contrast to M. tuberculosis, which takes 6 to 8 weeks of incubation to grow. Examples: photochromosome, the examples can be abbreviated as MASC, that is Mycobacterium marinum, Asiaticum, Simiei, and Kansasi. Okay, and the examples of scotochromosomes are abbreviated as SSG, stands for Mycobacterium scrofulaceum, Sulgite, and Gordon. Fine. Non-chromosome includes Mycobacterium ulcerans, very important, and Mycobacterium avium complex, avium intracellular complex. Whereas rapid grower are those organisms which grows less than 1 week includes Mycobacterium shilloni and fortuitum. Okay. Now I will tell you some of the important diseases produced by atypical Mycobacterium. The most important is Mycobacterium marinum, which is the agent of fish tank granuloma, or also called as swimming pool granuloma. Fish tank granuloma or swimming pool granuloma. Mycobacterium kansasi, it produces a pulmonary lesion resembling pulmonary tuberculosis. The lesion resembles pulmonary tuberculosis. Scrofulaceum, as the name says, it can produce scrofules, which are nothing but subcutaneous ulcers. Gordoni is a tap water commensal. It is a commensal in the tap water. Ulcerans is the agent of the most important MCQ, Burulis ulcer. Burulis ulcer. You all know that Mycobacterium avium complex, it can cause opportunistic infection. This opportunistic infection is common in HIV infected people. Shilloni and fortuitum, they are rapid grower, and these rapid growers, they are known to produce post-trauma injection abscess. Shilloni and fortuitum, they are known to produce post-trauma injection abscess. So this is all about the various important atypical Mycobacteria and the important questions associated with them. Fine. So let us now focus on Mycobacterium lepra, the third Mycobacteria which is important for exam. Mycobacterium lepra or Hansen's bacilli. You know that leprosy is an ancient disease, very old disease, and for ancient days it is a social stigma. Leprosy patients are always socially outcasted, having a false belief that they can transmit the disease efficiently. Hence, we should not go near to the lepra patient. In contrast, the real fact is, it is a very low communicable disease. The transmission is extremely low. The person-to-person transmission is extreme. They say that 5% of spores after staying 5 years together can transmit the disease. After 5 years of staying together, only 5% of the spores can transmit the disease. So that indicates that the communicability is extremely low. In contrast, it is a social stigma. We have a false belief that we should not go near to the leprosy patient. Fine. So let us now discuss. It has an incubation period of They say that after 2 to 5 years the disease will appear. The clinical manifestation appears only after 2 to 5 years. So it is a long, one of the bacteria having longest incubation period. The disease can be classified. There are various classifications to describe leprosy. Basically there are 3 classifications. Ridley-Joplin classification is the oldest and the most famous, most widely used classification. Apart from that, there is a Madrid classification and there is an Indian classification. Whichever classification you use, the basic formula is there are various categories in each classification, and the categories are bipolar. They say that leprosy is a bipolar disease. So based upon the cell-mediated immunity, the categories have been classified, and the two extreme pole of the category will be lepromatous leprosy and tuberculoid leprosy. So these two are the extreme poles: lepromatous leprosy and tuberculoid leprosy are the extreme poles of classification. In between you have certain borderline variety. In Ridley-Joplin classification, the borderline variety are classified as lepromatous borderline leprosy, borderline leprosy, and tuberculoid borderline leprosy. So there are five categories in Ridley-Joplin classification: lepromatous leprosy and tuberculoid leprosy are the extreme poles. In between you have lepromatous borderline leprosy, borderline leprosy, and tuberculoid borderline leprosy. In Madrid classification, in between you have indeterminate variety and borderline variety. These two are the thing what is there in between. So there are total 4 stages. Indian classification again same two are there, that is indeterminate and borderline variety. Apart from that, it has one more variety called as pure neurotic variety. So there are 5 stages in Indian classification. First 4 are same as Madrid, plus the 5th one is pure neurotic variety. Okay, so this is the classification. Let us now discuss the differences between the two extreme poles, that is lepromatous leprosy and tuberculoid leprosy.
Okay, so the differentiating features between lepromatous leprosy and tuberculoid leprosy. LL is always multibacillary, having bacteriological index around 4 to 6, whereas TT is paucibacillary, having bacteriological index of 0 to 1. The skin lesions in LL is always multiple, many skin lesions, and they are symmetrical. Margin is irregular, and many variations, many variety of skin lesions are seen, like multiple nodules which are described as lepromata. One of the variety is plaque. All these are the variety of skin lesions seen in LL patients: plaque, xanthoma like papules, leonine facies. Okay, so all this, even eyebrow alopecia. So these are the various cutaneous manifestations seen in LL patients. In contrast, TT lesions are few. Of course, they are asymmetrical with a sharp margin. Okay, and always there is a tendency of central clearing. There will be a tendency of central clearing. Fine. So coming to the other differences between TT and LL. Nerve involvement. The nerve involvement is always early in TT, whereas late in LL. They say that early anesthetic lesions will be there in skin. Skin lesions will have early anesthetic lesions as well as thickened nerve. The most common nerve to be affected is ulnar nerve, followed by next common is post auricular nerve. Nerve abscesses are also seen. This is important in BT, borderline tuberculate variety. Okay, so these are the cutaneous and nerve manifestations. Next is the CMI and AMI. They say that CMI, LL it is low, TT it is normal, and because CMI is low, lepromin test is negative in LL whereas it is positive in TT. In contrast, the humoral immunity or AMI, antibody mediated immunity, TT it is again normal whereas LL it is exaggerated. You will have various autoantibodies will be elevated in LL. That is why VDRL often becomes biological false positive. Biological false positive VDRL is quite common in LL. Okay, so these are the other differences. Then apart from that, they say that macrophages in LL it will be foamy type, foamy or lipid laden macrophage, whereas in TT the macrophages will be epithelioid type. Langhans giant cell, this is again a type of dendritic cells which are absent in LL but they are seen in TT. So these are the differences between LL and TT what you need to remember. Anyway, so these are the manifestations. Sometime you will have deformities. Deformities are also important in leprosy. They say that 25% of untreated individual, they go for various deformity. And the most common deformities include in face, you of course I have already told leonine faces, sagging of face, eyebrow loss of eyebrow, all this will be there. Hand ulnar nerve will be affected, you will have claw hand, wrist drop, feet, again foot drop, okay, plantar ulcers, all these may be there. Corneal opacity. Can you tell me why these particular areas are involved? They say that leprosy, M. lepra has a tendency to affect the colder area of the body. They say that it has a tendency to affect the colder area of the body, like anterior eye, testis, then the cold skin. So all these are the various areas, and also the nerves are the various areas which are particularly affected by M. lepra. Fine. So these are the various deformities. Now I will tell you something about lepra reaction. Lepra reaction is of two types, lepra 1 and lepra 2. Lepra reaction 1 is hypersensitivity reaction type 4, whereas the lepra reaction type 2 is hypersensitivity reaction type 3. The code is, if you add both it should become 5. 1 plus 4 equal to 5, 2 plus 3 equal to 5. So like that you need to remember. Type 2 lepra reaction is seen in LL patient. Lepra reaction type 1 is seen in borderline patient. Borderline patient, following treatment, they may go towards LL or they may go towards TT. Following the treatment, the borderline patient may progress towards LL or they may improve towards TT. Accordingly, it is called as reversal reaction or downgrading reaction. Either they will downgrade towards LL or they will upgrade, or the reversal reaction will take place towards TT. Okay. So, following treatment, they will either upgrade or they will downgrade, and they say that here the drug of choice is glucocorticoid. Glucocorticoids are the drug of choice, and of course the Th1 cells, they play important role in lepra reaction type 1. In contrast, lepra reaction type 2 is also called as ENL. ENL stands for erythematous nodosum leprosum. It is called as ENL, and they say that it is usually seen in LL patients. LL patients are multibacillary or paucibacillary? LL patients are multibacillary. So, in a multibacillary leprosy, following dapsone treatment, they say that when you start dapsone in a multibacillary leprosy, all of a sudden the organism will be destroyed and the antigens will be released. Enormous antigens will be, lepra antigens will be released. They will bind to the corresponding antibody, and the antibody antigen complexes, they will be deposited in various places. They will be deposited in various places. Usually they will be deposited in skin to produce nodular lesions, which are called as ENL or erythematous nodosum leprosum. Apart from that, even the other organs are affected, like eyes, testes, kidneys. All these are the various other organs will be affected in lepra reaction type 2, whereas lepra reaction type 1, the other organs are usually not affected. And as far as the drug of choice is concerned, of course glucocorticoid is given first. If it fails, then thalidomide is given, and clofazimine also is an alternate drug which is considered here. And here Th2 cells predominant. Th2 cells usually predominant in lepra reaction type 2. Th1 in 1 and Th2 in 2. Easy to remember. Fine. So, these are about the lepra reactions. Now, we will discuss about epidemiology. Leprosy, as I told you, it is a bipolar disease. The source of infection is usually multibacillary, that is, multibacillary means TT or LL? Multibacillary, that is LL and sometimes BL cases. They are the most important source of infection. Transmission is concerned, nasal droplet is the most common mode of transmission, followed by contact, followed by direct contact. Rare mode of transmission will be breastfeeding, vertical mode, and even tattooing. All these are rare mode of transmission. Most common mode is nasal droplet. They say that nose will be having a higher bacillary load, and the nasal droplet transmission is the most common transmission. As far as communicability is concerned, leprosy is not highly contagious. As I told you earlier, it is not a highly contagious disease. You need intimate contact. intimate and prolonged contact is required. They say that one proverb is that they say that after 5 years of staying together, only 5% of spouse will get leprosy. So it's not highly contagious disease. Unlike the social stigma which says that it is highly contagious and you should not go to the leprosy patient, but it is totally different than that. Fine. So this is about the transmission and the source. Then coming to the geographical distribution. Currently the leprosy is exclusively confined to developing nations, mainly in Asia and also in Africa and Latin America. India of course accounts for highest number of cases. Highest number of leprosy cases they reside in India. But of course, you know that the leprosy elimination status, they say that the country is said to be leprosy eliminated if the prevalence is less than 1 per 10,000 population. If the prevalence is less than 1 per 10,000 population, then this is said to be the country is eliminated for leprosy. India also is said to be leprosy eliminated. The current prevalence in India is 0.68 is the current prevalence of leprosy in India. They say that among all the states, only few states like Chhattisgarh, and Bihar also is recently been eliminated. Dadar and Nagar Haveli, this is a union territory. So Chhattisgarh and Dadar and Nagar Haveli are the only state or union territory which remains above the 1, that is more than 1 per 10,000 is only present in these two states, that is Chhattisgarh and Dadar and Nagar Haveli. It was Bihar before, now Bihar, Orissa all are under 1. And overall in India the leprosy elimination status is 0.68. Okay. So this is about the geographical distribution of leprosy. Coming to laboratory diagnosis. Yes, smear microscopy. You know that leprosy is not lepra bacilli is not cultivable. So the most important tool of diagnosis is smear microscopy. Okay, please remember the totally 6 specimens are collected, 4 skin specimen, then 1 from ear lobe and 1 from nasal mucosa. Okay, and the skin specimens are collected by a method called as slit skin smear technique. This is a technique followed to collect the skin specimen. And please remember the edge of the lesion, the specimen is collected from the edge of the lesion, not from the center. Okay. So the specimens are subjected to modified gel stain by using 5% sulfuric acid. How much for tuberculosis? 25%, whereas for lepra it is 5%. And the description is like this, very easy to remember. M tuberculosis stays separately, scattered, whereas M lepra stays united, jointly. So this is the difference what you have to remember. M lepra, the description is the bacilli are arranged in parallel rows of cigar like bundle. cigar-like bundles of acid-fast bacilli. And the cigar-like bundles of acid-fast bacilli, they reside, they are mixed with lipid material. The cigar-like bundles of acid-fast bacilli are often mixed with lipid material to produce globi. These are called as globi. Globi are nothing but cigar-like bundles of acid-fast bacilli mixed with lipid material. And these globi are usually present inside a foamy macrophage, lipid-laden macrophage. And the foamy macrophage is called as vitreous lepra cell. The foamy macrophage is called as vitreous lepra cell. So this is a typical description of M. lepra under microscopy, what you need to remember. And there is a point of difference. How can you differentiate live and dead bacilli? Because if you do a smear microscopy, everything will be dead. So how can you differentiate originally the organism was live or dead? They say that the live bacilli will be uniformly stained. This is one important feature, with parallel sides and rounded end, and length is 5 times the width. So this is a typical description of live organism, whereas dead bacilli will be irregular, non-uniformly stained, and they are often fragmented and granular in appearance. See, this is a very important tool, because the leprosy patient, even if they will improve after the treatment, if you take a skin lesion, organisms will be there. So you will often confuse it, they are responding or they are not responding. So this is the differences. How will you make out the organism is a live organism or a dead organism? Okay. And of course you can grade by two methods: bacteriological index and morphological index. Bacteriological index is the total bacilli per field, whether live or dead, irrespective. Morphological index is the total, the percentage of uniformly stained bacilli. So that is why the morphological index is more meaningful. It is more meaningful in assessing the response to treatment. Okay, so all this is about the direct microscopy. Other than that, second is about culture. The answer is it is not cultivable. What are the animal we use? Repeat. Armadillo, 9-banded armadillo, and footpad of mice. Footpad of mice. Other than that, antibody detection, not very useful. You can do fluorescent lepra antibody absorption test, FLA-ABS, fluorescent leprosy antibody absorption test. You can also do a ELISA detecting antibody to phenolic glycolipid 1 antigen, PGL1, phenolic glycolipid 1 antigen. Antibody detection is not much useful. It is the best tool of diagnosis is always a microscopy. We always rely on microscopy. Then coming to lepromin test. Lepromin test is a method to detect whether your CMI is intact or not. This is again a very important aspect for your MCQs. Lepromin test is it is similar and it is dissimilar to the tuberculin test. In some points it is similar. Like for example the procedure. The procedure is again 0.1 ml of lepromine antigen injected intradermally. The reading, here you take two reading, one you take at 3 days, one you take at 3 weeks, that is 21 days. The 3 days reading is early reading or Fernandez reading, and this is nothing but you are going to look for induration like what you do for tuberculin test reading. The late reading or the Mitsuda reading, here the induration will not be there. Instead of that you will have necrosis, ulceration and nodule formation. And the late reading is the nodule of more than 5 millimeter is considered as positive, and the late reading, if it is positive, it indicates intact CMI. The CMI is intact. And please remember, the interpretation of lepromine test, interpretation of tuberculin test in adult, it is a prevalence marker. Tuberculin test in infant, diagnostic marker. In contrast, lepromine test is neither a prevalence marker nor a diagnostic marker. It is just a marker of CMI. And also it is used to classify the lesion, and also is used to assess the prognosis. So these are the uses of lepromine test. If the lepromine test if the test is positive, indicates intact CMI, indicates TT, indicates prognosis good. If the test is negative, indicates low CMI, which indicates it may be LL case, which indicates bad prognosis. So this is the interpretation of lepromine test, to assess the intact CMI, to classify the lesion and to assess the prognosis. Fine. Then coming to treatment. Leprosy patient, the treatment depends upon whether it is a paucibacillary case or it is a multibacillary case. This is again a very important aspect. You have to classify. How can you classify it is a pauci or multi? Just like that you cannot classify, there are some criteria. They say that skin lesion 1 to 5 is considered as paucibacillary, 6 or more is considered as multibacillary. Nerve involvement, only one nerve involvement is called as paucibacillary. 2 or more is considered to be multibacillary. It should be smear negative. You do a microscopy, it should be smear negative, whereas multibacillary is smear positive. We know that TT is a paucibacillary, LL is multibacillary. Other than that, they say that BT and indeterminate, all these variety are paucibacillary. Whereas multibacillary LL, BL, BB, all these variety are considered to be multibacillary. Fine. So these are the differences. So accordingly the treatment regimen. So once you classify it is pauci or multibacillary, accordingly the treatment regimen will vary. How it will vary? Paucibacillary, the treatment is, yes, Possibly the treatment is dapsone daily plus rifampicin monthly under supervision, whereas multibacillary same plus you have to add clofazimine. And duration possibacillary is up to 6 months, multibacillary up to 1 year, or till the patient becomes smear negative. Then follow-up is done for 2 years, whereas here it is done until 5 years. Okay, so this table is again very frequently asked exam questions, very frequently asked. Okay, so leprosy, though it is going to be eliminated from the world, in India it is already eliminated, but from MCQs it is not eliminated. It is quite frequently asked topic in exam. Enterobacteriaceae. Okay, so family Enterobacteriaceae, there are various organisms, and all these organisms, they have a family property. They have a family or property of, all organisms under this family are gram-negative bacilli. They are non-fastidious, they can grow in any medium, ordinary medium. They are catalase positive, oxidase negative. They are nitrate reducer and glucose fermenter. At least they will ferment glucose, plus or minus other sugars, but glucose all will ferment. Okay, so other than that they are motile with the exception of Klebsiella and Shigella, which are non-motile. And of course you all know that they are facultative anaerobe. There are some exceptions to this family. The most important exception is catalase. All our catalase are positive except Shigella dysentery type 1, which is catalase negative. Similarly, all are oxidase negative except Plesiomonas, which is a recently introduced organism into this family, which is supposed to be oxidase positive. Okay, so these are the exceptions to family Enterobacteriaceae. Fine. So based on lactose fermentation on McConkey agar, you can classify Enterobacteriaceae into lactose fermenting, non-lactose fermenting, and late lactose fermenting. Lactose fermenting you have E. coli and Klebsiella. Non-lactose fermenting others. The E. coli and Klebsiella will produce pink colony on McConkey. Others will produce pale or colorless colony. They are NLF. Example: Proteus, Shigella, Salmonella, Yersinia. Okay. Late lactose fermented, the most important example is Shigella soni. Shigella soni, which ferment lactose after 2 to 5 days of incubation. Hence, it is called as late lactose fermenter. So let us directly start Escherichia coli. E. coli is one of the important human pathogen, and it can produce variety of manifestation. UPEC, that is uropathogenic E. coli, is a strain that produces UTI. UPEC, uropathogenic E. coli. Similarly, the diarrheogenic strains can produce diarrhea. Apart from that, there are various pyogenic strains. Pyogenic strain can cause skin soft tissue infection. They can cause meningitis, various pyogenic infection, wound and soft tissue infection, meningitis, bacteremia, like that various pyogenic manifestation. So let us now discuss, these are the two important E. coli strains that are very frequently asked in the exam. Let us discuss one by one. First we will discuss uropathogenic E. coli. Uropathogenic E. coli is the most common agent of UTI. Approximately, they say that maybe 60 to 70% of, around 70% of strains are 70% of UTI is, of course, even more than that is due to uropathogenic E. coli. There are two kind of manifestations. They say that they can produce lower UTI, they can also produce upper UTI. Undoubtedly lower UTI is more common. The root is, lower UTI, the root is ascending infection. Ascending route, the E. coli can, the perianal E. coli can migrate in the urinary tract to cause ascending UTI. Upper UTI, again ascending is the most common route. So the perianal E. coli, if they migrate to infect bladder, they will produce lower UTI. Further migration to the kidneys, they can cause upper UTI. Followed by even the descending route also can cause upper UTI. Usually the descending route means via the hematogenous route. Example, there are various organisms like Staph aureus or Candida, like that there are various other organisms other than E. coli which also can cause descending UTI. By definition, lower UTI, you will have cystitis, urethritis. Upper UTI, you will have pyelonephritis. Pyelonephritis. As far as the virulence factor is concerned, E. coli virulence factor is concerned, lower UTI, the fimbria producing strain. Because you know that if you want to do a ascending infection, you should have organ of adhesion which will adhere to the urethral epithelium. So for that, the fimbrial producing strains like various fimbria like P. fimbria or mannose resistant fimbria, all these are the various fimbria that are produced by E. coli that will cause ascending infection. Whereas descending infection, capsular strains, usually the capsular strains can cause descending infection. Fine. So these are the differences between upper UTI and lower UTI. Coming to lab diagnosis. Of course, predisposing factor you all know, so I am just briefing you. Females are always having higher risk. Why? Why females are always higher risk of UTI? Because of short urethra and proximity to anus. The urethra is quite accessible to anus, closely placed to anus. Apart from that, pregnancy you will have urinary stasis because of pressure by the fetus. So catheterization, all these are the various predisposing factors. Coming to the laboratory diagnosis, the most common, if you talk about specimen, the most common specimen is midstream urine, most common specimen. Ideal specimen will be suprapubic aspiration. Suprapubic aspiration is important for coma patient, infants, where you cannot collect the urine sample. And they say that catheterized patient, if the patient is under catheter, how to collect the sample? Yes, catheterized patient, you have to collect the sample from the tube, not from bag. Please remember why? Because E. coli can grow in urine sample. They say that urine is a good culture medium. In the bag, if you leave the bag for some time, E. coli can grow and will become more in number. Okay, hence always you have to collect the specimen from the tube. Fine. So after the sample collection, what you can do is you can do the initial screening. Initial screening is done by wet mount. You can do a wet mount to look for pus cells, bacteria. Gram stain can be done. Nitrate reduction test. All these are done initially for screening, because in certain labs where more urine samples will be there, 150, 200, 500 samples will be there. It is difficult to do a culture for everything. Hence, they follow the screening of urine sample. Only few suspected specimen only they will do culture. Other specimen they rule out based on the screening. Leukocyte esterase tests. All these are the various screening method to be followed first. Followed by you can do a culture. Culture, they say that you can use combination of blood agar and McConkey, or clay agar is used. This is quite popular. Clay agar is a specific medium used for urine specimen. Cysteine, lactose, electrolyte deficient agar. Okay, clay agar is a preferred method when you have a heavy sample load. Okay, so now the question is, if E. coli will grow in culture, it may be a pathogen, it may be a commensal, because you know that E. coli is a normal commensal in the perianal region, in the urethral tract. So while you collect the specimen, of course midstream urine you have to collect, but there is always a chance that midstream urine, the patient may not follow your instruction and it may get contaminated with the periurethral E. coli. So if tomorrow E. coli grows in culture, how to say that it is really a pathogen or it is a commensal just contaminated with urine while collection? So for that they say that you have to quantitate. More than 10 to the power 5 bacteria per ml is considered as significant. This is called as Kaas concept. This particular concept is called as Kaas concept of significant bacteria. Kaas concept of significant bacteria. Okay, so more than 10 to the 5 per ml is considered as significant. 10 to the 4 to 5 per ml is considered as doubtful significant, and less than 10 to the 4 is considered as insignificant. Okay, there are some exceptions to this. Any count or lower count is significant in certain conditions. There are some exceptions to the Kaas concept. One of the condition is prior antibiotic. If the patient is on antibiotics, then even the lower count is significant. If it is a suprapubic aspiration, then also any count is significant. If you get gram positive organisms, if you get candida, all these cases any count is taken as significant. Otherwise, if you have gram negative organisms like E. coli, then you have to do a quantitation. More than 10 to the 5 is taken as significant. Now the question is how the quantitation is done. The quantitation is done by two methods. The routinely followed method is a semi-quantitative technique, which is called as standardized loop technique. This is the routinely followed technique in lab, day-to-day practice. If they ask, the ideal technique is the quantitative technique. That is done by a method called as pour plate method. So this is how you have to quantitate the urine specimen. Fine. Then let us now discuss about diarrhea strains. Diarrhea E. coli. Diarrhea E. coli is classified under 6 strains are there: enteropathogenic E. coli, enterotoxigenic E. coli, enteroinvasive E. coli, enterohemorrhagic E. coli, then enteroaggregative E. coli, and the sixth variety is diffusely adherent E. coli. Enteropathogenic E. coli is the second most common cause of infantile diarrhea. Infantile diarrhea. It is non-invasive as well as non-toxigenic. It produces diarrhea by attachment and effacement of GI mucosa. This is a mechanism of producing diarrhea: attachment and effacement of GI mucosa. Enterotoxigenic E. coli is the most common agent of traveler's diarrhea. It produces two types of toxin: heat labile toxin and heat stable toxin. Heat labile toxin increases cyclic AMP, heat stable toxin increases cyclic GMP. Fine. Okay. And of course, other than these two toxins, it also expresses a fimbrial antigen which helps in adhesion, called as colonization factor antigen. Colonization factor antigen. It is a fimbrial antigen expressed by enterotoxigenic strain. Next is enteroinvasive E. coli. Enteroinvasive E. coli is invasive. Because it is invasive in nature, it leads to dysentery. Similar to sigilosis. The dysentery of enteroinvasive E. coli is similar to that of sigilosis. The invasion is mediated by a virulence factor called as virulence marker antigen. This is the virulence factor responsible for invasion. And this particular E. coli is called as atypical E. coli because many of the biochemical reactions are negative, like it is non-motile. E. coli is usually motile. Enteroinvasive E. coli is non-motile, lactose non-fermenter. So like that, it is biochemically atypical than other E. coli. Okay. It is diagnosed by Seren's test. Seren's test is an important animal inoculation test. It is an important animal inoculation test. They say that guinea pig inoculation. Guinea pig inoculation leads to conjunctivitis. Leads to conjunctivitis. Guinea pig eye inoculation leads to conjunctivitis. Apart from that, it is also diagnosed by detecting VMA antigen by ELISA. Virulence marker antigen can be detected by doing an ELISA. So this is about enteroinvasive E. coli. Next is enterohemorrhagic E. coli. Enterohemorrhagic E. coli produces a very important toxin called as virocytotoxin, which is phage coded. Phage coded virocytotoxin. It is also called as Siga-like toxin because the mechanism of action is same like Siga toxin. The mechanism of action is inhibit protein synthesis by inhibiting ribosome. Inhibition of protein synthesis by inhibiting ribosome. This is the mechanism of action. The most common food to be associated will be beef products. Apart from that, vegetable salad and other food, but beef products will be the most common food to be associated. Most common strain to produce enterohemorrhagic manifestation is O157H7 is the most common strain to produce enterohemorrhagic manifestation. Complication such as hemorrhagic uremic syndrome and hemorrhagic colitis. These are the two important complications: hemorrhagic uremic syndrome and hemorrhagic colitis. Okay. Diagnosis of enterohemorrhagic E. coli is by using a very important medium called as sorbitol McConkey agar. Okay, sorbitol McConkey agar. Other than that, you can detect the virocytotoxicity. The virocytotoxin can be detected by cell line cytotoxicity. Cytotoxicity on virocell line. This also can be used. Okay. Next is enteroaggregative E. coli. Enteroaggregative E. coli, they say that why it is called as enteroaggregative, because on F2 cell line it is arranged as stacked brick like fashion. It is arranged as in a stacked brick like manner, hence it is called as enteroaggregative E. coli. It produces a toxin called as yeast. Yeast stands for enteroaggregative heat stable enterotoxin. Enteroaggregative heat stable enterotoxin. Please remember, a recent outbreak was occurred due to O104H4. This is a recently identified strain that has caused acute diarrhea. It has produced an acute diarrhea outbreak in Germany. And it is an enteroaggregative strain. It is a variety of enteroaggregative strain, but the peculiarity is it produces virotoxin, and because it produces the virotoxin, it can produce complication like hemorrhagic uremic syndrome. Okay, so though it produces the virotoxin and hemorrhagic uremic syndrome, but it is more closely linked to enteroaggregative E. coli, not enterohemorrhagic E. coli. Okay, so these are the various morphotypes of diarrhogenic E. coli. Now we will discuss brief about Klebsiella. E. coli and Klebsiella, what are the differences? Both are lactose fermenting, but Klebsiella is mucoid LF. Why it is a mucoid? Because it is capsulated. E. coli is non-capsulated. Klebsiella is capsulated, hence it can produce mucoid LF colony. Klebsiella is non-motile, whereas E. coli is motile. There are various important species. Klebsiella pneumoniae is the most important species. It can produce pyogenic infections like E. coli. Other than that, Klebsiella ozone it can produce ozone, or which is also called as atrophic rhinitis. Then Klebsiella rhinoscleromatis, this produces rhinoscleroma. And don't forget, the agent of donovaniasis is classified under Klebsiella now. Which is the agent of donovaniasis? Previously it was called as Calaimactobacter. Now it is classified as Klebsiella granulomatis. We will discuss in detail under miscellaneous bacteria this particular topic, but you have to remember that it is reclassified under Klebsiella now, Klebsiella granulomatis. Fine. A bit about Proteus. Proteus can produce various manifestations. First of all, Proteus, the common tribe specific test is PPA test. All organisms under this tribe is PPA positive. Okay. Proteus has a Fishy order. It produces swarming on blood agar. All these are the specific MCQs what they can ask on Proteus. It can produce swarming on blood agar, and of course there are two species, Proteus mirabilis and Proteus vulgaris. Both are H2S positive. Both are even urease positive. How to differentiate is indole test. Vulgaris is indole positive, whereas mirabilis is indole negative. This is the method to differentiate Proteus vulgaris and Proteus mirabilis. Regarding the manifestation, Proteus can cause, of course, pyogenic infection, UTI. It can also cause renal stone, struvite stone in alkaline urine. Fine. And there are certain Proteus antigen like OX2, 19 and OXK. These three antigens are used where? They are used in Weil-Felix reaction in the diagnosis of rickettsial diseases. Weil-Felix reaction in the diagnosis of rickettsial disease. Okay. There is a peculiar phenomena which you have to remember related to Proteus, Dyne's phenomena. Dyne's phenomena is if two strains are same, then they say that in a blood agar plate, if you inoculate two strains, strain 1 and strain 2, you know that Proteus has a property to swarm. The colonies will gradually they will swarm, they will proceed. So if two strains are similar, then when they will proceed further, they will completely merge with each other. But if the two strains are different, then there will be a line of demarcation. This is called as Dyne's phenomenon. There will be a line of demarcation, which is called as Dyne's phenomenon. Okay. By the way, can you list out the organism that can swarm? Proteus. Which Clostridium? Titani. Apart from that, even Serratia can swarm. Serratia. And Vibrio. Which Vibrio can swarm? Vibrio alginolyticus or parahemolyticus. So, which one? Yes, Anand Narayan has wrongly given Vibrio parahemolyticus has a swarming property, not alginolyticus. Okay, so these are the organisms which can swarm. Fine. So this is all about Proteus. Then we can discuss a bit about Shigella. Shigella, there are 4 species. There are 4 important species: Shigella dysentery, boydi, flexneri and soni. The most common species in world is Shigella soni. However, India is concerned, still Shigella flexneri is the predominant species. Shigella flexneri is the predominant species. Fine. Infective dose. Please remember, students, infective dose, if you classify Shigella, Salmonella and Vibrio, all are enteric pathogens. Shigella has the lowest infective dose of as low as 10 organisms can initiate the infection, whereas Salmonella 10 to 3 to 10 to 6 organisms. Vibrio 10 to the power 6 to 10 to the power 8 organisms are required to initiate the infection. So Shigella, the infective dose is very less. Okay. Coming to the virulence factor, virulence marker antigen, cigatoxin. Cigatoxin is expressed only by Shigella dysentery type 1, not by other Shigella. Shigella dysentery type 1 alone can produce cigatoxin. Hence, this particular strain can cause hemorrhagic uremic syndrome and hemorrhagic colitis. And also they say that enterotoxin, which is called as SHET. SHET is Shigella enterotoxin. Okay, this is usually expressed by Shigella flexneri and other species of Shigella. Okay. So LPS, it is a gram negative organism, so lipopolysaccharide or endotoxin is another important virulence factor. So all these are various virulence factors of Shigella. Fine. So laboratory diagnosis is concerned, they say that mucus fleck with blood will be the ideal specimen. You know that bacillary dysentery always mucus fleck with blood is taken, and the medium enrichment broth, they say that the Shigella and Salmonella, when you are culturing the stool specimen, the culture media are almost same. Shigella and Salmonella, when you are culturing the stool specimen, the enrichment broth is gram negative broth or a selenite F broth or tetrathionate broth. These 3 are enrichment broth for both Shigella and Salmonella. Selective medium, you can use DCA, deoxycholate citrate agar. XLD can be used, xylose lysine deoxycholate agar, XLD, or even enteric hectoin agar can be used. All these are various, and Shigella salmonella agar. One more selective medium is SS agar. Shigella salmonella agar. So as I told you, most of the medium for stool processing for Shigella and salmonella are almost same. Okay. Coming to the various biochemical reaction, Shigella is an organism of exception. There are various exceptional property what you have to remember. Like for example, a Shigella is usually NLF, except Shigella soni, which is late lactose fermenter. Shigella are catalase negative, except Shigella dysentery type, catalase positive, like any Enterobacteriaceae, except Shigella dysentery type 1, which is catalase negative. They are mannitol fermenter, except again Shigella dysentery, which is negative for mannitol fermentation. So like that, there are various exceptions are there which you need to remember. Okay. Then we will discuss about the next organism, Serratia. Serratia is again a rare pathogen. It is important because Serratia marcescens it produces a characteristic pigment which is composed of prodigiocin. This is a pinkish to red color pigment, and that is why, though it is a commensal in sputum, but it often makes the sputum red color, and that leads to a condition called as pseudohemoptysis. It is a commensal in sputum, but because it produces pigment, so sometimes sputum will be red in color, which is described as pseudohemoptysis. At the same time, you have to remember that the non-pigmented strain of Serratia, this is increasingly reported as hospital strain, hospital infections, hospital acquired infection. Okay, and also it is characteristically it produces a type of beta-lactamase called as AMP-C beta-lactamase. Okay, so it is a multi-drug resistant strain. So the pigment producing Serratia marcescens is the usual strain, which is a sputum commensal, whereas nowadays the non-pigmented strains are increasingly reported, and they are hospital strain, and they often cause multi-drug resistant infection. Okay. So next is about Yersinia. Yersinia, especially Yersinia pestis, we can discuss. Yersinia pestis is the causative agent of plague. How many varieties of plague are there? Plague, there is 3 important variety of plague: bubonic plague, yes, pneumonic, and septicemic plague. Which is the most common variety? Yes, bubonic plague is the most common variety, characterized by inguinal lymph node enlargement. It is transmitted by, it has an incubation period of 2 to 7 days. Pneumonic plague also has an incubation period of 2 to 7 days. In contrast, septicemic plague also has an incubation period of 2 to 7 days. In contrast, pneumonic plague has the lowest incubation period of just 1 to 2 days. Regarding the mode of transmission is concerned, bubonic plague is transmitted by, yes, bubonic plague, the most common mode of transmission is rat flea bite, rat flea exposure. followed by direct contact with rodent. Followed by direct contact with rodent. In contrast, pneumonic plague, there is man-to-man transmission by inhalational mode. Septicemic plague is usually secondary to either bubonic or pneumonic. Usually it occurs secondary to bubonic or pneumonic plague. Fine. So these are the three variety of plague. And please remember certain epidemiological feature of Yersinia. Reservoir, rodents are the reservoir. Wild rodent are the reservoir. Source of infection is again either infected rodent or rat fly, or maybe the cases of pneumonic plague. Only a pneumonic plague can be a source, because you will have man-to-man transmission. Vector, as I told you, rat flea. The most common mode of transmission is exposure to rat flea. They say that the species is Genopsiella Chiopis is the species which is considered to be the most efficient vector, and it is found in North India, whereas Genopsiella astia is less efficient, found in South India. Human flea, that is Pulex irritans. This may rarely, it can also serve as vector, but mainly Genopsia chiopsis, which is the most efficient vector, which is found in North India. Fine. So this is all about the various epidemiological feature. So coming to the geographical distribution, the recent outbreaks I can outline. In 1994, I'm talking about Indian outbreak. 1994, there was a Surat epidemic, and this epidemic has affected more than 600 cases. Followed by 2002, there was an outbreak in Shimla. 2004, there was an outbreak of bubonic plague in Uttaranchal. Okay. So these are the recent plague outbreaks. 1994 outbreak was quite important because it has a very important historical aspect. So many people were affected, and so many people, they left Surat and they went to their hometown. So more number of deaths were there because of migration, not because of plague. So it was a lesson learned by Government of India that we should not disclose the outbreak so easily to the media. Otherwise, more number of deaths will be reported because of migration, not because of the disease. So starvation and so many negative things happened because of disclosing the news. Coming to lab diagnosis, they say that microscopy, if you do, buboes aspirate if you take, and if you do a microscopy by a very important stain called as Wesen stain. Wesen stain. Then what you can see is, Wesen stain is nothing but it is a methylene blue stain. Then what you can see is, you can see the typical bipolar appearance. Typical bipolar appearance or ceftipene appearance. Okay. Culture McConkey, it will produce non-lactose fermenting colony. Blood agar, it can produce pigmented colony. And glucose broth, glucose or ghee broth, if you use, then they say that it is described as the growth occurs hanging from the medium, which is called as stalactite growth. The growth is described as it is as if it appears as if it is hanging from the surface of the ghee broth, which is described as stalactite growth. Very frequently asked MCQ. Okay. So these are the various important diagnostic methods. Other than that, F1 antigen detection. F1 is the most important virulence factor for Yersinia pestis. So F1 antigen detection by direct immunofluorescent microscopy, or you can also go for a PCR to detect the gene coding for F1 antigen. Okay, PCR detecting the gene coding for F1 antigen. Okay, treatment, they say that streptomycin was given in the olden days as the drug of choice, of course, but as far as the current recommendations are concerned, they say that gentamicin is more superior, hence it is recommended now as the drug of choice than streptomycin. Olden days streptomycin was given, now gentamicin is given as the drug of choice. Please remember, beta-lactams are not effective. Beta-lactam or macrolides are not recommended. Okay. Chemoprophylaxis, the drug of choice is doxycycline, and please remember, it is recommended not in general. Chemoprophylaxis is recommended to all contacts of pneumonic plaque. This is again very important indication of chemoprophylaxis. Recently it was asked in some entrance where the chemoprophylaxis is indicated. To all contacts of pneumonic plaque. Okay. Don't forget, plague, there is a vaccine. There is a very important vaccine for plague. Vaccine is prepared in institute called as Haffkine Institute in Mumbai. Haffkine Institute in Mumbai. There are two vaccines available, formalin killed, which is called as Haffkine vaccine. Haffkine vaccine. And one more vaccine, that is live attenuated vaccine. So two vaccines are available. Okay, the formalin killed vaccine is used, but the thing is the protection is only for 6 months, not for longer duration, and it is not protective against pneumonic plaque. It is protective only for the other two, that is the bubonic plaque. It is not protecting against the pneumonic plaque. So these are the drawback of formalin killed vaccine, and even the live attenuated vaccine also the same criteria are applicable. Okay, so that's it. Yeah. So Salmonella is again a very important organism as far as exam is concerned, and so let us discuss on this. So first we will have a discussion on the classification of Salmonella. There are various classifications of Salmonella. The oldest and the most widely accepted classification is clinical classification, which divides Salmonella into two groups, typhoidal and non-typhoidal Salmonella. Typhoidal Salmonella includes typhi and paratyphi, whereas others are included under non-typhoidal Salmonella. Second classification is antigenic classification, which is also called as Kaufman-White classification. According to this Salmonella, of course, you know that it has got three antigen, O antigen, H antigen and VI antigen. This classification is mainly based on O antigen and partly on H antigen. So, H and O antigens are used to classify Salmonella under Kaufman-White scheme, and under which there are various serogroups, and serogroups are further divided into serotypes. So, for example, genus Salmonella, the nomenclature is quite peculiar. What you have to remember, species is Enterica, subspecies also Enterica, serogroup will be typhi. So, like that the nomenclature is been designed. Okay. So, typhi is not a species, typhi is a serogroup, and there are various serogroups are there, and all together they say that 67 serogroups are designed so far. Serogroup 2 is a serogroup which contains Salmonella paratyphi A, and serogroup 4 contains Salmonella paratyphi B, serotype 9 contains Salmonella typhi. Okay. So, these are the important Salmonella in the typhoidal group. Okay. So, the third classification is molecular classification. Molecular classification is the latest and the most accurate classification. Okay, so these are the variety of classifications in Salmonella, and the Kaufman-White scheme is again a very important question as far as exam is concerned. So, let us discuss the various antigenic structure of Salmonella. As you know, Salmonella has got three antigen, O, H and VI antigen. So, first let us summarize the O and H antigen. O antigen is somatic antigen, H is flagellar. O antigen is heat stable, of course alcohol stable, but it is formaldehyde labile. In contrast, H antigen is heat labile, heat and alcohol labile, but it is stable to formaldehyde. This is particularly important for preparation of O and H antigen. When you prepare O and H antigen, if you subject the strain to formaldehyde, then O antigen will be destroyed and what will be remaining will be H antigen. The other way around you can do for H antigen preparation. Okay. So, they say that O antigen is less immunogenic. In contrast, H antigen is more immunogenic. Less immunogenic means what? The O antibody titer is always less, whereas H antibody titer will be raised to a greater extent. However, it is seen that the O antibodies, even the titers are less, they appear early and go early. That is why they are the marker of early infection, early or recent infection. In contrast, H antibody, though the titers are more, they usually appear late and go late. Hence, if only H antibodies are there without O antibodies, then they are the marker of convalescent period. Okay. So, this is again an important point what you have to remember when you interpret the Widal test. As you know, both H and O antigens are used in Widal test to detect the respective antibodies in patient serum. So, when O antigen reacts with its antibody, when you perform the Widal test, O antigen, when it reacts with its antibody, it forms the antibody, the antigen antibody complexes which are formed are compact, granular and chalky clumps. Compact, granular and chalky clumps. In contrast, the H antigen antibody reaction, the complexes which are formed are large, they are described as large, loose, fluffy, cottony, woolly appearance. An optimum temperature for the reaction is 37 degree, whereas for O antigen antibody reaction the optimum temperature for agglutination is 55 degree. Okay. So, these are the general concepts what you have to remember. When we will discuss Widal test later, all this will be useful to interpret the Widal test results. So, now let us discuss the VI antigen. VI antigen, as you all know, it is the surface envelope polysaccharide antigen, polysaccharide capsular antigen covering the O antigen. It is not present everywhere, it is expressed only in few strain like Salmonella typhi, Salmonella paratyphi C, Salmonella dublin and non-Salmonella like Citrobacter. So, these are the restricted members which can express the VI antigen. So, when VI antigen is present, as I told you, it covers the O antigen. So, when VI antigen is present, it renders the bacilli inagglutinable with O antisera. So, this is again an antigen which will interfere in the Widal test. In Widal test, you all know that you are detecting O antibodies, but if the VI antigens are present in the test strain, then it will prevent the O antigen antibody reaction. Hence, always the strains should be devoid of VI antigen. You have to clear the VI antigen before you perform the Widal test. Fine. The VI antigen is poorly immunogenic. It is not highly immunogenic, it is poorly immunogenic. Poorly immunogenic means VI antibody titer will be always low. Fine. Hence, it is not used for diagnosis. They say that the VI antibody titer is low, hence it is not helpful in the diagnosis of cases. That is why it is not used in Widal test. But here a point to remember is VI antibody, they say that complete absence of VI antibody in a proven case of enteric fever. Complete absence of VI antibody in a proven case of enteric fever carries bad prognosis. The VI antibodies, if they are completely absent in a proven case of enteric fever, carries bad prognosis. These antibodies, they generally disappear in convalescent stage. However, if they persist, then indicates, this is MCQ they ask, indicates carrier. So, the carrier stage is diagnosed by VI antibody. Cases are diagnosed by O antibody and H antibody, whereas carriers are diagnosed by VI antibody. And any titer, they say that as low as 1:10 antibody titer is also considered as significant, in contrast to O and H antibody, where the titer should rise around 80 and 160. Fine. So, one more MCQ they ask is, Fach typing of Salmonella typhi is done by using VI specific bacteriophages. There are VI specific bacteriophages. Those bacteriophages, they use the VI antigen as receptor to enter into Salmonella typhi. So, Fach typing is done by using VI specific bacteriophages. Fine. So, this is all about the VI antigen. Next, we can discuss about pathogenesis. Pathogenesis, again the mode of transmission is oral mode through contaminated food and water. Okay. So, the food hygiene, if you maintain, then you can prevent enteric fever. You will be knowing one of the famous cook, which who was later called as Typhoid Mary. She was a cook in US, and she was producing, she was a carrier of Salmonella typhi, and she had made so many outbreaks of enteric fever in the school where she was working. So, food hygiene is the most important thing. Infective dose, yesterday we have discussed how much, 10 to the 3 to 10 to the 6 bacilli. Of course, do not forget, if you consider about the risk factor that will promote the infection, stomach acidity. If the conditions that decreases, that leads to decrease of stomach acidity, will promote the enteric fever transmission. So, like for example, less than 1 year of age, antacid intake, achlorohydria, all these are the conditions where the stomach acidity will be decreased. All this will lead to increased chance of transmission. If your intestinal integrity also is decreased, like for example, inflammatory bowel disease, prior history of GI surgery, or even prior intake of antibiotics, all this can lead to decreased intestinal integrity, and as a result the transmission is favored. Fine. So, these are the various aspects what you need to remember. Let us now discuss after transmission what happens. Entry. They say that Salmonella enters in the GI epithelium through a particular cells called as M cells. M cells are the specialized cells present in the GI epithelium. They say that M cells are modified epithelial cells. How they are modified? you know that the columnar epithelial cells will be like this, whereas M cell are the modified epithelial cell. They are say that they are the flat cell, they are flat, their villi will be shortened, they are flat cells and they have a big basolateral pocket and they are flat, the villi will be flat, they are shortened villi. So, these are, so the modified epithelial cells which are called as M cell, this is the site of entry of Salmonella. This is how this is where the organism enter, and do not forget M cell is the site of entry of various organisms like Shigella, Salmonella, Vibrio, poliovirus, like that there are number of important organisms, enteric pathogens that channel inside through the M cell. And this entry of Salmonella occurs by a phagocytosis called as bacteria mediated endocytosis. The process of entry is called as bacteria. The second step after they enter through M cell by a process called as bacteria mediated endocytosis. So, once it is entered inside, they reside inside the vacuole. Inside the epithelial cell there is a vacuole, and inside the vacuole the organism reside, okay, and then they are delivered to the basolateral pocket. From the vacuole they are delivered to the basolateral pocket. So, the organism will be delivered to the basolateral pocket. They will come and they will lie in the basolateral pocket, and basolateral pocket is the place where plenty of T lymphocyte and macrophages will be there. So, those T lymphocytes now in the basolateral pocket, the bacilli will be taken off by the macrophages and they will be carried out into the bloodstream. So, this is how the infection sets in. Infection sets in via the bloodstream. They can go to various organ. They can go to various organ. Okay, so this is how the pathogenesis occurs, and there are various virulence factor like type 3 secretory system of Salmonella typhi will help in entry and multiplication. Okay. So, this is how the pathogenesis sets in. Salmonella pathogenesis is important, and if you are a second year student, then of course it is a very important aspect in your MBBS exam. Then clinical manifestation. Entry fever is not a rare disease, it is quite common in India. The clinical manifestations are very typical, characterized by a fever which is described as step ladder pattern. It is a type of prolonged and continuous fever. Apart from that, other manifestation like headache, chill, myalgia, all these will be there. Decreased appetite, rashes which are described as rose spot. It is seen around 30% of individuals at the end of first week. Rose spot, rashes are more, these rose spots are more prominent in white skinned individual. In Indian patient it is less prominent. Okay. The late intestinal, of course you will have pain abdomen, etc. The late manifestation Intestinal manifestations will be GI bleeding, ulcerations, intestinal perforation. First ulceration that can lead to intestinal perforation. This usually occurs around 3 to 4 weeks of interval. Late intestinal manifestation. Neuropsychiatric complication. Among the complication, neuropsychiatry complication. So this is described like meningitis. It can ranges from meningitis, cerebellar ataxia, which is together described as the delirium also will be there, which is called as muterism delirium or coma vigil. Okay. So these are the various neuropsychiatric manifestation. So why it is called as typhoid? The typhoid word is related to neuropsychiatric manifestation. Even the typhus fever in rickettsia, there is a neuropsychiatric complication. It will be temporary. When the patient will recover, these complications will gradually decline. And don't forget, late manifestation you will have hepatosplenomegaly also. Hepatosplenomegaly, relative bradycardia. All these are important signs. Okay. So manifestations of enteric fever is quite important. Fine. So now we can focus on salient feature related to epidemiology. As far as epidemiology is concerned, host humans are the most important host. Please remember the main difference between typhoidal salmonella and non-typhoidal salmonella. Non-typhoidal salmonella you will have animal reservoir, whereas typhoidal salmonella humans are the principal host. Okay. And the locality to be affected, they say that urban areas are more commonly affected than rural. And don't forget young children, age wise, young children and adolescents. Most important risk factor, poor sanitation. As I told, it is transmitted by food and water. So hygiene, food hygiene and water hygiene plays a very important role to prevent salmonella infections. Okay. Salmonella typhi is more common than paratyphi. They say that Salmonella typhi to paratyphi ratio, this is again an important MCQ they sometimes ask, especially a paratyphi A ratio. Salmonella typhi to paratyphi A ratio is 4:1. According to the standard books, it is 4:1. Please remember, though this is there, but Salmonella paratyphi A appears to be increasing always. There is an increasing trend of paratyphi A. This is because of the reason that now we have vaccination to Salmonella typhi, typhoral. So this vaccination to Salmonella typhi is available now. So, but there is no vaccine at present to Salmonella paratyphi A. The old TAB vaccine is outdated now. So now the current vaccines are mainly targeted to typhi. Hence the paratyphi A is increasing. But please remember, paratyphi A, the infection will be milder than that of typhi. Fine. Then coming to carriers, they say that up to 10% of untreated people can become carrier. And the carriers are of two types: fecal carrier and urinary carrier. Which is more common? Fecal carrier is more common. they say that they multiply in gallbladder and are excreted in feces. Urinary carrier is rare, but it is particularly associated with schistosomiasis, schistosoma infection, especially hematobium, schistosoma hematobium infection, and they usually multiply in kidney. The multiplication will take place in kidney and they are excreted in urine. They are also common if you have urinary tract anomaly. If you have urinary tract anomaly, then also these urinary carriers are common. Okay, how much time they will shed? This also sometimes they ask, not very important, but sometimes they ask duration of shedding. Accordingly, you have various type of carriers like convalescent carrier, which shed for 2 weeks to 3 months. Then temporary carrier, months to 1 year, and the most important question what they ask is chronic carrier. The chronic carrier of Salmonella typhi enteric fever is defined as transmission or shedding more than 1 year. This is in contrast to the chronic carrier of hepatitis B. How much time? Hepatitis B, it is 6 months. If it is excreted for 6 months, it is called as chronic carrier. I mean, not excreted, it will be there in the blood for 6 months, then it is called as chronic carrier. In contrast, for enteric fever it is more than 1 year. Okay. Okay, so now there are some reference center. If you get a chance to work in enteric fever, then these are the very good centers where you can do a good kind of research on enteric fever. National Salmonella phage typing. The Center for phage typing is Lady Hardin Medical College, Delhi. Then the reference center, the National Salmonella Reference Center is located in Central Research Institute, Kesoli. There is one more center for animal. This is located in Izat Nagar. Okay. So these are the various reference centers which you have to remember. Now the most important aspect of Salmonella, laboratory diagnosis. Laboratory diagnosis of enteric fever. The laboratory diagnosis of enteric fever, even it is important for week wise. They sometimes ask week wise what are the first week, second week, third week. I mean second to third week we can discuss together because things are common, and fourth week onwards. First week, they say that first week 3 cultures are done, 3 important cultures. Blood culture is usually done in first week. If negative, you can go for a bone marrow culture. If negative, go for a duodenal aspirate culture. Okay. So if bone marrow and duodenal aspirate cultures are there, they are more positivity is more in them than blood culture. Don't jump on that is why I tell that don't remember the code as BASU. This is an outdated code which is not in use now. Blood culture of course we do, but if bone marrow culture is there, then bone marrow is much superior to blood culture. If the patient is an antibiotic, if patient on antibiotic, then blood culture is negative, bone marrow culture is done, bone marrow culture sensitivity is done. fine. Clot culture is more sensitive. Blood culture is there, but if you have clot culture in your option, then it is a more sensitive specimen than blood culture. Okay. Second and third I will tell you little bit later. Let me finish what we do in first week. So blood culture, you know that how the blood culture is done, which medium? They say that the castaneda's biphagic medium or even monophagic medium we use. So blood culture, if somebody will ask, blood is directly cultured in blood agar and Mekong agar, yes or no? Blood is the specimen which cannot be directly cultured in the solid plates, blood agar, Mekong agar, you cannot culture directly because organism load is very less in blood. So always blood specimen has to be enriched, and the best specimen is brain heart infusion, broth and agar. If you are using a monophagic medium, then we use only broth, okay, brain heart infusion broth. If you are using a biphagic medium, then what we use is there will be a agar slant, BHI agar, slant will be there, slope will be there, and also broth will be there, BHI broth. Okay. And I hope if you have finished your internship, then you would have collected blood specimen for culture. How you are collecting the blood specimen? Can you when you collect the blood specimen, you have to give the specimen in the microbiology lab, they will inoculate into this medium, or you have to inoculate in the bedside? Yes, blood culture is done at the bedside. You have to collect the blood, and at the bedside itself you have to inoculate into this bottle. How you are going to inoculate? You have to open the cap and inoculate? No, they say that in the cap there will be a slit. So you have to inject directly through the slit. You should not open the cap, because all this will lead to contamination. Blood is a very precious specimen. You cannot allow it to get contaminated. Okay. And sometimes they ask which anticoagulant is used. In blood, the anticoagulant what is used is called as, for blood culture, SPS is the anticoagulant which is used. SPS stands for sodium polyanethol sulfonate. This is the recommended anticoagulant which is used for blood culture bottles. Okay, so this is all about first week. Now you tell me what you do in second week. Second and third week we depend upon Widal tests. See, the blood culture also will be positive, but they say that blood culture positivity will be decreased. Okay, the positivity of the blood culture will be decreased, hence Widal test is more recommended. But if they ask which test is used for confirmation of diagnosis in second week, can you write Widal test for confirmation of diagnosis? Widal test is a highly, you cannot rely on Widal test. The antibodies may appear in normal population also. So of course the raised antibody will be there only in the enteric fever cases, but there is I will discuss Widal tests after this. There are so many anamnestic reactions. So which is recommended in second week, answer will be Widal test, but which is used for confirmation, then again you have to depend on blood culture or even PCR to detect the genes. Those are more confirmatory. Okay, so they say that antibody appear only at the end of first week. That is why in first week the Widal test is not used, it is used only in second to third week. But if patient is on antibiotic, then what to do? Widal will be negative. Widal will be negative. In such case you have to do stool culture. Okay. We have discussed in Shigella the culture medium, so I am not going to repeat. The stool culture, the medium of Salmonella and Shigella are almost same. Can you tell? If I told you earlier, then you should be able to reproduce. Can you tell what medium? Enrichment broth, selenite F broth. Okay, gram negative broth, tetrathionate broth. All these are broth. Selective SS agar, DCA, XLD, all these are common to Shigella and Salmonella. Only one medium for Salmonella you can remember extra, that is Wilson-Blair medium. Wilson-Blair medium is only for Salmonella, not for Shigella. Okay. Wilson-Blair medium will have jet black colonies. Fine. Then 4th week again stool and urine culture is done. Then for carrier you can do stool and urine culture, because you know that fecal carrier and urinary carrier are the two important carriers. So stool and urine culture are done even for carriers, and apart from that VI antibody detection. VI antibody detection. Okay, and indirectly you can do the sewage culture also, which is indirect method of knowing that the water sample is going to be contaminated. Okay. So this is in general about laboratory diagnosis, but as you know there are so many questions on Vidal test. So Vidal test, there is a synopsis which is required to know. Okay, so can you tell me Vidal test is a what kind of reaction, precipitation or agglutination? It is a agglutination. Usually tube agglutination is done. Slide also is available, but the better method is tube agglutination test. So we are using 4 antigens here. Salmonella typhi O antigen, which is called as TO antigen. Salmonella typhi H antigen, abbreviated as TH. Salmonella paratyphi A H antigen, AH. Paratyphi B H antigen, BH. So can you tell me why 3 H antigen, only 1 O antigen? The reason is the O antigen is cross reactive. The all 3, that is Salmonella typhi, paratyphi A, paratyphi B, all 3 the O antigen is cross reactive, because they share a common antigen called as factor 12. Factor 12 is a common antigen which is shared by all 3. That is why we are using only 1 O antigen, which can detect O antibodies raised against any of these 3 serotype. Fine. So with this, now we will discuss about what are the various results. Okay. What antigen strains are used? Sometimes they ask. Please remember, Salmonella typhi 901 strain is used for preparation of TO and TH, whereas for paratyphi A and paratyphi B the laboratory maintained strains are used. Okay, the laboratory maintained strains are used. Okay, so as I told you, it is a tube agglutination test, and I will tell you how to interpret the result. The interpretation is very important. So what you are using? You are using 4 antigens. What are they? TO, TH, AH, pH. And what you are going to detect? You are going to detect antibody in patient serum. Is it clear? If it is clear only I can tell you further. See, suppose if Salmonella typhi infection is there, what antibodies will be raised? Antibodies will be raised against TO, TH, AH, BH will be negative. Suppose Salmonella paratyphi A, which antibody will be raised? AH will be raised, but O antibodies are common, these two will be negative. Paratyphi B, again BH and O, these two will be negative. Now I will ask you one more question. What about if you have all H raised, TO is negative? What you are thinking? This is because of TAB vaccination, which is outdated now. TAB was a vaccine is in use. It was containing both typhi, paratyphi A and B, and that is why all 3 H are raised. And O antibodies appear early, go early, so that is why O antibodies will not be seen, only H antibodies will be seen. Can you tell me, TO antibodies are there, all others are negative, what it could be? Early or late? Early. Typhi or paratyphi? It can be paratyphi also. So you have to just tell early enteric fever. You cannot tell what it is. It could be typhi, it could be paratyphi. Okay. All are negative, only TH is there. What it could be? Convalescent stage of Salmonella typhi. Convalescent stage of Salmonella typhi. Getting the point? This is very important, because as a doctor your job is to interpret the result. Doing the test the technician will do. Interpretation of the result is your job. So it is very important to know the interpretation of the result. But with this, what you have to remember, certain thing is, there is a baseline titer in endemic area. You know that enteric fever is quite endemic in India. We all have been exposed to Salmonella in the past. If I do a viral test to all of you, then you all will have some antibodies in your blood. So any antibody titer cannot be taken as significant. They say that the significant titer for O antibody should be more than 100, H antibody should be more than 200. If it is less than that, it is called as baseline titer in endemic area. If it is less than the cutoff, it is called as baseline titer in endemic area. And this cutoff also will vary from place to place. For example, in Pondicherry, we take O antibody as 80 and H antibody as 160. So this will vary from this cutoff will vary from place to place, depending upon the endemicity of enteric fever in the particular locality. One more thing I want to tell you, single rise of titer is important, or 4-fold rise of titer. Which is more significant? 4-fold rise of titer at 1 week gap. This only you have to consider as significant. This has no value. Why? Because in enteric fever there is a phenomena which occurs called as anamnestic reaction. This anamnestic reaction, the definition is rise of titer, especially H antibody, in unrelated infection. Okay, this is probably if you have a past history of enteric fever, or even sometime if you have a exposure also without a proper history of enteric fever, then also the unrelated infection, like for example malaria, tuberculosis, like that there are so many diseases where your H antibodies will be raised. You will have fever and other features. If you do a vital test, H antibody will be raised, and unnecessarily you will start the treatment. Later on you will come to know that the patient is suffering from malaria. So that is why I am telling that viral test should be interpreted very cautiously, otherwise you will end up in giving wrong treatment to the patient. Okay. So how this can be obviated, how anamnestic reaction can be obviated? You have to repeat the test after 1 week, because the anamnestic titer, they are transient titers, they will fall after 1 week, whereas if it is a true antibody titer, then it will persist or even rise also. Okay. So this is all about viral test. I hope you have understood, and it is not only important for your exam, in your clinical practice in future also these points you can easily apply and you can treat the patients. Treatment of enteric fever. There is always a changing trend in the treatment of enteric fever. The olden drugs, the old 3 drugs, chloramphenicol, ampicillin and cotrimoxazole, these are the drugs which were given before 90s, and these were so frequently used that the organism had developed resistant to this, and these strains are called as MDR S typhi strains. So from 1990 onwards, most of the strains of Salmonella typhi are MDR strains. That is why these 3 drugs they stopped giving. These resistant to all these 3 antibiotic was there, so they stopped giving all these 3 drugs. They say that currently the recommendation is, the guideline is, because now we have MDR strains, so now the guideline is for empirical treatment. Before the diagnosis start, ceftriaxone is given as empirical, but later on after doing the culture sensitivity, if you know that the strain is a fully susceptible strain, that is if susceptible to all the drugs given in enteric fever, then ciprofloxacin is given. If it is MDR strain, as I told you, the MDR strain means resistant to chloramphenicol, ampicillin, cotrimoxazole, then also you can give, the drug of choice will be ciprofloxacin, because ciprofloxacin will be sensitive in this case. But if you have NARS strain, NARST, that is defined as nalidixic acid resistant S typhi, nalidixic acid resistant S typhi. In this case, but however, it will be sensitive to ciprofloxacin. The definition says that it is resistant to Salmonella typhi, but it is sensitive to resistant to nalidixic acid, but sensitive to ciprofloxacin. In this case, the drug of choice you can give ceftriaxone, but if you do not want to unnecessarily burden the patient with injectable antibiotics, then as an alternate you can give azithro, or you can give even ciprofloxacin, but you have to give longer course and higher dose, increased dose and longer course. Usually it is given for 1 week, 500 milligram, but in this case 750 milligram BD for 2 weeks you can give. So longer course and higher dose. What I mean to say is ciprofloxacin is not contraindicated in this case. You can just higher the duration and dose. But if it is totally resistant to ciprofloxacin, then of course ceftriaxone is given. For carriers, ampicillin, or even you can give amoxicillin, but you have to add probenecid and you have to give the course for 6 weeks, either ampicillin or amoxicillin plus probenecid, and the duration is around 6 weeks. Okay, so this is all about treatment of enteric fever. Very important, because you will get plenty of cases of enteric fever, so you should know how to treat them. Vaccination for enteric fever. The older vaccine, older and outdated vaccine, these are TAB vaccine, whole cell killed vaccine, all these are outdated. Currently what is in use is injectable, that is VI capsular vaccine, and oral, that is triforal. So these are the two vaccines which is in use, and both these vaccines are important for exam. This VI capsular vaccine, they say that it is composed of VI antigen. VI antigen derived from Salmonella typhi strain TY2. This is the strain from where the VI antigen has been derived. It is given in the doses single dose containing 25 microgram of VI antigen, given IM or even subcutaneously, and the protection is usually for 2 years, and boosters are given every 2 years. Initially it was thought that boosters are not required, but now they are telling that boosters are given every 2 years. Okay, and in this context I want to add one point. VI antigen is a what type of antigen? Capsular antigen. Capsular antigen, what is the problem? T independent antigen, so it is contraindicated less than 2 years. It is contraindicated less than 2 years. Okay, and one more point, where the VI antigen will be there, what are the organism the VI antigen is there? Salmonella typhi, Salmonella paratyphi, A, B or C? C. Then of course dubulin and all, citrobacter and all. That means VI antigen is absent in paratyphi A and paratyphi B. That means this vaccine is, the VI vaccine is not effective. for paratyphoidal fever. It is effective only for typhoidal fever. Okay, so that is why I told you the paratyphoidal fever is more, increasingly presented nowadays. Similarly, typhoidal. The typhoidal also is protective for only typhoidal fever, not for paratyphoidal fever. Typhoidal, it is a live attenuated vaccine. The strain is Salmonella typhi, strain TY21A. TY21A. Again, here they say that this kind of strain, they lack galactose epimerase enzyme. So that is why they call that the strain are called as Gali mutant of S type. They are Gali mutant of S type. They lack galactose epimerase enzyme. So what is the peculiarity is, on ingestion it multiplies and initiate the immune response. It multiplies and initiate the immune response. After that, it is self-destructive. It will die of its own because it doesn't have the particular enzyme for survival. So it is self-destructive. As a result, it cannot cause any pathogenesis. As a result, it cannot cause any pathogenesis. It can initiate the immune response, but it cannot cause any pathogenesis. It is again available in lyophilized form. As enteric coated capsules. This is the only vaccine that is available as capsules. So it is very easy to administer. It is given orally before food. On alternate day 1, 3, 5 plus or minus on day 7. So total 3 to 4 doses. Total 3 to 4 doses. Protection starts after 7 days and lasts for approximately 4 years, and boosters are recommended every 3 years in endemic area. However, if you are a traveler, according to Harrison, boosters are recommended every year for travelers. Okay, boosters are recommended every year for travelers. Let us now discuss the last part of the session, non-typhoidal salmonella. Non-typhoidal salmonella and how it is different from typhoidal salmonella. Very important aspect, because non-typhoidal salmonella is again increasing nowadays. As I told, they are zoonotic. The non-typhoidal salmonella are zoonotic, whereas typhoidal salmonella is strictly human. Strictly human pathogen. Transmission mainly by the animal food product. This is waterborne, water or rarely foodborne. They say that as far as resistance is concerned, the typhoidal salmonella is relatively more resistant to environmental conditions like drying, salting. So all this it will be resistant, freezing, whereas comparatively the typhoidal salmonella will be less resistant. So that is why they stay in the environment for a quite a number of days, the non-typhoidal salmonella. Prevalence both developed and developing countries, whereas typhoidal salmonella usually confined to developing country. Okay. Then the main difference between NTS and typhoidal salmonella will be the pathogenesis. Pathogenesis, they say that typhoidal salmonella is similar in pathogenesis. I mean the non-typhoidal salmonella is similar in pathogenesis to typhoidal salmonella, except the fact that here you will have neutrophilic infiltration. Increase neutrophilic infiltration in GI mucosa. In contrast, typhoidal salmonella, where you will have increased lymphocytic infiltration in GI mucosa. Clinically, non-typhoidal salmonella you will have gastroenteritis. See, enteric fever is called as enteric fever, but it is a misnomer actually. There is no enteric, I mean the gastroenteritis features will not be there in enteric fever, whereas salmonella, non-typhoidal salmonella will have gastroenteritis features. Even bacteremia will be there, especially salmonella cholera suis. And other metastatic infections such as intra-abdominal, salmonella osteomyelitis. Can you tell me which condition salmonella osteomyelitis is common in sickle cell patients? Reactive arthritis, especially in HLA B27 group of patients. Okay. So these are the differences between a typhoidal and a non-typhoidal manifestation. Treatment wise, they say that fluid, I mean conservative treatment, fluid replacement, antibiotic given only for invasive. For gastroenteritis, antibiotics are, I mean the milder gastroenteritis, antibiotics are not given, only for invasive or for severe gastroenteritis. Whereas the typhoidal salmonella, antibiotic are must, it should be given as soon as possible. And resistance wise, drug resistance wise, they are more drug resistance. NTS are more drug resistant than typhoidal salmonella. Fine. So these are the differences between typhoidal and non-typhoidal salmonella. Coming to the one of the important chapter of bacteriology, Vibrio. Vibrio, first we will discuss about classification. The classification is called as Gardner and Venkatraman classification. According to this, the Vibrios are classified into Vibrio cholera and other Vibrio group. So these are the two important groups. Vibrio cholera is further divided based on origin into various groups called as serowarts. They say that up to more than 200 groups are available, which the pathogenic groups are O1 and O139. This non-O1, non-O139, those are it is around O2 to O more than O2 to O200. So many groups are there, but except O1 and O. So these are less pathogenic. They can cause mild infections, but never cholera like infection. This O1 and O110 are the group which can cause cholera epidemics. Okay. So after that, the further classification also is there. They say that O1 can be further be classified into biotype. Biotype is based on biochemical reaction. The sero group or the sero var is based on O antigen, antigenic, whereas biotype is based on biochemical reaction. According to that, two biotypes are there: classical and alter. But don't forget, recently there are various alter hybrids are also available, have been reported, which will have mixed biochemical properties. And both classical and alter can be further classified into serotypes. Serotypes, again this is based on O antigen only, into Ogawa, Inaba and Hikojima. These three are serotypes. These three are serotypes. So this is the broad classification of Vibrio cholera, which is called as Gardner and Venkatraman classification. Fine. So as I told you, the biotype alter and two biotypes are there, classical and alter. But now we have various mixed property, which are called as the third variety is alter variant or hybrid. This alter variant, they have been described recently in Bangladesh as well as in few other places of Asia and Africa, and they will have mixed overlapping biochemical reactions of classical and alter. They will have both some biochemical properties which will resemble classical, some biochemical property which will resemble alter. There are various examples of alter variant, like Matlab variant, Mozambique variant. This was Matlab variant is from Bangladesh reported. Mozambique variant has been reported from Africa. So they will have mixed properties. And why it is important? Because you cannot say that all the strains are now alter or classical, because there are hybrid varieties are also available. So I can summarize you the differences between classical and alter. Classical and alter, there are certain biochemicals which can be done, like CEP-RBC hemolysis. This is a property of alter. Similarly, cheek-RBC agglutination, this is also a property of alter. Polymyxin B resistant, alter, whereas classical is sensitive to polymyxin B. Like that, alter is VP test positive. Similarly, reverse camp test is done. Reverse camp, this is positive for alter, negative for classical. Coming to cholera toxin, the gene coded for cholera toxin, they say that the classical toxin is given the name as CTX1, whereas Elter toxin is named as CTX2. Okay. So, these are the various biochemical properties wise the differences between classical and Elter. And the variants what we have discussed, Matlab variant, where it is I told in Bangladesh, it was reported from Bangladesh, but they say that this particular variant is having mixed property. Mozambique, one more variant. They say that the Mozambique variant, the properties are of Elter, except that the cholera toxin classical, that is CTX1. Okay, so like that there will be difference in minor differences will be there. Don't go into the depth, but you have to remember that these kind of variants they exist now. Okay, so let us now directly start the pathogenesis. Yes, so please remember both O1 and O139 can cause cholera epidemic. Okay, and the pathogenesis of both O1 and O139 are almost similar to each other. So what happens is the mode of transmission. The transmission, you know that it is a principally it is a waterborne, rarely foodborne. Infected dose more or less what I have told you, more 10 to 6 to 8, Salmonella, Shigella and Vibrio, which has more infected dose, Vibrio, but which is more virulent, again Vibrio, not Shigella. Then how it is possible that Vibrio has more infected dose? Because Vibrio is acid labile, so to bypass the gastric barrier, it is extremely acid labile, so to bypass the gastric barrier it has a higher infective dose. Okay, again the risk factor will be same as Salmonella. Any condition that decreases acidity of stomach, like Salmonella only, whatever I have told the risk factors, any condition that decreases stomach acidity can be a predisposing factor. Okay, so after the Vibrio crosses the stomach and it reaches the intestine, in the intestine first it will cross the mucus layer, and then it will it does by penetrating the mucus layer, and which may be achieved by its extremely active motility, and also because of the production of an enzyme called as mucinase enzyme. And one more important HA antigen, heme agglutinin antigen. Which is also called as cholera lectin. So heme agglutinin proteases, motility and mucinase enzyme, all these are the properties by which it will penetrate the mucus layer. So this is the first thing what has to, because in order to reach the GI epithelium it has to penetrate the mucus layer. Once it penetrates the mucus layer, the next step is adhesion. Adhesion to what? GI epithelium. And this is because of a very important pilus, very important fimbrial antigen called as TCP, that is toxic co-regulatory pilus. It is a fimbrial antigen by which the adhesion to GI epithelium takes place. Next is, once it adheres to GI epithelium, it will secrete the toxin. So the main pathogenesis is due to production of a very powerful toxin, that is cholera toxin. It is again a toxin that is bacteriophage coded, and overall the mechanism is increase of cyclic AMP. But I must tell you the detailed mechanism, because they may ask the steps of cholera toxin mechanism. So it has got two fragments, A and B. Again, wherever A is there, A for active, B for binding. B fragment binds to the GM1 ganglioside receptor on GI epithelium. Whereas fragment A is the active fragment, it causes ADP, ribosylation of G protein, which in turn leads to upregulation of adenyl cyclase. Upregulation of adenyl cyclase, that in turn causes intracellular accumulation of cyclic AMP. Okay. So this is again the mechanism. The increase of cyclic AMP is a mechanism which is shown by various other toxins also, like anthrax toxin. Anthrax toxin edema factor. Okay, then heat labile toxin of E. coli. Of course, cholera toxin, pertussis toxin. All this toxin, they cause increase of cyclic AMP. Okay. So now you tell me, in cholera toxin, if it increases cyclic AMP, that leads to what? How the diarrhea takes place? Cyclic AMP increase leads to, they say that, accumulation of sodium chloride in the lumen, and because sodium chloride gets accumulated in the lumen, this leads to movement of water, because to maintain the osmolarity, the water moves out. To maintain the isotonic environment of the fluid. To maintain the isotonic environment of the fluid, water moves out, and this leads to watery diarrhea. And they say that the loss of fluid and electrolyte leads to, so the fluid and electrolyte, if they are, the loss leads to profound shock due to dehydration. Dehydration takes place, so as a result you will have shock and acidosis, because even the bicarbonate are also loss. Loss of bicarbonate leads to acidosis. So these are the result, the effect of increase of cyclic AMP. Okay. So the gene that codes for cholera toxin is phage coded, and there is a regulatory gene called as STOX-R gene. This is a regulatory gene. It regulates the expression of cholera toxin as well as toxic co-regulatory pilus and some other factors also. So this regulatory gene is very important, that regulate the expression of cholera toxin as well as toxic co-regulatory pilus. Apart from cholera toxin, there are some other virulence factor. These I can tell you because they may ask which of the following is not a virulence factor of Vibrio toxin. So they say that Zona occludens toxin is there. So this will disrupt the tight junction. This was recently asked in AIMS. Tight junctions of epithelial cells. Siderophores, they will help in acquisition of iron, uptake of iron. Then what about bacterial endotoxin? Does it have any role? Gram negative, no it is, so it will have endotoxin, LPS. They say that unlike other gram negative bacilli, the LPS of Vibrio cholera does not contribute much to the pathogenesis. This is again an MCQ to be remembered. Unlike E. coli and other gram negative organisms, the Vibrio cholera LPS does not contribute to pathogenesis. However, they say that the LPS is immunogenic. It is immunogenic, and that is the reason why it is included in vaccine. This particular component is included in vaccine. Antibody against this antigen is protective in nature, but it is not useful in pathogenesis. Okay, in short, I will now discuss the various clinical manifestations. They say that O1 and O139, they produce various manifestations which can range from maybe asymptomatic to mild to explosive diarrhea, which is called as cholera gravis, which is more common. Asymptomatic is of course more common, whereas cholera gravis may occur in 5% of cases. Okay. Incubation period may be 1 to 2 days, and you know that you will have a watery diarrhea. Blood will be there or not? Whatever explosiveness of the diarrheal episode, but never blood will be there in the stool, because it is a non-invasive organism. It's the dysentery will never be a manifestation. Only you will have a watery diarrhea which will resemble rice water stool, and of course it will be painless. And the appearance of stools, they sometime ask in the exam, the rice water stool, what is the characteristic appearance? They say that it is non-bilious, cloudy, and watery with mucus flake. Mucus flake can be there, but no blood or no pus cells, and it has a fishy but slightly fishy, inoffensive odor. And again no fever, so no pain and no fever. Vomiting may be there, muscle cramps may be there, but no fever. Okay, now we will discuss about complications. Complications, they say that it is directly proportional to fluid loss. Whatever is the fluid loss, accordingly the complications will be there. If the fluid loss is less than 5% of body weight, then first manifestation will be increased thirst. 5 to 10% of body weight loss can lead to postural hypotension. And increased skin turgidity. But most of the complication comes when the fluid loss is more than 10%. Renal failure can take place, and that leads to various complications like oliguria, decreased pulse. So the features of shock will be there: hypovolumic shock will be the shrunken eyes, wrinkle, wasser, woman's skin. So all these are extreme of complication which occurs in basically the renal failure and other complications, they take place in cholera gravis patients. Okay, so all these are about manifestations. Now as far as cholera is concerned, epidemiology is very important. Which is the homeland of Vibrio cholera? The homeland is considered to be they say that the homeland is the delta region of Ganga and Brahmaputra. This is mainly West Bengal and adjacent Bangladesh. But the characteristic homeland where most of the outbreak, most of the endemics had happened, that is not there now. Now the cholera is there everywhere. They say that the first 6 pandemics, there are total 7 pandemics reported so far. The first 6 pandemics, they started from India, then they spread to the whole world, and these 6 pandemics were due to classical biotype, and they are extremely severe infection. The disease was extremely severe, mortality was extremely severe. The 7th pandemic, it is totally different than the first 6 pandemic. The 7th pandemic was due to elter, and elter has more number of carrier but less severe cases, because elter is supposed to be the hardier organism than classical. It can stay in the environment for a longer period. However, the cases are less severe. And the 7th pandemic is the only pandemic that started outside India. It was started from Indonesia. Of course, it has spread to the whole world, which includes India also later on. But the starting point was Indonesia. What about O139? Can you tell me what was the what is the year when O139 has appeared? They say that in 1992 O139 was first appeared near Chennai, then it has spread in 2 years, it has spread in the coastal region of Bay of Bengal. That is Andhra Pradesh, then Odisha, then up to West Bengal, then from West Bengal it has migrated to Bangladesh. So because it has spread along the coastal region of the Bay of Bengal, it was also called as the Bengal strain. And from 1992 to 94, it has, enormous number of cases were reported. It was so much that they thought that, are we going to have the 8th pandemic? Like that the question was arised. But of course, later on from 94 onwards, there was a decline in number of cases. Now the cases are there, but not much. Now also this O139 is there, but not much number of cases. And they say that it is capsulated. The O139 is capsulated. Hence they say that it may be invasive. This is one difference than alter. And they say that O139, it is believed to be a derivative of alter. However, it is the difference is it is capsulated and it may be invasive. There is the only difference. So because it is invasive, so extraintestinal manifestations may appear. So this is the difference between alter and O139, because it is capsulated, so extraintestinal manifestation may appear. Currently, what is the status if they ask? Currently few cases are there from Bangladesh as well as from India. Only few cases have been reported. It is not totally out, it is there, but very few cases. Okay. Now let us discuss certain epidemiological factors. Reservoir will be humans. There is no animal reservoir like Salmonella typhi. Source, again either asymptomatic individual or carriers, they play an important role. As I told you, carriers are there. So carriers may be, variety of carriers may be healthy carriers or may be incubatory carriers, convalescent carrier, or may be chronic carrier. So there are variety of carriers which, I mean, the organism can be set in the feces either during the incubation period, during the convalescent stage, as well as in the chronic carrier. In general, alter is having more number of carriers than classical. And if they ask what is the case to carrier ratio, it is around 1:50 for classical. This is a MCQ actually, whereas it is 1:90 for alter. So alter has more number of carrier than classical. Seasonality, of course, it is a waterborne, so it is mainly seen during the rainfall. Okay. And they say that there is a association between blood group. The O blood group are having a greater risk of severity, whereas AB blood group has the least risk. So this is again one of the difference what they ask, the blood group relationship between the severity of infection. Age, again a point to be noted here, during epidemic children are commonly affected, whereas in between epidemic, this was asked recently in AIMS, all ages are equally effective. During epidemic it is the children, whereas in between epidemic all ages are equally effective. Then how it is maintained? During epidemic it is maintained by carriers. In between epidemic it is maintained by sea water, especially the planktons. Okay, so cholera vibrio is maintained in between by the planktons, and as I told, it is acid labile, extremely acid labile, but it is alkali stable. Similarly, it is of course it is heat labile, but it is resistant to refrigeration. So these are the MCQs what they ask about the epidemiological determinants. Okay, so now without wasting any time, let us discuss on lab diagnosis. Samples specimen will be the mucus flakes of stool. For carrier, even the rectal swabs can be taken. For carriers, rectal swabs can be taken. Of course, you can go for when you collect the specimen, the various transport media can be used. VR fluid is the traditional medium, Venkatraman Ramakrishnan medium. Apart from that, Carey Blair medium, alkaline salt transport medium, like that, even autoclaved seawater. Autoclaved seawater can be used. Okay, so these are the transport medium to be used, and once it comes to the lab, processing is immediate. Please remember, do not store the sample for long time. It has to be processed as soon as possible. If you go for a direct microscopy, gram stain, if you do, typically you will get comma shaped gram negative bacilli arranged in fish in stream appearance. This is again MCQ they ask. Usually stool specimen gram stain we do not do unless we suspect cholera. When we suspect cholera, gram stain in, because stool specimen will have normal flora, like if you do a gram stain, plenty of E. coli other organisms will be there. Gram stain is not recommended, but when you suspect cholera, yes, because the typical fish in stream appearance help a lot in diagnosis. Apart from that, motility by hanging drop, the extremely active motility is described as dating motility or shooting star motility. Darting motility is described as an extremely active motility with frequent change of directions, zigzag movements will be there. And please remember, darting motility is also seen by Aeromonas, Campylobacter. So darting motility is not confirmatory. It is highly suggestive but not confirmatory. What you can do is, if you have H antisera, then what you can do is stool you can add with H antisera. H antisera means what? Antisera, antibody against the flagellar antigen. After that, if you do a motility, then if you see that there is no motility, if the organism became non-motile, then this can be used as confirmation. Okay, because this is this you can do very fast, no need to wait for culture which takes 24 hours to grow. So this can be done for confirmation, but only darting motility is a suggestive feature, not a confirmatory feature. Okay, so now you can do processing. Culture can be done. Culture can be done. You can use enrichment broth. Enrichment broth like alkaline peptone water, okay. Mansour's medium, Mansour's taurocolate, tellurite medium, these are the enrichment broth can be used. when you are using alkaline peptone water, please remember you have to subculture at 6 hours, otherwise even other organisms will grow. So alkaline peptone water, if you are using, you have to subculture at 6 hours. Okay, then selective medium can be used, alkaline bile salt agar, Mansood's G triple T agar, G triple T stands for gelatin, taurocolate, tellurite, trypticase. So this is one medium, but the most widely used medium is TCBS, which stands for thiosulfate, citrate, bile, sucrose agar. Thiosulfate, citrate, bile, sucrose agar, and because it has sucrose, they say that Vibrio cholera can ferment sucrose. That is why you have yellow colonies. Yellow colonies. Otherwise, other organisms like for example Vibrio parahemolyticus, it does not ferment sucrose, so it will produce green colony. The color of the medium is green. The color of the medium is green, so it will produce green color colonies only. So this is again a highly selective medium for Vibrio cholera. It is widely used now. In most of the colleges they use TCBS medium. Of course, then certain biochemical properties can be considered. Vibrio cholera is catalase and oxidase positive. Sometime you can do a cholera red reaction, indole plus nitrate, both together is called as cholera red reaction, indole positive and nitrate positivity. String test can be done, and it is susceptible to vibriostatic agent. Vibriostatic agent is nothing but it is a chemical called as O129, and this particular chemical, they say that Vibrio cholera is susceptible to vibriostatic agent. So these are the various biochemical reactions. Then regarding the treatment, drug of choice for adult, this is again very important. Doxy, if resistant, then you can go for ciprofloxacin, otherwise doxy. Children, cotrimoxazole. Pregnancy, furazolidine, and for chemoprophylaxis tetracycline is given. Okay, so all these four are individual MCQs. Okay, next is vaccine. Vaccine, they say that injectable killed vaccines are not in use, they are outdated. What has been used is now oral cholera vaccine, OCV. There are two type of oral cholera vaccine: killed whole cell vaccine and oral live attenuated vaccine. Oral live attenuated vaccine can use strain as CVD 103 HZR. It is one of the strain what is used for oral live attenuated vaccine, but widely used vaccine is killed whole cell vaccine. This is a vaccine which is widely used, killed whole cell vaccine. They say that again two types are there. Whole cell vaccine is there, one type, and the other type is whole cell recombinant beta B subunit, which is called as whole cell recombinant B subunit. So these are the two variety of vaccines are available. Here the protection is only 6 months. That is the drawback of cholera vaccine. So that is why they say that it is indicated only during epidemics. Cholera vaccine is not indicated otherwise. It is it is indicated only during epidemic because the protection is short lasting. Okay, so this is all about cholera vaccine. Now we will discuss halophilic vibrio. What do you mean by halophilic? Vibrio cholera is halophilic or non-halophilic? Vibrios can be classified as halophilic and non-halophilic. Halophilic means they can grow at higher salt concentration, that is more than 6% salt. Vibrio cholera maximum it can grow up to 6%. More than 6% it will not grow. And please remember 1% of salt is required for optimal growth of vibrio. If there is no salt, vibrio cholera will not grow. 1% salt is required for optimum growth of vibrio cholera, and maximum it can survive up to 6%. Whereas there are some vibrios like vibrio parahemolyticus, vibrio vulnificus and vibrio alginolyticus. So these are the three vibrios which are called as halophilic vibrio. In that, alginolyticus can survive maximum even up to 10% salt. Okay, so these three are considered as halophilic vibrio. So let us discuss a bit about vibrio parahemolyticus. Vibrio parahemolyticus, it can cause foodborne gastroenteritis. And please remember all these three, they are parahemolyticus, vulnificus and alginolyticus, all these three, the mode of transmission is usually exposure to either ingestion or even the exposure to the various raw or uncooked seafood. Like oysters. Okay, vibrio parahemolyticus results from ingestion, whereas vulnificus and alginolyticus, if they produce skin and soft tissue infection, then maybe a exposure also can cause infection. But usually the seafood or various sea plants and all, if you are exposed, you will get this halophilic vibrio infections. So gastroenteritis is the main manifestation. Other than that, extraintestinal manifestation such as wound infection, etc., or even otitis, sepsis, etc., can be presented. And lab diagnosis wise, vibrio parahemolyticus, again it is capsulated, it is bipolar stain. All these are typical features. Of course, it is motile but no darting, and one of the important, of course, our TCBS, I told you that it will produce green colony because it is sucrose non-fermented. There is a special medium called as Vagatsumagar. It is a modified blood agar called as Vagar-Suma agar. Here it produces a characteristic hemolysis which is described as Kanagawa phenomenon. This is the most identifying feature of Vibrio parahemolyticus. Okay. Then the next is Vibrio vulnificus. Vulnificus is called as L plus Vibrio. That is the only Vibrio that can ferment lactose. Only Vibrio that can ferment lactose. Recently they have asked what kind of manifestation it produces. Either primary sepsis. This is usually it presents in patient with underlying liver disease, liver or iron overload. Then otherwise wound infection, and gastroenteritis, which is the most common feature of parahemolyticus, here it is very rare. Gastroenteritis may be there, but it is very rare. Then alginolyticus. Alginolyticus is again, they say that it tolerates maximum salt. That is the highest salt tolerant Vibrio. Up to 10% it can tolerate. It can produce, I think 2013 or 14 it has come in names. What kind of infection it produces? It can produce ear, eye as well as wound infection. This is the most common manifestation of alginolyticus. Few cases of otitis externa has been reported. Otitis media, otitis externa, conjunctivitis, all these have been reported. And rarely it can cause bacteremia in immunocompromised patient. But mainly eye, ear or and wound infection. Okay, so that finishes your Vibrio chapter. It deals about Pseudomonas and other non-fermenter as well as HPB, that is Haemophilus, Bordetella and Brucella. So let us start first with non-fermenter. In non-fermenter we will discuss first on Pseudomonas. Pseudomonas, as you know, it is one of the most resistant organism in the hospital. One of the most drug resistant organism encountered in the hospitals. There are various virulence factors of Pseudomonas which will decide its pathogenesis. They say that it is one of the organisms that has enormous number of virulence factors, like toxins. There are various toxins which can be classified as diffusible and non-diffusible toxins. Among them, exotoxin A is the most important virulence factor. Apart from that, there are so many other exotoxins, exotoxin S, U, T, etc. Protease, there are various enzymes, protease, elastase, like that there are so many spectrum of virulence factor, but the most important is exotoxin A. Other than toxin, if you consider about other virulence factor, they say that pigment production. Pseudomonas is known to produce various pigment which can be described as pyocyanin. It will give rise to blue green pigmentation. It is produced only by Pseudomonas aeruginosa, not by other Pseudomonas species. Apart from that, other pigments like pyorubin, pyomelanin, and fluorescein. Fluorescein are also called as pyoverdin. This fluorescein is produced by all species of Pseudomonas, whereas pyocyanin is confined only to Pseudomonas aeruginosa. So, pigment production is again considered as important virulence factor. Then the next is alginate coat. Alginate coat is responsible for formation of biofilm. It is a slime layer which is responsible for formation of biofilm, and this is important for patients with cystic fibrosis, and usually the mucoid strain of Pseudomonas is capable of producing alginate coat or the slime layer, mucoid strain of Pseudomonas. The next property which helps in virulence is the tendency of multi-drug resistance, as well as it is resistant to drug and disinfectant. Do not forget, Pseudomonas is resistant to an array of disinfectants, multi-drug and multi-disinfectant resistance. It has a wide temperature range. It can survive in any temperature starting from 5 to 45 degree centigrade. Fine. So, these are the various virulence factors by which the Pseudomonas is considered to be the most important hospital acquired pathogen. Coming to the clinical manifestation, it can cause various kind of hospital infections ranging from pneumonia, that is ventilator associated pneumonia is quite common, as well as it can cause chronic respiratory tract infection, and as I told you, cystic fibrosis patient, especially it can cause chronic respiratory tract infection, ear infections like malignant otitis externa, swimmer's ear, okay, corneal ulcer, especially in the contact lens user. Contact lens user, any other parasite which is important? Yes, acanthamoeba. Okay, so Shanghai fever, then various skin and soft tissue infection, which can be ranged from, yes, burn infection. They say that Pseudomonas is one of the most common organism to infect the burn wound surface. Ecthyma gangrenosum, ecthyma gangrenosum, then dermatitis, to web space infection, green nail syndrome, one of the frequently asked MCQ, green nail syndrome. It is a paranoikia due to Pseudomonas. Okay, and it is usually results from submerging the hands in water for longer time. okay, green nail syndrome. So, coming to the various other manifestations, it can also cause meningitis, cellulitis, etc. UTI also it can cause, especially the catheter associated urinary tract infection. Okay. So, now let us concentrate on how to identify Pseudomonas. Pseudomonas, as I told, it is resistant organism, and the laboratory diagnosis wise it is oxidase positive, produces non-lactose fermenting colonies. Okay, it is a non-fermenter. Non-fermenter means what? No sugars can be fermented. Apart from that, the other important features, OF test shows oxidative pattern as it is a non-fermenter. Pigment production is again, they say that King's media is used to enhance the pigmentation. Pigmentation can be enhanced in King's media. Selective media is used as cetrimide blood agar. Of course, do not forget it is also motile with polar flagella. So, these are the various biochemical reactions by which you can identify Pseudomonas. Treatment of Pseudomonas infections will be the most important MCQ in Pseudomonas, because there are very limited spectrum of antimicrobials which can be given in Pseudomonas infection. So, anti-pseudomonials can range from penicillins. Among the beta-lactam, they say that penicillins like piperacillin, meslocillin and ticarcillin. Among the among the cephalosporins, ceftazidime, cefoperazone and cefepime. This is important because which cephalosporin is anti-pseudomonial action has, very frequently they have asked. Monobactam like Astrionum, even carbapenems can be given like Minopenem and Imipenem. So, these are the anti-pseudomonial beta-lactam group of antibiotics. Among the aminoglycoside, the anti-pseudomonials are tobramycin, amikacin and gentamicin. Quinolones, ciprofloxacin and levofloxacin. And please remember, these, if every antibiotic, if none of the antibiotic work, then the last resort of antibiotic what is given is polymyxin such as colistin. Colistin is the last resort of antibiotic given for anti-pseudomonials. Okay, so this is all about the other non-fermented Burkholderia. Burkholderia is also a non-fermenter like Pseudomonas, but it differs from Pseudomonas because it is resistant to polymyxin and it is bipolar stain or having ceftipene appearance. So, these are the two differences from Pseudomonas. Among the various species of Burkholderia, Burkholderia pseudomallei is the most common one. Apart from that, you have Burkholderia mallei and Burkholderia cepacia. Pseudomallei is agent of melioidosis. melioidosis, also called as Vietnam time bomb disease. The reason of this naming is it has a long latency, hence they say that it will produce its effect after longer time, hence it is called as Vietnam time bomb disease. And melioidosis is characterized by pulmonary infection. Apart from that, ulceration and lymph nodopathy. So these are the various, because they sometimes give you the clinical manifestations which may mimic with tuberculosis also. So you have to differentiate whether it is melioidosis or not. It can be because of its long latency, it can be used as an agent of bioterrorism. Okay. The selective medium for Pseudomyelin is ash down medium, very frequently asked MCQ. Okay, ash down medium. The drug of choice of melioidosis, according to Harrison, it says that you have to give 2 phases. The first phase, which is called as intensive phase, it is you have to give ceftazidime, or maybe a carbapenem can be given, and it is given for 2 weeks, followed by maintenance phase. This is given for 12-week duration, and oral cotrimoxazole is given. Oral cotrimoxazole, and this maintenance phase is mainly to prevent relapse. It has a tendency to reoccur again, so that is why maintenance phase is given. In contrast, Burkholderia malayi, it is also zoonotic. In animals, it can cause various diseases like glanders and Farcy. Okay. Mainly horses, it is known to infect horses. And coming to the human infection, local skin nodules will be the most common presentation. How it differs from malayi, I mean Pseudomyelin? Burkholderia malayi is non-motile. In that way, it is different than Pseudomyelin, and it cannot grow on Mekong agar. And guinea pig inoculation leads to testicular swelling. This is called as Strauss reaction. This is again very old phenomena, but as you know, your question setters are also old, so they can ask about Strauss reaction. So these are the features which are present only in malayi but not in Pseudomyelin, so by which you can differentiate. The third species is Burkholderia cepacia, and cepacia is supposed to be the most common Burkholderia species and is usually encountered in hospitals. It is a nosocomial pathogen. And why it is very common in hospital? Because it is its ability to grow in various hospital places like IV fluid, even disinfectant also, because it is also multi disinfectant resistant, so it can grow in IV fluid, disinfectant, etc., detergents. Fine. And regarding the manifestation, it can cause cepacia syndrome, which is characterized by a respiratory tract infection and sepsis. Okay. So these are the various Burkholderia species. Now one more non-fermenter which is again quite common in hospital, Acinetobacter. It is a non-fermenter, but it differs from Pseudomonas because next to Pseudomonas, Acinetobacter is common. So how it differs from Pseudomonas is it is oxidase negative and it is non-motile. That is how we differentiate it from Pseudomonas. But please remember, it can cause various ranging from ventilator associated pneumonia, wound and soft tissue infection, burn infection. So like that various infections it can cause. Okay. So Acinetobacter is again a very important hospital pathogen, and like Pseudomonas, the treatment spectrum is almost same like Pseudomonas. Spectrum of antibiotic, almost anti-pseudomonials you have to give, but again it is a multi-drug resistant organism. So this is all about Haemophilus, I mean non-fermenters. Now let us discuss HBB group of organism. So first we will discuss about Haemophilus. Haemophilus is, hemo means what? Blood. Philus is, so it is a blood loving organism and it requires two important factors to be present in blood. As blood contains two important factors and those two factors are needed for the growth of Haemophilus, that is why it is Haemophilus, blood loving organism. It is highly fastidious. Ordinary medium it will not grow. In fact, the entire HB, Haemophilus, Bordetella, Brucella, all three are highly fastidious organism. They will not grow in ordinary medium. And Haemophilus needs two important growth factor in blood, factor X and factor V. Don't pronounce as 5 and 10, they are factor X and factor V. Factor X is a hemine present freely in blood, but whereas factor V is a NAD enzyme which is present only inside RBC. That is why if you see that Haemophilus influenza do not grow in blood. I am talking about in blood agar. Why? Because in blood agar factor V is not freely available, it is present only inside RBC, whereas it can grow in heated blood agar. Heated blood agar is very good, chocolate agar, because chocolate agar the RBC will be lysed and it will be released outside. In blood agar, put a Staph aureus stick line in the center. The center, if you put a Staph aureus stick line, Staph aureus is hemolytic or not? Hemolytic means what? Adjacent to the stick line, the RBCs are lysed, yellowish zone will be there. RBCs are lysed means V factor will be released. If the V factor is released, that means Haemophilus influenza can grow in the adjacent stick line of Staph aureus, and this property is called as satellitism. This property is called as satellitism. Okay. So this is the introduction. Now we will discuss about virulence factor. Now we are discussing about Haemophilus influenza alone. So for Haemophilus influenza, the virulence factor, the principal virulence factor is capsular polysaccharide. It is a capsulated organism, and based upon the capsular polysaccharide there are 6 serotypes from A to F. In that, the Haemophilus influenza B serotype is the most virulent as well as most common serotype, accounting for maximum number of invasive infections. And this Hib capsule, the capsule of Haemophilus influenza B is typically composed of a antigen called as PRP antigen. PRP stands for polyribosyl phosphate. It is also a type of capsular polysaccharide antigen, but composed of ribose sugars, a polyribosyl phosphate, and it is strongly antigenic. Because it is strongly immunogenic, hence it is used for vaccination. Fine. If somebody asks the most common serotype, of course Hib. After that, what is the next common strain of Haemophilus influenza? They say that next to Hib, the next common is non-typable strain. See, there are 6 serotype based on capsule, but there are 5 to 10% of strains which are not having any capsule, they are non-typable strains. So, non-typable strains are next common, they are the next common strain next to Haemophilus influenza B, and they also can cause various non-invasive infections. They cannot cause invasive infection like meningitis, but they can cause non-invasive infection. So, when we are discussing about virulence factor, the next topic has to be the various manifestation. Haemophilus influenza, the manifestations broadly categorized into invasive and non-invasive. Okay, invasive like CNS infections like meningitis, pyogenic meningitis, subdural effusion. Subdural effusion will be the most common CNS complication of Haemophilus. Epiglottitis. Haemophilus influenza is the most common cause of epiglottitis. Pneumonia. Okay, so these are the common invasive conditions. Non-invasive conditions are usually by the non-typable strain. Example, otitis media. Otitis media is the most common non-invasive complication. Exacerbation of COPD. Okay, sinusitis. Like that, various non-invasive complications can take place. Fine. Lab diagnosis, I have already told, the culture media will be, tell me, you can use a chocolate agar. If you are using blood agar, then you have to use Staph aureus strychnine, or the special medium like Levinthal agar and field agar. These are the special media for Haemophilus influenza. Specimen CSF and blood can be taken, and please remember CSF should not be refrigerated, because Haemophilus influenza will die. You should not refrigerate the CSF specimen, otherwise Haemophilus influenza will die. Fine. So, these are the various culture medium for Haemophilus influenza, and if you do a gram stain, you will get pleomorphic gram negative baseline. Haemophilus influenza is having pleomorphism, that is various shape and size. Pleomorphic gram negative bacilli ranging from cocci, cocobacilli to bacilli to filamentous form, various forms are seen. Okay. Capsular antigen can be detected in CSF. by doing a latex agglutination test. Of course, culture I have already told, these are the various media which can be used. Then after it grows in culture, you can do the how to know that it is Haemophilus influenza or it is some other Haemophilus species. So for that purpose, what you can do is check for factor requirement. There are special discs are available, X and V factor discs are available. So you can use those discs and you check for factor requirement. This is very important because you have to know which Haemophilus species require which factor. Both X and V factor are required for, of course, Haemophilus influenza and Haemophilus aegypticus and Haemophilus hemolyticus. This is important, you have to remember. Only X factor will be needed for Haemophilus ducrei and Haemophilus aprophilus. V factor alone is needed for all para. All para is what and all Haemophilus species having para, that is para influenza, para hemolyticus and para aprophilus. So can you tell me now, based upon this, satellitism is shown by which one? MCQ for you. Satellitism is shown by which species? Satellitism is due to which factor? Is due to the release of V factor. So V factor, if it is required, then those organisms will produce satellitism. That means satellitism is shown by all Haemophilus species except where the V factor is not required. Yes, ducrei and aprophilus. They do not produce satellitism. Fine. So this is the laboratory diagnosis. Treatment: if it is invasive infection, cephalosporins are given. If it is non-typable, then they say that Haemophilus influenza non-typable strains are usually resistant to beta-lactam because of production of beta-lactamase or maybe alteration of penicillin binding protein. Hence the drug of choice here is cephalosporin, quinolones. Okay. Then chemoprophylaxis. Chemoprophylaxis, they say that rifampicin is given. Rifampicin is indicated. So these are the treatment profile for various Haemophilus infections. Okay. So now let us have a look on other Haemophilus species. Haemophilus aegypticus, which is also called as Koch weak bacillus. This causes a very important infection called as Brazilian purpuric fever and pink eye syndrome, also called as Egyptian ophthalmia. Egyptian ophthalmia. Fine. Then Haemophilus ducrei. Ducrei is the agent of chancroid.
chancroid or soft shore, and it is characterized by painful non-indurated soft ulcer as well as lymph node. Both ulcer and lymph node are painful and non-indurated. Okay, and regarding the diagnostic feature, they say that it shows bipolar stain. Of course, like Haemophilus influenza, it also can show pleomorphism, and the bipolar stained bacilli, they are arranged in end-to-end fashion. This is described as school of fish appearance or railroad track appearance. The bipolar stained bacilli are arranged in end-to-end fashion, which is described as school of fish appearance or railroad track appearance. It is antigenically homogeneous. So, the Haemophilus influenza has got 6 serotype, Ducrey has got only 1 serotype, it is antigenically homogeneous. As far as culture is concerned, here the MCQ you have to remember is rabbit blood agar is used, or even chocolate agar is used, added with 2 V, V for vancomycin and isovitalex. Rabbit blood agar or chocolate agar is used, added with 2 V, that is vancomycin and isovitalex. The drug of choice is azithromycin. And because it is a sexually transmitted disease, so to both the sexual partners. Okay. Then Hassek group, you have to remember the organism under Hassek group. Hassek group stands for what? What they are actually? They are the group of highly fastidious organism, gram negative bacilli. They are the normal flora of oral cavity. They are the normal oral cavity flora, but occasionally they can cause local mouth infection and dreaded serious infection called as bacterial endocarditis. They are associated with even bacterial endocarditis, such as bacterial endocarditis. So, you have to remember the list. The list is very important. HACEK. H for Haemophilus. But which species of Haemophilus they ask? Is it influenza? No. They are Aprophilus, Paraeprophilus and Parahemolyticus. I mean para-influenza, sorry. Aprophilus, Paraeprophilus and para-influenza. A for Aggregatobacter. Actinomycetomo mitans. At least you can remember as Aggregatobacter. It was called as, the older name also you can remember, it was called as Actinobacillus, which was renamed as Aggregatobacter. C for Cardiobacterium and E and K stands for Eikenella, Corodens
and Kingella kingi. Among these, one MCQ what they ask is this Echinella corrodens has a property of producing corroding colonies on blood agar. Producing corroding colonies on blood agar. Now let us discuss the important features of Bordetella and Brucella. Bordetella, again regarding the virulence factor is concerned, pertussis toxin is the most important virulence factor, and you know that it increases cyclic AMP. The role of pertussis toxin is increases cyclic AMP. Other than that, various other toxins it can produce like tracheal cytotoxin, adenyl cyclase, of course bacterial endotoxin also is there, it is a gram negative organism. Various adhesin molecules, they help in adhesion to the respiratory epithelium like filamentous heme-agglutinin. All these are important for vaccine. Filamentous heme-agglutinin, pertactin, which is the outer membrane protein antigen, and fimbriae. Various fimbriae are there. So these are the various molecules, various factors that are responsible for adhesion. So in this context, I want to tell you that this pertussis toxin is only produced by Bordetella pertussis, not by Parapertussis. Okay, it is produced only by Bordetella pertussis. So let us discuss the clinical manifestation. Pertussis, the clinically it passes through three important stages: catarrhal stage, paroxysmal stage, and convalescent stage. Catarrhal stage is highly infectious. It is the infectious stage by which the patient can transmit the infection. It is also the stage where both smear and culture will be positive. It is a diagnostic stage also. However, the symptoms are non-specific. Non-specific symptoms will be there. In contrast, paroxysmal stage is characterized by presence of specific symptom such as whooping cough and projectile vomiting. Whooping cough and projectile vomiting. In contrast, the infectivity is less. They say that in this stage it is less infectious, and also the smear and culture may become negative. Convalescent stage is characterized by increased antibody titer. Antibodies will be raised. So this is how you can differentiate between various stages. And don't forget, whooping cough is like a symptom is not specific to Bordetella pertussis. If you talk about the differential diagnosis of whooping cough like symptom may also be present in various other organisms. You have to keep the differential diagnosis in your mind when you are diagnosing the pertussis. The other differential diagnosis like mycoplasma, Chlamydia pneumoniae, various viral infections like adenovirus, influenza, and non-infectious conditions like use of AC inhibitors. Okay, so all these are the various other conditions where whooping cough like symptoms may be produced. Okay, so with this now let us discuss certain important aspects of epidemiology. Please remember there is no carriers here. The only source of infection will be early cases, that is which stage? Convalescent stage, catarrhal stage. The catarrhal stage will be those patients are the only source of infection. Age will be less than 5 years, is the most common age group to be affected. And do not forget, the recent outbreak has happened in Washington in 2012, and there is no cross protection with parapertussis. So, even if you take the vaccine, there is no cross protection with Bordetella parapertussis. Silent feature of lab diagnosis. I will tell you 5-6 important MCQs related to lab diagnosis. The most gold standard specimen, the best specimen will be nasopharyngeal aspirate. Okay, if you do here, gram negative cocobacilli arranged in thumbprint appearance, and culture is supposed to be the gold standard method of diagnosis. And the various, it is also a fastidious organism, as I told, it is highly fastidious. So, Bordet Gengu agar or Regan low medium, these are the two medium, and this medium it produces characteristic mercury drop colony, also called as bisected pearl appearance colony. And please remember, this culture and smear will be positive only in catarrhal stage, not in other stage. You can also detect antigen by doing direct immunofluorescence test. Okay. PCR also can be done, it is the most sensitive assay, but gold standard is always the culture. And antibody detection is, the antibodies will be appearing only in the convalescent stage. Okay. About swabs, how to collect the specimen? Of course, nasopharyngeal aspirate is the most important specimen. You can also do a nasopharyngeal swab, and ordinary cotton swab you should not use. You have to use the specialized swab like alginate swab. This is the best swab, followed by Dacron swab also can be used. And do not use the ordinary cotton swab. Charcoal based medium also can be used. Charcoal based swabs like Swartz medium, Amis medium, all these what we have discussed for gonococcus. If nothing is available, then these swabs also can be used. Okay, so this is all about the various laboratory diagnostic tool. Regarding treatment is concerned, macrolides are the drug of choice. Okay, and chemoprophylaxis, erythromycin. Yes, the vaccine for Bordetella is again very important. As you know, DPT, P stands for pertussis, but which pertussis? Killed pertussis vaccine. This is the most important, this is the traditional vaccine what is used. Other than that, now we have DAPT. So, AP stands for acellular pertussis vaccine. So, first we will discuss about killed pertussis vaccine. Killed pertussis vaccine, of course, it is given along with DPT. So, we have discussed how it is given. 5 doses are given at 6, 10, 14, then booster 1 at 1.5 year, booster 2 at 5 years. So, this is how it is given, but this killed pertussis vaccine is associated with side effect. The most important side effect is neurological side effect as well as hypotonic hyporesponsive syndrome. As a result, this killed pertussis vaccine is contraindicated in more than 5 to 6 year age, and it is also contraindicated in progressive neurological disorder. We have discussed these points under diphtheria chapter also. Here exception is cerebral palsy and febrile seizure. These are not contraindications. Cerebral palsy is non-progressive static condition, febrile seizure is a transient condition. So, these are not contraindications. Of course, hypersensitivity reaction to previous dose is another contraindication. So, because the side effects are there, that is why acellular pertussis vaccine is given. They claim that acellular pertussis vaccine is devoid of neurological complications. So, it is safe even after 5 to 6 years. They sometimes ask the composition. It contains, of course, pertussis toxin. The pertussis toxin, toxoid is the main composition. Other than that, it may contain other elements like filamentous heme agglutinin antigen, pertactin and fimbrial antigens. Okay. So, this is the principal component, these are the additional component. Okay. So, this is all about Bordetella. So, the next topic is Brucella. So, as I told you, HBB, all three are fastidious, highly fastidious. Haemophilus and Bordetella are strictly human. In contrast, Brucella is a zoonotic pathogen. Brucella is a zoonotic pathogen. There is this classification scheme which is used to classify the various Brucella species, which is called as nomen species classification, and there are various nomen species are there. Brucella melitensis. The species are classified based upon the animal they infect. Brucella melitensis infect sheep, goat and camel. Other than that, you have Brucella abortus, Brucella canis, suis. So, these are the important species. Abortus infect cattle, canis dogs, suis can infect pigs. So, which animal is susceptible to which Brucella species is again MCQ for you. Okay. Coming to pathogenesis. So, with this introduction, let us discuss how the pathogenesis occurs. Transmission. Brucella transmission, again the most common mode of transmission is direct contact with the infected animal. Direct contact with the infected animal tissue is the most common mode, followed by ingestion of milk product, inhalation. All these are in bracket. You write down there is no man to man transmission. Direct man to man transmission not possible. Of course, once it is transmitted, they say that the various target organs are there. Usually it is an intracellular organism affecting the reticuloendothelial system. Okay, so reticuloendothelial organs are the primary organs which are targeted. Incubation period may be range from week to months. It as low as 1 week to as long as few months. So, coming to the various clinical manifestation, they say that the classical triad of acute brucellosis consists of fever with night sweat, arthralgia and hepatosplenomegaly. Fever is having a, they say that the brucellosis, the acute brucellosis, it is a typhoid like illness. But how it varies from typhoid fever is, there are some differences. The differences are the fever is having undulating pattern. They say that the fever is called as undulant fever because it has a fluctuating pattern of fever, and of course it is less severe and less acute than typhoid fever, and you will have more musculoskeletal involvement. And of course, I hope you all know the undulant fever, the acute brucellosis which is called as undulant fever. Also it is otherwise known as Malta fever because of the place, name of the place, Malta fever or Mediterranean fever. Malta fever or Mediterranean fever. These are the other name given to undulant fever. Okay, so this is all about brucella, clinical manifestation. Laboratory diagnosis wise, again it is a typhoid like manifestation. Typhoid like laboratory diagnosis also is done, like for example in the first week you have to do a blood culture and bone marrow culture. And of course, you have to remember that here erythritol is added as a growth factor. Added as a growth factor. Okay, so blood culture and bone marrow culture is done. Of course, automated systems also can be used like Bactec for blood culture. So this is usually done in first week of infection. Whereas in second week of infection, in typhoid fever, what you do? Viral test. Here in the second week of infection, the antibody detection test is done, which is described as standard agglutination test. Standard agglutination test. So let us discuss a bit about standard agglutination test. This is a test where we detect antibody against Brucella abortus antigen. Antibody against Brucella abortus antigen. Okay. So, usually it detects IgM antibodies against the LPS antigen. Usually we use LPS antigen of Brucella abortus, against which it detects IgM antibodies. Fine. So, this standard agglutination test is useful for acute brucellosis, not for chronic brucellosis, because the antibodies are IgM type, hence it is useful only for acute brucellosis. But at the same time you may have various false negative and false positive conditions. False negative standard agglutination tests may occur due to Poisson phenomena, or it may occur due to presence of blocking antibodies. They say that this sometimes the IgG antibodies may be present, which may act as blocking antibody, and will have a false negative standard agglutination test. False positive standard agglutination test may occur in cross reacting related infections such as gram negative infections like E. coli, cholera, etc. Toluemia, all these infections you may have false positive standard agglutination tests. So, for chronic brucellosis, ELISA or complement fixation tests are a recommended test, not standard agglutination tests. ELISA is the recommended method for chronic brucellosis. Other methods, like of course you can go for a PCR, detecting specific gene like outer membrane protein 2 gene, and of course Brucellin skin test is available. Phage typing. Phage typing is done by using a specific phage called as lysiphage typing. Lysiphages are used. This is again a MCQ what they frequently ask. Okay. And in animals, brucellosis is diagnosed by various tests such as Rose-Bengal card test. These names they usually ask: Rose-Bengal card test, milk ring test, and whey agglutination test. So, these are the three important tests done to detect brucellosis, diagnose brucellosis in animals. Coming to the most important MCQ related to brucellosis, what are the treatment regimens we follow? There are two treatment regimen: gold standard regimen and WHO regimen. So, gold standard regimen, you can give streptomycin plus doxy. WHO regimen, the streptomycin is replaced by rifampicin. Doxy has been maintained, and do not forget the relapse may occur in 5 to 10% cases, and if CNS involvement is there, then ceftriaxone is added. If CNS is affected, then ceftriaxone is added, and the regimen is prolonged for 5 to 6 months, increase duration. Okay. So, this is about brucellosis. Discuss the next chapter, that is spirochetes. Okay. The word spirochete is described as spiro means spirally coiled. kit is they are extremely thin organism, and the various organisms under this family are Treponema, and Borrelia, Leptospira. Leptospira causes leptospirosis, which is called as Weil's disease. Borrelia, there are 3 important species: Borrelia recurrentis, Borrelia burgdorferi, and Borrelia vincenti. Recurrentis causes relapsing fever, burgdorferi causes Lyme's disease, vincenti causes Vincent angina. Coming to Treponema, Treponema pallidum is the only sexually transmitted species. Other species, they are transmitted by direct contact. So, T. pallidum is sexually transmitted, which causes syphilis. Other than that, there are 3 important other pathogens like Treponema pertwini, transmitted by direct contact, it causes Yas. Treponema endemicum causes endemic syphilis or Beagel, and Treponema caratium causes Pinta. So, these 3 are transmitted by direct contact, whereas syphilis mostly transmitted by sexual contact. And regarding the Borrelia species, relapsing fever is transmitted by louse, burgdorferi Lyme's disease transmitted by tick, and Vincent angina again by contact. Weil's disease again transmitted by contact to rodent urine. Okay, so that is how the mode of transmission of various organisms under spirochete you can remember. Okay, and please remember they are motile. All the members under spirochete are motile, but they have endoflagella. That is, the flagella is inside. They have endoflagella. So let us discuss the most important pathogen, the most important disease, that is syphilis. So, regarding the clinical stages, syphilis, you can know that has an incubation period of 9 to 90 days, highly variable incubation period. Clinically, it is distinguished as primary syphilis, secondary, latent, and neurosyphilis, late syphilis. Primary syphilis is characterized by painless, hard, indurated ulcer and lymph node. Both lymph node and ulcers are painless, hard, and indurated. Ulcer is extragenital if it is transmitted by direct contact. If transmitted by blood transfusion, then there is no primary syphilis. Directly the patient is presented with secondary syphilis. Okay. Then secondary syphilis is characterized by Three important manifestation: lymph node, skin, mucosa and mucocutaneous. Skin, of course, rashes will be there, mucosal patches will be there, and at the mucocutaneous junction you will develop condyloma lata. So, these are the triad of manifestation in secondary syphilis. Other than that, lymphadenopathy also will be there. Okay. After that, there will be a latent phase, then there will be late syphilis. Late syphilis is characterized by CNS, CVS and cutaneous manifestation. Cutaneous lesions are called as gumata. CVS, you will have aortic regurgitation and aneurysm. CNS manifestations are described as tabes dorsalis, and GPI, that is general paralysis of insect, general paralysis of insect, GPI. Fine. So, these are the manifestations. Coming to laboratory diagnosis, syphilis, they say that direct microscopy under which dark ground microscopy is usually done. It has a detection limit of 10,000 bacilli per ml, and direct fluorescent microscopy is also available. This approaches to 100%, nearly 100% sensitivity. Direct fluorescent microscopy, it is better than dark ground microscopy, and it is extremely thin. So, gram stain if you do, then it is not visible. So, how it is visible by ordinary microscopies? You have to use silver impregnation to increase the thickness. So, the silver impregnation stains such as Livarditis stain and Fontana stain, these are used to increase the thickness. And please remember, if you are using ordinary microscope, silver impregnation stains are must, otherwise gram stain, it is so thin that it is not visible. So, other than microscopy, the next diagnostic tool is culture, and please remember, it is again one organism like Mycobacterium lepra that is not cultivable. Do not follow the Koch postulate, and the only way to diagnose is via the animal inoculation, and here rabbit testis is used. But please remember, this particular rule is applicable for pathogenic Treponema species. The pathogenic Treponema species are not cultivable. However, the non-pathogenic species such as Rhetus Treponema, these can be cultivable in various medium like Smith-Noguchi medium. Smith-Noguchi medium. Fine. So, this is about culture. Then next is antibody detection. In antibody detection, you can classify as non-specific tests or non-treponemal tests or also called as standard test for syphilis, and the other group of tests are called as specific tests or treponemal tests. Non-treponemal tests, the examples are older tests like which are outdated tests like complement fixation test. Example is Wassermann test. Kahn test. Kahn test is an example of tube flocculation test. Newer methods like VDRL, RPR and TRUST. TRUST is toluidine rate, unheated serum test. Why this classification is a non-specific test and specific test? Under which criteria this division is there? They say that the non-specific tests, all these tests, why they are called as non-specific? Because they are non-treponemal. That is, they use non-treponemal antigen, that is cardiolipin antigen. Cardiolipin antigen is used. Cardiolipin antigen is used, and this cardiolipin antigen is derived from bovine heart. Bovine heart derived antigen is used. In contrast, the specific test they use specific T pallidum antigen. They use specific T pallidum antigen. So let us discuss the most important among all, that is the VDRL test. VDRL test stands for venereal disease research laboratory test. This is the test which was named after the lab. The VDRL lab is located in New York, based upon which the disease was named. And as I told you, it is a tube, it is a slide flocculation test, which is a type of precipitation reaction. It usually detects IgG antibodies, and how the test is done is, the procedure is, first you have to prepare the VDRL antigen. They say that the VDRL antigen has to be prepared by reconstituting the antigen with buffer. They say that the VDRL antigen is available along with a buffer solution. So you have to break the antigen vial, you have to break the buffer vial, then you have to reconstitute the antigen with buffer. Once it is reconstituted, it has to be used within 24 hours. It has to be used within 24 hours. Then the second step is patient serum preparation. Patient serum preparation is done by heating at 56 degree centigrade into 30 minutes. They say that if you do that, the non-specific inhibitor which are present in serum, they will be destroyed. If you heat for 56 degrees centigrade for 30 minutes, then the non-specific inhibitors which are present in the serum, they will be destroyed. So once the antigen is ready and the patient serum is ready, next step is you have to take the VDRL slide. VDRL slide is a concavity slide. Concave slide. It has got various 6 to 12 number of concavities are there. So what you have to do is, in each concave you have to add a drop of antigen, you have to add a drop of patient serum, and you have to rotate for 4 minutes. Following which you will have clumps. These clumps should be visualized under microscope. After the rotation is over, low power field actually. After the rotation is over, you have to keep the slide under the low power field of microscope, and what you have to see is clumps will be produced. The antigen antibody reaction occurs in the form of clumps. Now I will tell you how VDRL is different from RPR. RPR is macroscopic. RPR is what? Rapid plasma reagent test. It is a macroscopic test, whereas VDRL has to be visual. The slide has to be visualized by low power field. RPR is macroscopic. The reason is, they say that in RPR the cardiolipin antigen is added with carbon particle. That is why the size is bigger. That is why the clumps are of bigger size. VDRL, the antigen should be used within 24 hours. RPR, they say that the antigen can be stored for longer. It is the most stable antigen. It can be stored longer. Why? Because EDTA is used as a stabilizer. Preheating is must. Preheating of serum is must in VDRL. Whereas RPR, they say that there is no need of preheating. Why? Because here again one substance called as choline chloride is added to remove the non-specific inhibitor. That is why preheating is not required here. Rotation for 4 minute VDRL, 8 minute RPR. The biggest advantage of VDRL is VDRL can detect even the CSF antibody. Of course serum antibody, apart from that CSF antibody, whereas RPR only serum antibody. The CSF antibody cannot be detected by RPR. Okay. And of course one more advantage of VDRL is it is very cheaper. They say that if you break the vial and you reconstitute with the buffer, the reconstituted antigen can be tested for more than 250 number of samples, and the cost of each vial is only 13 rupees. So that 13 rupees can be used to test for 250 number of samples. Very cheaper VDRL compared to that. RPR is, because RPR you are doing for individual tests and it is expensive. So VDRL is used for field visit or even antenatal screening, where you have lot of sample. VDRL is preferred. Okay, so the differences between VDRL and RPR. Okay, so now I will tell you the specific test. Specific tests or triponomal tests. Once again, VDRL, I have to tell certain other aspects. VDRL, the major drawback is you may have biological false positive VDRL. Biological false positive VDRL is, it may happen in various non-specific conditions, like for example malaria, HIV, IV drug abusers, even pregnancy, infectious mononucleosis, hepatitis, filariasis. So like that there are various conditions where VDRL may be biologically false positive. So that is one of the drawback of VDRL as well as RPR. Both, this is the drawback. But the advantage is VDRL and RPR, the advantage is they become negative following treatment. That is why they are the best tool for monitoring the response to treatment, especially VDRL. They say that VDRL is the best method to, followed by RPR, is the best method to monitor the response to treatment. Okay, so they have advantages, they have disadvantages. So compared to that, the specific method or the trypanosome test, as I told, these tests they use specific T pallidum antigen. The various examples are TPI, that is T pallidum immobilization test, TPHA, T pallidum heme agglutination test, TPPA, again T pallidum particle agglutination test, FTA-ABS. Here it is fluorescent trypanosome antibody absorption test. So these are the various trypanosome or specific antibody detection methods which are available. So in this context, I will tell you the MCQs what they ask about the sensitivity and specificity of various serological tests in syphilis. Point to be remembered. So please remember, of course, in primary syphilis, the most sensitive will be Western blot. I didn't tell you there are among the specific method, the other tests like Western blot and enzyme immunoassays are recently devised. You can just add these two to the specific method, Western blot and enzyme immunoassay. So the most sensitive assay in primary syphilis is Western blot and enzyme immunoassay, followed by TPPA, followed by RPR, followed by FTA-ABS. So this is the sequence. This is a very important table you have to remember. So this is the sequence you have to remember. For primary syphilis, the most sensitive assay is Western blot, followed by TPPA, then RPR, then FTA-ABS. So this is the sequence you need to remember. Secondary syphilis, all tests are equally sensitive, and that to 100%. They say that all tests are 100% positive in secondary syphilis. So secondary syphilis, there is no problem in diagnosing, and remember, secondary syphilis is the most infectious stage also. Transmission is maximum in secondary syphilis. Then for late syphilis, before that latent syphilis, the most sensitive. Again, almost all trypanosome tests are equally sensitive, just like secondary syphilis. Late syphilis, the most sensitive test is FTA-ABS, followed by TPHA, heme agglutination test. Then overall most specific is TPHA, enzyme immunoassay, and then again TRUST, toluidine red unheated serum test. All these tests are 99% specific, though trust is a non-specific test, but the specificity is good, they say. It is one of the recently devised non-specific test. Okay, so this is the sequence what you need to remember. Many students, they keep on asking which is the most sensitive test. This particular table has been taken from Tropley-Wilson, which is the standard book to answer these questions. Okay, so let us now discuss how to diagnose congenital syphilis. Congenital syphilis is generally diagnosed by IgM FTA ABS. There is a variant of FTA ABS called as IgM FTA ABS. Other than that, you can go for a PCR or dark ground microscope. Okay, so dark ground microscope to demonstrate the spirochete in the umbilical cord, placenta, or even the nasal discharge of the newborn baby. They say that this is the most definitive diagnosis. Other than that, you can go for a PCR, IgM, FTA, ABS. But what about VDRL? If you do VDRL, what is the problem? VDRL detects which antibody, IgM or IgG? VDRL mostly detect IgG antibodies. So IgG antibodies means you cannot differentiate between maternal transfer and true fetal antibody, because IgG antibody can cross the placenta. So they say that there are some criteria. If you are using a VDRL, they say that if fetal, if baby's titer is more than mother's titer, then you can consider that it is a true infection, true congenital infection. One more criteria is rise of titer of baby at 3 months compared to birth titer. This is also, you can consider that it is a true infection, but all these are suggestive, you cannot use for confirmation. They say that all these are used for suggestive diagnosis. Confirmation is done by dark ground microscope, PCR, or even IgM, FTA, ABS. Okay, so this is about diagnosis of congenital syphilis. Now let us discuss treatment. Treatment, they say that penicillin is the drug of choice in all stages. Alternate for primary and secondary syphilis, tetracycline is given, whereas for neurosyphilis or pregnancy or HIV individual, they say that the alternate, if you have penicillin allergy, then the alternate is nothing but desensitization, followed by desensitization to penicillin, followed by give again penicillin. So this is the MCQ what they repeatedly ask. Drug of choice, of course, is penicillin. Alternate in case of penicillin allergy, for primary and secondary syphilis it is tetracycline. For neurosyphilis, pregnancy and HIV individual, desensitization, followed by again prescribe penicillin. So let us now discuss Borrelia. Borrelia, as I told, there are 3 important diseases: relapsing fever, then Lyme's disease and Vincent's angina. Let us discuss one by one. Relapsing fever is of 2 types: epidemic relapsing fever and endemic relapsing fever. Epidemic relapsing fever is due to Borrelia recurrentis, and which is exclusively human pathogen. It is transmitted by louse, and the epidemics usually takes place in East Africa, especially Sudan. In contrast, endemic glassing fever is due to other species, like for example Borrelia dutoni and hermisi, but not Borrelia recurrentis. It is zoonotic. Rodents are the reservoir. It is transmitted by tick, and the endemicity is confined to North America and sometimes Central Asia. The drug of choice also vary. They say that doxycycline single dose is given for epidemic, whereas the same doxycycline is given for 1 week for endemic. Epidemic it is given single dose doxycycline, endemic it is given for 1 week. Okay, so this is all about relapsing fever. Then Lyme's disease. Lyme's disease is caused by Borrelia burgdorferi. Burgdorferi. They say that it is transmitted by tick. It is a tick-borne pathogen transmitted by tick. Again, rodents are the reservoir. Okay. Clinically, there are 3 stages. Clinically, Lyme disease is characterized by 3 important stages. Stage 1 is the local infection, local skin lesion, which is called as erythema migrans. This is an annular lesion, annular skin lesion. Second stage is disseminated stage, where other organs will be involved. Third stage is persistent stage. Okay, so like that there are 3 stages of Lyme's disease. Coming to the laboratory diagnosis, they say that Kelly's medium is the recommended culture medium. Unlike Treponema, which are non-cultivable, Borrelia can be cultivable in various mediums like Kelly's medium. Antigen detection in urine, one more important diagnostic tool, and they say that if you look for joint fluid examination, then there will be increased polymorphonuclear cells like neutrophil, whereas CSF examination reveals increased lymphocyte. This was recently asked in AIMS 2011. Okay, so CSF examination reveals increased lymphocyte, whereas joint fluid examination reveals increased polymorphonuclear cells. Antibody detection also is done by ELISA, Western blot. Both the methods are available. So these are the various diagnostic tools for Lyme disease. Drug of choice for all cases except CNS or AV block. The drug of choice for all cases is oral doxycycline, whereas if you have a CNS or AV block, then ceftriaxone is given. Okay, so this is all about Lyme's disease. Okay, Vincent angina is nothing but, what are the 2 agents of Vincent angina? Yesterday we have discussed leptotrachea, or which is this is the new name, the old name is Fusobacterium fujiformis. This is obligate anaerobe, and Borrelia vincenti. And Vincent angina is nothing but it is an ulcerative gingivostomatitis. And the risk factor will be malnutrition and other viral infection. Unhygienic oral condition can be a important risk factor. Fine. So this is all about Borrelia, Leptospira. Leptospira has got two species. Biflexa is the non-pathogen, whereas interrogens is the pathogenic species. And interrogens can be further be classified to various. They say that around 23 to 26 serogroups are there, and each serogroup can be further be classified to various serotypes. Okay, around 25 serogroups are there, which can be further be classified to around 250 serotypes, or they are also called as serovars. Each of the serovar has got its own geographical distribution. So the serovars, they vary in their geographical distribution. They also vary in their severity of infection. So that is why you have to identify which serovar has been. Okay. Coming to epidemiology, 3R you should not forget. 3R stands for the epidemiological triad of leptospirosis: rice field, rainfall, and most important is rodent. And the mode of transmission is concerned. The most common mode of transmission is indirect contact with either water or wet surface contaminated with animal urine. This is the most common mode of transmission. Other than that, direct contact with urine or placenta, etc. of infected animal, infected rodent. So indirect contact is the most common mode of transmission. So that is why rodent control is the most important for prevention of leptospirosis. Okay. As far as India is concerned, Leptospira is endemic in most of the states, especially Tamil Nadu, Kerala, and as well as Andamans. If you don't forget, leptospirosis is also called as Andaman's hemorrhagic fever. Andaman, it is highly endemic. And the regional research center, they say that the regional medical research center for leptospirosis, this is also located in Port Blair. So Andaman, lot of cases as well as lot of research leptospirosis. Fine. So regarding the clinical manifestation, 5 to 14 days will be the incubation period, and disease is classified into two stages. They say that first you will have a mild or anicteric stage. Later on, icteric stage or severe, which is described as Weil stages, or hepatorenal hemorrhagic syndrome. The mild or the anicteric stage will have non-specific symptoms like fever, myalgia, etc. Okay, later on conjunctivitis may be there. Okay, and after some time you may have an immune stage which is characterized by meningitis, uveitis, etc. Okay, so initially you will have fever, myalgia, conjunctivitis. Later on you may develop an immune stage which is characterized by a meningitis, uveitis, etc. So these are the feature of anicteric stage of leptospirosis, and this occurs in 90% of individuals, whereas 10% of individuals they progress to icteric stage or severe veil stages, are also called as hepatorenal hemorrhagic syndrome. And this hepatorenal hemorrhagic syndrome is characterized by, they usually ask where and all hemorrhages are there. Please remember pulmonary hemorrhage and conjunctival hemorrhage, okay, GI hemorrhage. So these are the hemorrhages which are commonly seen. Okay, so this is all about clinical manifestation. Lab diagnosis, again CSF, blood are the specimen in early stage, whereas late stage the specimen of choice will be urine. And when you do a dark ground microscope, you can visualize the organism, and remember Leptospira has to identify under diagram microscope. They say that here the spirals are more in number and it has a hooked end. More number of spiral and it has an umbrella shaped hooked end. So this is a specific feature of leptospirosis, leptospira under dark ground microscope. Other than that, culture can be done. Culture again EMJH media. EMJH media is again the most ideal culture medium. Apart from that, Korthoff and Fletcher medium. But please remember, though the culture techniques are available, but it is highly fastidious and extremely difficult to grow in culture, and there is always a risk of contamination. So that is why culture is not followed routinely. It is followed only in reference centers. Extreme risk of contamination of the culture bottles. Okay, so if somebody will ask you which is the most convenient tool in leptospirosis, please remember antibody detection methods are routinely done, and if somebody asks you the gold standard method of diagnosis, answer is microscopic agglutination test. Microscopic agglutination test is the most accepted gold standard method for leptospirosis. They say that it is highly specific and it can detect the specific spirovars also. It is spirovar specific. Spirovar specific. Other than that, there are various other antibody detection methods like ELISA, okay, microcapsule agglutination test, etc. So many antibody detection methods are available. Microcapsular antigen detection test. So like that, there are various capsule, microcapsule agglutination tests. Various other methods are also available. Okay, molecular tests, PCR can be done. And there is a criteria to diagnose leptospirosis called as Fain's criteria. This is a specific criteria to diagnose leptospirosis. It is a WHO approved criteria which has taken various factors into consideration, like clinical feature, epidemiological feature, as well as laboratory diagnosis feature. All three together they have taken into consideration. Fain's criteria. Drug of choice, again mild leptospirosis can be treated with doxycycline. Severe, of course, penicillin is the drug of choice. This is about spirochetes. The chapter deals with rickettsia, chlamydia and mycoplasma. So let us now focus on rickettsia. Both rickettsia and chlamydia, both these two group of organisms, they have two common features. They cannot grow on artificial media. As well as both of them are obligate intracellular pathogen. Both the rickettsia and chlamydia are pathogen. Rickettsia has a third property. They say that these are the three triad of principles of any organism to be included in under CC. The third property is they are arthropod borne, transmitted by arthropod vector. And there are various organisms under this family: genus Rickettsia, Oriensia, Coxiella, Bartonella. Among these, now Coxiella and Bartonella are though we discussed this chapter, but they are now excluded. The various organisms under rickettsia. Typhus group. So typhus group, there is epidemic typhus and endemic typhus. Epidemic typhus is caused by Rickettsia provozaki. Endemic typhus is, the agent is Rickettsia typhi. Vector wise, epidemic typhus is transmitted by louse. The code is LET, L for louse, ET for epidemic typhus. Endemic typhus is transmitted by flea, mainly by rat flea or cat flea. Here the code is FEN, F for flea, EN for endemic typhus. Spotted fever group, you have three important members: diseases, Rocky Mountain spotted fever, Indian tick typhus, African tick typhus, and rickettsial pox. Four important diseases are there. The first three are transmitted by tick, whereas rickettsial pox is transmitted by mite, gamma-seed mite. Coming to the agent, Rocky Mountain spotted fever, the agent is Rickettsia rickettsii. Indian tick typhus, Rickettsia conuri. African tick typhus, Rickettsia africae. Rickettsial pox, the agent is Rickettsia acari. Okay. Coming to scrub typhus, here the agent is Oriensia, Oriensia shushugamushi.
and the vector is again mite, but it is trombiculate mite. Trombiculate mite. So this is again a very important table, which is important, which has to be remembered for exam. It's a again a must know table for your exam. Coming to the general clinical manifestation, they say that the most severe form is Rocky Mountain spotted fever, whereas the mildest form may be the rickettsial pox. Rashes, again the distribution of rash is again important for exam. Rashes all over the body except palm and sole. This is seen in epidemic typhus, whereas rashes over the trunk followed by extremity, this is seen by endemic typhus. In Rocky Mountain spotted fever, rashes will be there only on palm and sole, whereas there are certain diseases where you will have vesicular rashes. For example, rickettsial pox, chicken pox like vesicular rashes will be there, as well as African tick typhus, vesicular rashes will be there. There is no rash in Q fever. So based on rash you can differentiate various rickettsia members. Then the next feature is eschar. The black color eschar will be there in scrub typhus, rickettsial pox, then African tick typhus. All these diseases black color eschars will be seen. Okay. CNS involvement will be there in epidemic and endemic typhus. That is why it is they are called as typhus. Typhus means what? Mental confusion. Okay. Then recrudescence illness. Recrudescence illness is a feature of a variety of epidemic typhus which is called as Brill-Zinsser disease. Brill-Zinsser disease, this is a recrudescence illness of epidemic typhus. It is a latent epidemic typhus which is characterized by a recrudescence illness. Similarly, if they ask you Q fever is of course two stages, acute and chronic. Acute fever is acute Q fever is characterized by of course fever. Other than that, as I told you earlier, Q fever is transmitted by inhalational mode. No vector, no arthropod vector, transmitted by inhalational mode. So pulmonary manifestation will be there. Apart from that, hepatitis. So these are the three important features of acute Q fever: fever, pulmonary manifestation and hepatitis. Whereas chronic Q fever is characterized by endocarditis. So these are the characteristic feature of various rickettsial diseases. Fine. Then coming to the laboratory diagnosis, rickettsial diseases are diagnosed mainly by antibody detection. Among antibody detection, non-specific antibody detection by Weil-Felix reaction is the most famous and the most commonly done test. In this test we use protease antigen. Protease antigen OX19, OX2 and OXK. These are the three protease antigens we use. And in the patient serum we are trying to detect the respective antibodies in
patient serum. So, this table is very important because well Felix test is used in rickettsial disease to differentiate among various rickettsial diseases, like for example in epidemic and endemic typhus. Epidemic and endemic typhus, antibody against OX19 will be raised. In tick-borne typhus like Rocky Mountain spotted fever, African tick typhus, then Indian tick typhus, all these three are transmitted by tick. All these three antibody against OX19 and OXK will be raised. Whereas in scrub typhus, antibody against OX19 will be raised. So, OX19 and OX2 antibodies are raised in tick-borne typhus, tick-borne rickettsial disease. Only OX19 will be raised in epidemic and endemic typhus, whereas scrub typhus OXK antibody will be raised. But please remember, Weil Felix test is a non-specific test. Non-specific antibodies are detected. You may have false negative in case of prozone phenomena, that is excess antibodies. If excess antibodies are there, then false negative Weil Felix test can be possible. False positive Weil Felix test may be possible if you have unrelated protease infection, because you are using for protease antigens. So, unrelated protease infection, false positive Weil Felix test may be possible. So, always the confirmation is done, and they say that indirect immunofluorescence test is done to detect antibodies. This is done for confirmation. If the Weil Felix is positive, you can go for indirect immunofluorescence test to confirm the diagnosis. Other than that, there are certain other mode of diagnosis like Neal-Musser reaction. Neal-Musser reaction is animal inoculation test. Here the male guinea pigs are selected and they are injected intraperitoneally. Intraperitoneal inoculation into the male guinea pig can lead to three pattern of manifestations. In Rocky Mountain spotted fever, the guinea pig undergoes total scrotal necrosis, whereas in epidemic typhus only fever. In endemic typhus, fever plus testicular inflammation, the tunica layers of the testis will be inflamed and they will thicken, they will be adherent to each other. This property is described as positive tunica reaction, whereas in epidemic typhus it is described as negative tunica reaction. And this positive tunica reaction is seen by three species. The code is CAT. CAT stands for Rickettsia conuri, acari and typhi. All these three, that is endemic typhus, conuri is Indian tick typhus, acari is rickettsial pox. All these three you will have a positive tunica reactions. Other than that, there are various cell lines can be used for isolation of rickettsia. Egg inoculation, especially yolk sac of egg, is used for isolation of rickettsia. Drug of choice for most of the rickettsial diseases, drug of choice is doxycycline. Drug of choice is doxycycline. Coming to Bartonella. Why it is excluded from Rickettsiaceae family? Because it can grow in artificial medium. There are three important members: Bartonella quintana, Bartonella hensale and Bartonella bacilliformis. Quintana transmitted by louse. Trench fever is also called as 5 days fever. It is transmitted by louse. It is a louse-borne disease. Ensale is the most common among the three. It is responsible for a very important disease called as cat scratch disease, transmitted by exposure to cats, and it is characterized by a cervical lymphadenopathy. Lymph node will be enlarged, and a very important stain what is used to demonstrate the organism called as Warthin-Sterry silver nitrate stain. Silver nitrate stain is used to demonstrate the organism. Bartonella henselae. And please remember, apart from cat scratch disease, Bartonella henselae is also responsible for other manifestation, like it can cause bacillary angiomatosis. Bacillary angiomatosis. It is a neovascular disorder, and here Bartonella henselae is the most common cause. Other than that, even Quintana also can cause. However, Bartonella henselae is the most common cause of bacillary angiomatosis. Coming to bacilliformis, Bartonella bacilliformis can cause two manifestations. The local manifestation is called as verruga peruana. Verruga peruana is a local cutaneous manifestation. The systemic manifestation is described as Oreya fever. Oreya fever are also called as Carrion's disease. And please remember, bacilliformis is the transmitted, the vector is sandfly of the genus Lutzomia. Lutzomia is the vector for Bartonella bacilliformis. Okay, so this is all about various rickettsial diseases. Now let us discuss chlamydia. Chlamydia, as I told you earlier, like rickettsia, there are two features are same. They cannot grow on artificial medium, and the second point is chlamydia is again a obligate intracellular. One more point is it is called as energy parasite. The reason is it cannot produce its own ATP, it is dependent on the host cell ATP, hence it is called as energy parasite. It has got three important members, three important species: Trachomatis, then Shiitake and Pneumoni. They differ from each other in various ways. Let us discuss one by one. Chlamydia trachomatis, how they differ from each other is the inclusion body of chlamydia or trachomatis is diffuse, the inclusion bodies are described as compact inclusion body mixed with glycogen matrix. And of course, they are exclusively human pathogen. In contrast, Chlamydia shiitake and Chlamydia pneumoniae, both the inclusion body is diffuse vacuolated. Why diffuse vacuolated? Because they do not contain glycogen matrix. That is why they are diffuse vacuolated inclusion body. And among the
to chlamydia pneumoniae is of course exclusively human pathogen, whereas shiitake can also, it is the reservoir will be the birds. Okay, so coming to the coming to the manifestation of all the three. Serogroups. First, I will tell you about chlamydia trachomatis. Chlamydia trachomatis, there are various serogroups. Serogroup A, B, C can cause endemic trachoma. There are total 15 serogroups have been reported. A, B, C can cause endemic trachoma. D to K is sexually transmitted. They can cause non-gonococcal urethritis. And of course, please remember D to K is the most common agent of sexually transmitted disease as well as non-gonococcal urethritis. The most common sexually transmitted disease as well as the most common cause of non-gonococcal urethritis. Apart from that, D to K can cause other manifestation like infant pneumonia. They can also cause certain ocular manifestation like ophthalmia neonatal. In adult, they can cause swimming pool conjunctivitis. What is the agent of swimming pool granuloma? Swimming pool granuloma, yesterday we have discussed, the agent is chlamydia, Mycobacterium marinum, whereas swimming pool conjunctivitis, it is chlamydia as well as adenovirus, both can cause swimming pool conjunctivitis. And D to K can cause certain complications. Complications like Fitz-Hugh-Curtis syndrome, characterized by perihepatitis, which is also seen in gonococcal infection. Other than the Ritter syndrome, characterized by cup plus mucosal lesion. Cup stands for conjunctivitis, urethritis and polyarthritis plus mucosal lesion, described as Ritter's syndrome. Okay. So, this is one of the important complications of chlamydia trachomatis. And then the L1, L2, L3 serogroup can cause lymphogranuloma venerum. Lymphogranuloma venerum. Lymphogranuloma venerum is again characterized by painless ulcer but painful buboes, that is lymph node. Okay. Other important MCQs regarding LGB, they can ask. Fry test can be done. Fry test is usually done. It is a hypersensitivity type 4 reaction, Fry test for diagnosis, and one of the complication is ichthyomon. Ichthyomon is nothing but elephantiasis of vulva. Okay, so these are the specific MCQs related to LGB. Then chlamydia shiitake, transmitted by inhalational mode. Birds are the main source of the infection, and usually it produces a community acquired interstitial or atypical pneumonia.
Chlamydia pneumoniae is exclusively human pathogen, and it is responsible for again atypical interstitial pneumonia. In addition, it can cause, they say that it is associated with the pathogenesis of atherosclerosis. Chlamydia pneumoniae, there is a definite relationship with the pathogenesis of atherosclerosis. Apart from that, bronchial asthma, sarcoidosis, all these are other diseases which is related to Chlamydia pneumoniae pathogenesis. Fine. So, this is all about Chlamydia pneumoniae. Then we can discuss about laboratory diagnosis. Laboratory diagnosis, they say that we can go for a direct microscopy to detect inclusion bodies. There are various inclusion body, like for example HP body. HP body stands for Hillstadter Provozek body. This is seen in trachoma. Miyagawa corpuscles, this is seen in LGB. LCL body, Levinthal Colli Lilly body. So, all these are various inclusion bodies named in chlamydia. This is seen in psittacosis. Okay, and don't forget that if you use Lugol's iodine, then it can stain the glycogen matrix of Chlamydia trachomatis inclusion, because only Chlamydia trachomatis is consisting of glycogen, that inclusion body is composed of glycogen matrix. So, glycogen impregnated inclusions can be detected by Lugol's iodine. Other than the various histopathological stains can be used to diagnose the, to detect the inclusions of chlamydia. Second is antibody detection. There are two antibody detection methods are available. Complement fixation tests detect genus specific antibody by using LPS antigen, whereas microimmunofluorescence test available which is serovar specific, and it uses outer membrane protein antigen. Outer membrane protein antigen. Okay. Then culture, mice inoculation, egg yolk inoculation, and among the cell line, they say that McCoy cell line. McCoy cell line is specific for Chlamydia trachomatis, whereas Hep2 cell line, HeLa and McCoy cell lines are used for Chlamydia trachomatis, whereas Hep2 cell line is used for Chlamydia pneumoniae. Okay, Chlamydia pneumoniae. Let us now discuss about treatment. One thing, if they ask you the most sensitive and specific test, nucleic acid amplification test. Nucleic acid amplification test, that is nothing but PCR, is considered to be the most sensitive and specific test for chlamydia diagnosis, and this at present this is considered as the best tool for diagnosis of chlamydia. It is almost replacing the culture now.
Okay, so coming to the treatment for chlamydia trachomatis, azithromycin is the drug of choice. Sitaki, tetracycline, pneumonia also, tetracycline. Okay, so this is how the treatment of chlamydia varies. Coming to a synopsis of mycoplasma. The main difference between chlamydia rickettsia versus mycoplasma is chlamydia and rickettsia are obligate intracellular, whereas mycoplasma is free living. In fact, they say that it is the smallest free living organism. Chlamydia rickettsia, they cannot grow in artificial medium, whereas mycoplasma can grow in artificial medium. Chlamydia rickettsia will have a true cell wall, whereas mycoplasma, the interesting feature is they lack the typical cell wall. They say that the peptidoglycan layer is replaced by sterols, and as a result they are resistant to cell wall acting antibiotics. They are resistant to cell wall acting antibiotics. Okay, and of course, as far as the clinical manifestation is concerned, mycoplasma is the agent of primary atypical pneumonia. Primary atypical pneumonia. Coming to the drug of, laboratory diagnosis, they show gliding motility. Of course, they produce typical fried egg colony. The various culture medias are PPLO broth and PPLO agar. In this context, I want to tell you the various older name of mycoplasma. Mycoplasma is known to have various older name like Eaton's agent and PPLO. PPLO is pleuropneumonia like organism. Pleuropneumonia like organism. Okay, so fried egg colony, and the culture medium of choice is PPLO agar. Apart from that, apart from culture, you can go for antibody detection. Antibody detection, they say that you can detect various antibodies. First, non-specific antibodies can be detected. Non-specific antibodies are detected by test called as cold agglutination test and Streptococcus MG test. Why these are non-specific antibody detection tests? Because they detect antibody against non-specific antigen. Non-specific antigen like cold agglutination test uses human RBC antigen, human ORBC antigen. Streptococcus MG test uses Streptococcus MG as an antigen. That is why they are non-specific tests. Whereas you can have specific antibody detection tests like ELISA or even complement fixation tests. Of course, EFT is outdated now, so ELISA is one of the specific antibody detection tests for mycoplasma. Okay. Drug of choice, azithromycin.
except Mycoplasma hominis, it is one more species. The most common species is Mycoplasma anemone. Microplasma hominis, the drug of choice is doxycycline. Okay. So, this finishes the 3.11 chapter. Miscellaneous bacteria. So, let us discuss important organisms under this. Broadly, gram negative and gram positive miscellaneous organisms we will discuss. Among gram positive, Listeria and Actinomycetes. Then we will discuss the various gram negative organisms. So, let us start Listeria. Listeria monocytogenes. Listeria monocytogenes is known to produce neonatal meningitis. Okay. And regarding the diagnostic tool, of course, they say that it shows tumbling motility, and its motility is present at 25 degrees centigrade, but it is non-motile at 37 degrees centigrade. This property is described as differential motility. It is motile at 25, non-motile at 37, which is described as differential motility. Other than that, the growth is improved on refrigeration, which is called as cold enrichment phenomena. Cold enrichment phenomena means the improvement of growth on refrigeration. Okay. Among the various media, the selective medium of Listeria is Palcum agar. Palcum agar is the selective medium for Listeria, and you have to remember that the mode of transmission, as it is refrigeration is important. I mean, it can resist refrigeration, it can grow in presence of refrigeration. So, ingestion of refrigerated food is the most important mode of transmission of Listeria. Okay. Then the drug of choice, clinically, as I told, it can produce neonatal meningitis, and adults are usually asymptomatic. Okay. Very rarely it can cause meningitis in adult. Usually they are asymptomatic. They say that very old age group, more than 60 years, then it can cause various infections. Otherwise, it usually do not infect the adolescents. Treatment of choice, they say that the drug of choice is ampicillin. Please remember, it is resistant to cephalosporins, so they are not effective. So, listeriosis, of course, do not forget, is gram positive bacilli, which is inherently resistant to cephalosporins. And one more thing to be, I have forgotten to tell you, the lab diagnosis, CAMP test also is done. CAMP test also is done for Listeria. It is done for group B Streptococcus, it is also done for Listeria. Reverse CAMP test is done for Clostridium perfringens, reverse CAMP test. Actinomycetes. which include two important member, actinomyces and nocardia. The general feature is the members under actinomycetes, they are gram positive, branching and filamentous bacilli. They are gram positive, branching and filamentous bacilli. Okay. The difference between actinomyces and nocardia, both are gram positive branching bacilli, but the difference is actinomyces is anaerobe. Nocardia is a obligate aerobe and it is partially acid fast. It is partially acid fast. Actinomyces is anaerobe and it is non-acid fast. Actinomyces, they are the mouth commensal. They are generally the mouth commensal, and because they are mouth commensal, sometimes they can cause endogenous infection. And among various form, they say that cervicofacial actinomycosis is the most common form. Okay. Sulfur granules are usually present in the lesions of actinomyces, sulfur granules, and if you do a culture, they say that the colony appearance will be spidery molar teeth appearance. Spidery molar teeth appearance. In contrast, as I told, actinomyces, they are mouth commensals. In contrast, nocardia, the usual habitat is soil. So the infection is generally exogenous infection. Exogenous infection either by direct contact, that can cause mycetoma, or via the respiratory mode, that can cause pulmonary manifestation and various other complications like brain abscess. And actinomyces, they say that they usually infect immunocompetent individuals, whereas nocardia is specifically, it is prevalent in HIV infected and other immunocompromised individuals. Nocardia, of course, the diagnostic tool, as I told, it is partially acid fast. Apart from that, there is a technique called as paraffin bait technique. This is used for isolation of nocardia from soil as well as from clinical specimen. Paraffin bait technique is specifically used for isolation of nocardia. Drug of choice, penicillin is a drug of choice for actinomyces, whereas nocardia, the drug of choice is sulfonamide. So this is about miscellaneous gram positive bacteria. Let us discuss now miscellaneous gram negative bacteria. Let us discuss Campylobacter and Helicobacter. Campylobacter jejuni is again microaerophilic. Of course, it is zoonotic, it is microaerophilic. Microaerophilic means what? They require 5% of oxygen. They survive, the maximum, the optimum oxygen requirement is 5 to 10% of oxygen. Both the Campylobacter and Helicobacter are microaerophilic.
Okay, so the mode of transmission, they say that ingestion of poultry product most common. Ingestion of poultry product, usually raw or undercooked, is the most common mode of transmission. And regarding the pathogenesis, they say that they produce a powerful enterotoxin as well as cytotoxin. And clinical manifestation wise, they produce gastroenteritis, intestinal infection. Other than that, extraintestinal infection, this is mainly due to Campylobacter fetus, and this is mainly in immunocompromised individuals. In person with HLA-B27, it can cause reactive arthritis. Okay, and again a hypothesis is there that the Campylobacter can also trigger the pathogenesis of Guillain-Barré syndrome. Okay, this is mainly by Campylobacter jejuni, serotype O19. It is hypothesized that they can trigger the pathogenesis of Guillain-Barré syndrome. Okay, so this is all about. Then coming to the lab diagnosis, they are curved gram-negative bacillus, Gulving set. As I told, they are microaerophilic. They can grow at 42 degree centigrade. So this is again an identifying feature of Campylobacter jejuni. It can survive 42 degree centigrade. Darting motility, again an important feature. About the various culture medium, they say that Skyros medium, then Buzzler medium, and one more is Campi BAP medium. These are the three important culture medium for Campylobacter. Drug of choice, macrolide are given. This is for intestinal, whereas extraintestinal infection, they say that gentamicin is given. Okay, so this is all about Campylobacteriosis. Helicobacter. Helicobacter pylori. This is also microaerophilic, like that of Campylobacter. And regarding the virulence factor, they say that it produces urease enzyme. Maximum urease activity is by Helicobacter pylori. Okay, strongly urease positive. Apart from that, adhesins. Okay, toxins, like they produce vacuolating cytotoxin, and one more toxin called as cytotoxin associated gene. So like that, they produce two important
toxins. Okay. Regarding the manifestation, Helicobacter pylori, please remember, as far as the prevalence is concerned, 80% in developing a country, 30% in developed country, and 50% overall people, normal healthy people, they harbor H. pylori in their stomach. However, they are also associated with various clinical manifestations, though they are found in stomach acidic environment, but at the same time in certain individuals they can cause various manifestations like peptic ulcer disease. Most common manifestation is peptic ulcer disease. They say that 60% of gastric and 80% of duodenal ulcers are due to H. pylori. Okay, so antrum is the most common site. Whereas the cardiac end of stomach is never involved. Cardiac end of the stomach is not involved. Second will be, they say that it can promote pernicious anemia. Autoimmune gastritis, and of course they are also associated with adenocarcinoma of stomach. Various non-Hodgkin's lymphoma. So all these are the various conditions where H. pylori is involved. Chronic atrophic gastritis. Okay. So next is laboratory diagnosis. H. pylori can be diagnosed mainly by two important diagnostic tools, invasive and non-invasive method. Invasive is you have to do a endoscopic guided biopsy. And from the biopsy material, either you do a histopathological diagnosis or culture or biopsy urease test. Non-invasive method, the most important is urea breath test. And according to Harrison, they say that urea breath test is the most accurate, most consistent, most sensitive and the best tool for the diagnosis of H. pylori infection. And one of the advantages of urea breath test is becomes negative after treatment. So it can be used for prognosis also. It can be used for prognosis also. Other than urea breath test, the other non-invasive methods like antigen detection, antibody detection, you can do a PCR, all these are other non-invasive method, but urea breath test is the most consistent test for H. pylori. Treatment, they say that the first line treatment is OCM regimen, that is omeprazole, clarithromycin, and metro. Okay, so this is how the OCM regimen is given, and of course urea breed test is done for follow up. Fine. Then Legionella, one more miscellaneous organism, Legionella pneumophila. The most important MCQ is about its transmission. The transmission is recently it has been changed now. Initially we were thinking that the aerosol from contaminated AC is the most common mode. Now according to the latest edition of Harrison, they say that aspiration is the most common mode via the oropharyngeal colonization. Aspiration can occur either via oropharyngeal colonization of the organism or directly while drinking of contaminated water. Either oropharyngeal colonized organism can be aspirated or by directly by drinking the contaminated water. This is the most common mode, followed by other mode like aerosol from contaminated AC, air conditioner. And please remember, there is no man to man transmission. There is no man to man transmission, there is no animal reservoir, as well as there is no carrier. There is no carrier. And the disease can be classified as milder disease, which is called as Pontiac fever. It is a mild flu-like illness, or severe disease called as Legionnaire's disease. Legionnaire disease is nothing but it is characterized by atypical interstitial pneumonia. Okay. Sometimes even extrapulmonary manifestations also may be present, and most common site is heart. Most common extrapulmonary site is heart. In pathogenesis, one particular MCQ what they ask is coiling phagocytosis. Coiling phagocytosis is one of the important feature of Legionella pneumophila. Okay. Lab diagnosis, again it is poorly gram negative, weakly gram negative bacillus. So sometimes it may happen that when you do a sputum microscopy, you will have the organisms may be absent, only the pus cells will be present. So this also may happen because it is poorly gram negative. That is why they say that the best method of diagnosis is by culture, and BCYE medium is the most widely accepted culture medium for Legionella. Buffer, charcoal, yeast extract medium, BCYE medium, most accepted culture medium for Legionella. Other than that, urinary antigen detection. And also PCR is available mainly from water samples. PCR is done. Fine. The drug of choice again is macrolide. Macrolide like azithromycin are the drug of choice. Fine. So this is all about Legionella. Then a brief note on donovanosis. Donovanosis, what is the causative agent? Now it is called as Klebsiella granulomatosis. Klebsiella matis. Older name is Calaimotobacter. Calaimotobacter granulomatis. And donovanosis is characterized by painless ulcer and there is no lymph node involvement. Instead of that, the subcutaneous swelling may be there, which is described as pseudobubos. There is no true lymph node involvement. Subcutaneous swelling may be present, which is described as pseudobubos. If you do a microscopy, they say that Donovan body will be present. Donovan body is characterized by macrophage. This is a macrophage containing bipolar stain organism. They say that this is a bipolar stain bacilli will be there. Bipolar stained bacilli inside the big macrophage, which is called as Donovan body. Okay. And of course, drug of choice is azithromycin. What is the other name of the disease? Donovanosis, or also called as granuloma inguinal. The other name of donovanosis is granuloma inguinal. Fine. So this is about. Then last organism what we will discuss is Gardnerella vaginalis. Gardnerella vaginalis is the causative agent of bacterial vaginosis. Bacterial vaginosis is, one is Gardnerella vaginalis, other agent is Mobilincus. Yesterday we have discussed. Mobilincus also can be implicated in bacterial vaginosis. It is characterized by by four important findings. Together it is clubbed as Amsell's criteria. According to Amsell's criteria, you will have a profuse thin vaginal discharge, pH of more than 4.5. Why more than 4.5? Because the normal vaginal flora, which is composed of lactobacilli, they will be decreased. The number of lactobacilli will be greatly decreased. That leads to increase of pH. The discharge has a very offensive smell. Offensive smell, which can be increased by addition of KOH, which is called as whip test. The smell is enhanced when you add a potassium hydroxide, which is called as whip test. And the fourth criteria is the presence of clue cells. Clue cells are nothing but vaginal epithelial cells studded with numerous organisms. Vaginal epithelial cells studded with numerous cocobacilli. So, clue cell is the pathognomic feature of bacterial vaginosis, and they say that there is a scoring system called as Nugent scoring scale. This is used for calculating the load of organism in the vaginal smear. Okay. Drug of choice is again metronidazole. Okay, so the last part what we will discuss is rat bite fever. Rat bite fever, the two important agents are Streptobacillary moniliformis and the other one is Spirillum minus. Okay, so these are the two agents of rat bite fever. So that finishes the bacteriology. Then after that we will start virology.